yes, I am able to touch it, but doctor sitting here will say no, there is a gap. Therefore, minimum 2 or even more, always try to confirm in that. So for example, if I am touching my nose, whether I am touching like this here, up, down, all the images will show that I am there. So therefore, do not be in a rush, confirm it 2 or multiple images. Third, now these are the golden words of my teacher, Dr. Dureja sir. He said, putting in a needle is not the final thing, getting a good dye spread is the key. So wherever there is the dye, there is going to be drug. So getting beautiful needle positions is not fun. Getting a good, perfect dye position is what we are looking for. With that background, let us start about the images. Now, there are 3 basic images. What we are trying to say is, one is AP, one is lateral, another is oblique. Now, the serum position or the table position will not decide the AP. Right? So this is a common argument that I have with my technician who said, sir, 0 to aa raha hai. Because 0 nahi aa raha hai. It doesn't cater, because again there is obesity, positioning, skeletal deformities, and a lot of other things. So what we take is, how do we get an AP is, we take a structure bang in the middle of the spine, which is the spinous process. And then we take structures which are on the lateral surfaces and equidistant, which are the facets or the pedicle. So the spine has to be equidistant to the pedicle on both the sides. That is one. Second thing is, see, when we always imagine that fluoroscopy is like our eyes, right? And you need to align the fluoroscope in the direction where you want to put it. So for example, if you have a spine, your lumbar foraminals are in the lateral direction, something like this. So what you will need to do is, you will need to put your C-arm in this position so that you are right in the center. Versus if you want to do a trigeminal, so you want it in a foraminal. So what is the direction of the foraminal? The patient is lying supine. For patient's foramen ovale is here. So patient's head is here, leg is there. So what we will be doing is, we will be putting the C-arm position like this. So it has to be aligned. So one is AP, another is oblique. What is technically oblique is basically any position which is not the standard AP, lateral or axial or coronal cuts is referred to as oblique. Third thing Dr. Tandon beautifully talked about is the parallax. Don't try to remove the parallax of the entire spine. Concentrate on the level where you are doing an intervention. Because what I have seen people struggling, they try to square the entire thing. That's not possible. Take your time, square it, find a sweet spot, and only concentrate on the level that you are trying to achieve. Okay, now counting we have counted. So what is the best way of counting? Top to bottom, bottom to top? Bottom to top. Hand, can I have bottom to top? Very good. The ideal way is top to bottom. The reason being, there is more of transitional vertebrae present as an anatomical anomaly as we know, right? Therefore, try to go initially, always try to go from top to bottom. That is one. Second thing, how I have bridged it is, how I do it is, rather when I'm looking at the MRI, rather than putting the numbers, I see whether the last disc is the problem or the penultimate disc is the problem. So I just take that equation out of it. Oblique, again, there is nothing as a perfect oblique. 15 to 25 is the literature, but try to get an oblique where your transverse process goes within the body and your facets are at 6 o'clock position. Squaring we have discussed. So this is a lumbar spine and this is a famous Scotty dog. Not a big fan, but yeah, there you get the images. Now this is an oblique image where you can see the entire Scotty dog. So this is the pedicle. Below the pedicle is the position of your foramen. So any transforaminal, whichever route you want to go. So below the pedicle is the site for foraminal injection. Pedicle above and medial is the site for facet joint injection. and this is the site for median branch, and you need to keep the active tip in this particular direction for the median nerve RFA. So these are the various images which we talk about. Again, this is an AP or an oblique image? Oblique. You see the Scotty dog. Now here you see my target, I can only target this point because this is the part which has been squared. So pedicle, below the pedicle foramen, pedicle above and medially, this slit is the facet. So these are multiple images. The same principle is applied when we are going for a lateral image, and as I told you, we need to be very sure of our needle both in AP lateral images before we find out. The spine, I think Dr. Dureja sir will be talking about it, so I won't. But here what we are looking for is trying to get that perfect lateral image. Here the challenge is get to perfect lateral image. Again, how do we make sure it is that like this articular pillars are like a single line. So this is a perfect lateral image, and probably during our live demonstration we will be demonstrating how do we get it. Die, always use a die, use a cardiac die, do not use a urological die. Whenever in doubt, you might be performing across the world, whenever in doubt, though it's a very standard company, but still always ask for a cardiac die. So now just to end, this is an oblique image. This is the Scotty dog. This is the superior articular process. The eye of the Scotty dog, which is the site for the median nerve. This again the lower Scotty dog median nerve. Superior articular process. This is the facet joint. This is the site for your transforaminals. So even if you cannot see the Scotty dog, most prominent structure below the pedicle is your foramen. This is the site for your discal procedures. Dog, facet. Thank you. Any questions?
Any question? Anybody? Sir, two blocks are there. One is the medium branch and the other one is the right foramen.
Yeah, sir.
Only two points we have to concentrate is the eye of the pedicle. Above the eye is for medial branch, and below the neck is for the transforaminal.
Okay, sir. I'll break it down to the basic. So you just need to concentrate on the pedicle.
Okay.
Below the pedicle is the foramina. Below the pedicle is the foramina. Above the pedicle medially. Above the pedicle medially is the facet. Right, sir? And the eye of the dog is the site for the medial branch. Right, sir? But if you have to do an RF, so basically what happens is, this is the articular process and the transverse process. So a gutter kind of a thing is formed. So what happens is, you have to place the active tip of a radio frequency needle like this, in the direction. Right? So just a practical tip, so rather than going like this, when we are doing an RF, we go from below and place it in this gutter. Right? If we are doing a diagnostic, then we go on a head-on or a needle view.
Okay, I think we should talk
Yeah. No, sir, I am done with question.
Another question. I think
We can discuss this during the workshop. I think it will be live.
Thank you, sir.
Thank you.
Thank you, sir. With this, we conclude the first session. After the end of the session, I request the chairpersons to kindly facilitate the speakers. First of all, Professor Kale sir has just joined us. So Professor Kale sir can also join us for felicitating the speakers. May I request the chairpersons to kindly felicitate Professor Dureja sir. Next slide रखो. Binna madam, please. the chairpersons to kindly felicitate Dr. Ashish Tandon. May I request the chairpersons to kindly felicitate Dr. Dhruv Bibra. May I request the Professor Kale sir and Professor Deepak Agrawal sir to kindly felicitate the chairpersons. Professor Mahapatra sir. Professor Mahapatra sir is our chief guest and our.
It is taking gift from your own house.
Sir, please.
Hello, Ashish.
May I request Professor Kale sir and Professor Deepak sir to kindly felicitate Bindra madam. May I request Professor Kale sir and Dr. Deepak sir to kindly felicitate Dr. Ramesh Dodamani. Thank you, Kale sir and Dr. Deepak sir. With this, we conclude our first session. Now we will move on to inauguration session. I hand over the podium to Dr. Dattaraj to conduct the proceedings of inauguration session. Dr. Dattaraj, please. Sir. So kindly be seated, like we are inaugurating a program. Yeah. So with great pleasure, I invite all of you to this pain conference under aegis of Indian Society of Peripheral Nerve Surgery. And this was actually like a crash course connecting dots between completely conservative management with the medicines and then the more invasive surgical management. So less invasive like blocks and ablative procedures. And we are privileged to have our chief guest Dr. A.K. Mahapatra sir who are guiding this department over the last 35 years, and I request him to please join the chair, sir, on the dais. Manoj, please accompany the sir to dais. Manoj, accompany sir to dais, please. Now I request Manoj to please accompany Dr. S.S. Kale sir to dais. बाहर सब बोलना इनॉग्रेशन के लिए अंदर आ जाओ. अरे तुम तो नहीं अभी सुनो. Then I request President of Dr. Kale to join the chair. Then Director of Meeting Dr. Deepak Agrawal sir, I request him to please join the dais. Then I request Dr. Rajesh Sharma, who is the organizing secretary, energetic man, to join the dais, please. I request Kathy to please welcome Dr. A.K. Mahapatra sir with the flower bouquet. I request Kathy to please welcome our the head of department and president of this meeting, Dr. S.S. Kale sir, with the floral bouquet. I request Kathy to please welcome director of meeting, Dr. Deepak Agrawal sir, with the floral bouquet. And welcome Dr. Raju Sharma sir, who is the organizing secretary of this meeting, with the floral bouquet. So as we know, light is the symbol for brightness, which throw way into the darkness, and the goddess Saraswati is the goddess of knowledge. So let's invoke God Saraswati by lighting a lamp of knowledge and wisdom, and inaugurate this program, so that we go step higher over the proceeding of next 1 or 2 days. So I request our dignitaries, Dr. A.K. Mahapatra sir, Dr. Kale sir, Dr. Deepak Agrawal sir, and Raju Sharma to come and start the lamp lighting. I request Dr. Gureja sir and Dr. Ashish Tandon to join for the lamp lighting ceremony, please. Thank you very much, sir. Over the period we were thinking about, like, we have conducted various workshops earlier on operative procedures, then various times, and a lot of demo on cadaver and lot of stuff like on sovereign modules as well. So we thought, like, let's do something which can connect the gap between things, and we can do a less invasive procedures, and we can provide a complete solutions. So it was a brainchild of Dr. Deepak Agrawal, who was thinking all the way over the line of this module, and then he brought up with this concept. So I request him to please come on the stage and give his welcome address.
Good morning and welcome to all the delegates. I especially thank Professor Mahapatra, who has been our head of department for such a long time, has been director of various institutes, and for actually coming and blessing us and taking time out for this workshop. I also thank Professor Kale, who is our current head of department and who has always been proactive and helping us in conducting these workshops and guiding us. And obviously Dr. Rajiv and Dr. Datta, who are the actual forces, the co-organizers, who have been doing this. We have been planning this workshop for a long time because I feel that neurosurgeons have been neglecting a lot of patients with pain, especially back pain, cervical pain. Most of our OPDs are with patients with these kind of pathologies. More than 50% I would say, whom we just send for physiotherapy and pregabalin, gabapentin, all these things. So with this background, we thought that why don't we start doing the procedures which a lot of people in the private like Dr. Ashish Tandon, Dr. Dureja and everybody has been doing, and help our patients instead of just making them move around. So with this philosophy in mind, this workshop finally culminated in today in having this program. I hope it enlightens us all and it's a purely academic feast for 2 days, and I hope we can soak in as much as possible. Thank you so much.
So thank you very much, sir, and I'm hopeful that definitely we'll be reaching one step higher and we'll be knowledgeable by the end of this workshop. I request now our President of the meeting, Dr. S.S. Kale, sir, to please come and give a word of wisdom. Professor Mahapatra, Dr. Deepak Agarwal, Dr. Rajiv Sharma, Dr. Datta Raj, all my faculty colleagues here, and our invited guests, faculty who are going to demonstrate pain procedures, all the doctors who have come from all over the country. What can I say, I'm surprised, pleasantly surprised to see the level of enthusiasm of this meeting. Frankly speaking, I had not thought that we'll be able to fill this boardroom, but it's overflowing. So it is a felt need, as they say, it is a need, and I suppose it is a need of the hour. We get caught in these big cases who get referred to these big hospitals, that we forget the daily patients who come, routine patients who come with pain, who don't have any neurological deficit or who don't have a lesion which merits surgery, but they still have pain, and you have to address it. In these big hospitals, we just say, okay, you don't need surgery, go to some other department. But I guess it is a need of a whole lot of patients which is not addressed by us neurosurgeons, and this workshop will probably fill a definite gap which exists in the armamentarium of neurosurgeons to address the problems faced by our patients. So I welcome you all once again, very good, and keep it up. Thank you very much. Thank you very much, sir. Definitely, like you have rightly said, that there is
plus 10 medical colleges. So it's a very quick development of healthcare in India. And if you look at independence, there is nothing, practical nothing. In 1900 there are 7 medical colleges. In about 1947, about less than 25 medical colleges. But it was thanks to Board committee Dr. Joseph Bohr, who gave a report to British government that to develop the healthcare in India, they create the British government Royal Health Society, gave a committee, that Bohr committee should be there to improve the healthcare in India. You should know this. If you do not know in a profession you belong, it's like nowhere. So Bohr committee in 1943 took 3 years and gave a report 1946 what should be healthcare delivery system in India. That is the reason why all the medical school existing in 1946 were converted to medical college. 25 of them. So suddenly from 7 or 8 medical colleges, there are about 30 medical colleges in India. And we are part of that Bohr, Joseph Bohr. He is a Kerala gentleman. And he was made the committee chairman by British government. So the question is that today we owe a lot of things to Bohr committee, and this institute is by part of the Bohr committee report. Bohr committee gave a report to Rajkumari Amritkar, who is the founder, the health minister of India from 1947. And he used to be the president of this institute, and they say the Bohr committee recommend that there should be a medical university in the country. That is how this medical, we must know, because many people here are the product of AIIMS and they do not, because when I take interview for the professor, I ask what is the meaning of AIIMS, where did it start, what is the purpose? Purpose was quality medical education, international level patient care, and good quality research. How many of you know this medical institute is third in medical publication in the world after Harvard Medical School and Yale University? Do you know anybody? In 10 years time, Harvard Medical School published 47,000 paper, the Yale University published 23,000 paper, and this university produced about 10,000 paper. But do you know that Harvard Medical School has 4,000 faculty? And this was having a faculty of now 700, we have 800 posts, out of which about 200 posts are vacant because of reasons all of you know. So if you see the Harvard work in AIIMS score better. There is a write-off which came in, I think about a year back, comparing Harvard Medical School to AIIMS. They compare the number of patients to number of doctors, cost benefit, and the amount of money spent. The amount of money spent for Harvard Medical School in billions, how much? Billions, as compared to AIIMS, the money spent by the government is nothing. I think it is 4,000 crores for a budget, nothing, not even a half a billion. So the amount of patient you treat is 10 times more than Harvard Medical School, because we have large number of people come from. So imagine the contribution of this building, this hospital, institute to the country. And the aim was to produce teachers. If you look at past 10 years or 20 years, all the medical graduates went to US. We are very happy our doctors are going to America. But to make a doctor in India, it costs crores. Do you know that how much money government of India spend in crores? So if a person does MBBS or MD or MS and goes abroad, the America is getting fine products for nothing. And we do not understand how much we harm our country by going abroad. I remember 1st January 77, I was going PG here, and the America was making difficult for the visa. We are 15 a batch of postgraduates joined in 75, 76. And do you know in 6 months time, all of our batch who joined left, we are 5 left. I think Dr. Guruja might not have joined that time. So the question is that we all love to go and work abroad at the cost of our poor country. I think that's bad. I'm happy that you people are serve your country, so I salute you, because you are the true citizen of country. Lot of people come from America like Shekhar, Sen and all these my friends, they say, oh this is big, that is big. Now the Shekhar put, if you look at the doctors, I think WhatsApp, Shekhar give a lot of advice. Never work for this country. The people who sit in New York advise to Indians what to do. Is not very sad? What are the village life people have seen? Go and see village about 50 kilometers from here. Go to Balabgarh. Go from Balabgarh to Jhansa. The rural center of this institute, beautiful institute, is Balabgarh. Balabgarh has sub-center Jhansa. I was posted 3 months in Balabgarh in 78 and 1 month in Jhansa. And that will my best remembrance of this institute. Because the village, the simplicity of the people, the river, part of the Jamuna is flowing nearby, you will never forget. The question is that what you are going to carry from your career. Here is an institute where he is going to teach you pain management, and pain is a very important part of human being. Anybody can tell he has never suffered with pain? On any of you can tell you have not suffered headache, backache, toothache, stomachache? So can anybody say that he is not touched by the disease of pain? No. Yet they are all different. Management, abdominal pain is different, headache is different, chest pain, and we are talking about body ache, body pain. We are not about headache. We are not talking chronic headache. We are not talking about abdominal pain where you give injection. We are talking about musculoskeletal pain. So this pain management is basically talking about musculoskeletal pain. For a brain tumor pain you cannot give injection here. Cannot. Or a spinal cord tumor, no nerve block is going to help. So you have to understand what to use in what situation. That is the reason where I don't see, even today I don't see more than 5 patients a day. In 6 hours I examine 5 patients. History taking, understanding his problem, psychological aspect, familial aspect, problem, economic problem, doctor's marriage not done. You have to see what. That is why Dr. Abdul Kalam said physical pain, mental pain, social pain, psychological pain, doctor giving pain. What pain doctor give? Lakhs of rupees for pain management. So you have to see what type of pain he is having. Is it physical, mental, social, psychological, or doctor given? I tell everybody, do meditation for pain. Get up in the morning, sit under sunlight for 1 hour, take honey, haldi and warm water. Don't use AC, muscle spasm. I don't use AC. I stayed in Delhi for 45 years. I had no AC in my house. Enjoy summer is sweating, winter is shivering, and rainy is getting wet. If you change your nature, nature is going to ditch you. Get wet in rain, get sweat in summer, and get shivering in cold. The nature is like that. Thank you very much. Don't change nature.
So thank you very much, sir. I mean, like, I can take few tips from your the talk. I mean, like, definitely this is made in workshop or made in India workshop, because we have like all the experts and faculty from India. So that is one point. Second, I mean, like, let's remember Abdul Kalam and get his wings of fire to handle pain for next 2 days and subsequently in our career. Thank you very much, sir, for your address. Before handing over mic to Dr. Raju Sharma for vote of thanks, I will like to acknowledge Dr. Rath, who is our registrar, and I will request Dr. Rajesh to please welcome with the flower bouquet. हाँ, अब register. Yeah. Yes, thank you. He is one of the pillar of yeah. Yes, so we'll stop AC in his rooms. So fine, sir. So he is a pillar of our neuro anesthesia department, and now I'll request Dr. Raju Sharma to please give vote of thanks. Before I start giving the vote of thanks, I request Dr. Rajesh Meena to felicitate our faculty, Dr. Navdeep Sokal also. Dr. Navdeep Sokal will be presenting his talk in the afternoon session. Dr. Navdeep Sokal is our professor in neuro anesthesia and quite doing a lot of work in pain management, which and we will be eager to learn from him during the afternoon session. Thank you. With this, we are at the session of vote of thanks, and though this is a very difficult task, and I will try to do as much justice as possible with me. First and foremost, I would like to thank Professor A.K. Mahapatra sir, chief guest of this workshop, who spared his busy time out and came so far off to grace this occasion. Sir is currently working as Vice Chancellor of Shiksha Anusandhan deemed to be University in Bhubaneswar. sir is a founder member of this society, and not only a founder member, actually this society is a brainchild of Professor Mahapatra sir, and this was started way back in 2010. And when I took that charge of treasurer of ISPNS, and when I opened the file, the first page was application form signed by Professor Mahapatra sir, dated 19 December 2011. So this is actually a brainchild of this, and we are all here because of, we can assume that we are all here because of Professor Mahapatra sir, who planned and conceptualized this society. I am thankful to Professor Kale sir, chairman of this workshop and HOD Neurosurgery of AIIMS New Delhi. Sir had seen each and every aspect of this workshop on his own, and not only guiding us, each and every step he checked and ensured that everything is planned as per need. I am thankful to Professor Deepak Agarwal sir, co-director of this workshop, for planning this workshop. Actually, this workshop, sir was receiving lot of input since long time by the request of delegates, and the last straw was put when sir organized this ISPNS cadaver workshop in March 23 at our trauma center. A lot of delegates had requested to sir at that time, and I am sure many of them have registered for this workshop also. I am thankful to all those delegates who pushed us for organizing this workshop. I am thankful to Professor G.P. Dureja sir, who is currently working as director of Pain Management Center in Delhi. Actually, this pain management services at AIIMS was started by sir at AIIMS in 1986, and not only in AIIMS, it was sir is called as pain management pioneer of our country. This is what I heard from your department colleagues, sir. And sir took VRS from Institute in 2005 and handed over the legacy to Professor Virendra Mohan sir, Dr. Debesh Bhoi, who are continuing his work in the department now. Thank you sir for sparing your busy time and dedicating 2 full days for this workshop. Thank you very much sir. I am thankful to Dr. Ashish Tandon, who is the director of World Endoscopic Brain and Spine Center in Jabalpur, who came far off from his busy schedule. Sparing out 3 days for a private practitioner is very difficult. I appreciate his contribution for this academic program, and I am sure all of you will gain a lot of things from him during this workshop. I am thankful to Dr. Dhruv Bibra, who helped me in organizing minute things besides the scientific program. I am thankful to Dr. Mahendra Singh Chauhan, Dr. Anirbandhi Banerjee, Dr. K.V. Narsingh Rao, Dr. Siddharth Chawli, Professor Virendra Mohan sir, Professor Navdeep Sokal, Dr. Debesh Bhoi for their contributions to the program. I am thankful to Professor Girja Prasad sir for coming and guiding us, and even during the planning of workshop scientific program, he guided me a lot. I am thankful to Professor Arvind Chaturvedi sir. Actually, sir was planned to attend this conference, and I had planned for a treasury neurology session to be chaired by him, but because of some personal reasons, sir is not available today. I am thankful to sir for his guidance and support for organizing this workshop. I am thankful to Dr. Ashish Bindra, Professor Manjiri Tripathi madam, Professor Chandra sir. My department colleagues helped me a lot, especially my junior colleague Dr. Dattaraj, Dr. Ramesh Dodamani, Dr. Shweta Kedia, Dr. Sachin Borkar, Dr. Kokula, Dr. Rajesh Meena, Dr. Satish Verma, Raghav, Dr. Surya, Dr. Ravi. They helped me a lot in organizing this workshop. My department residents, they did a lot of hard work in arranging the patients, looking after them, doing their workup and planning the surgery. I'm thankful to all my residents for their hard work. Special thanks to our sponsors, Sun Pharma team, all the 5 divisions of Sun Pharma, Intas Pharma and Synthes for their contribution and support to this academic event. Various vendors, Prashant from Philips, Gaurav, Manish Sharma, audiovisual team led by Ravinder. Our OT nurses have also worked a lot for this workshop, and I am thankful to all of them, our OT nurses, our OT technicians, my office staff, Anugrah, Vinay, Shubham, Navneet, Khyati, Yogesh, Amit, all of them have worked hard for this workshop. I'm thankful to all of you who has taken time out of your busy schedule and come far off, leaving your busy private practice and spending time, and I'm sure you all will learn a lot from this academic program. Lastly, I would like to extend a heartfelt word of thanks to all those who have made today's event possible, whose name I may have missed, I could not have highlighted because of shortage of time. I am thankful to all of you for your valuable contributions. I now invite you all to the dining hall for a high tea. Thank you very much. With this, we conclude the inauguration session. We will join back for a case after this tea break for 20 minutes. It's 9:45 now. 10 o'clock exactly we will start case discussion live from OT. Thank you very much.
I said nothing of response.
Just to get a perspective of great diagnostic value to us.
मेरी बात सुनो। हेलो, बोलो बोलो, किससे बोल रहे हैं? हाँ ठीक है, एक मिनट यार, 4 5 ऑन कर दें।
For getting electrode has to be close of the certain temperature. They are going to be into fluoroscopy, few concepts about fluoroscopy which I always have gathered over the period of time. Slide, can I have the slides please? Three. Therefore, we need to confirm
हेलो हेलो हाँ मैं ये कह रहा हूँ कि अभी कौन सा वो चले, कौन सी ओटी चलेगी पहले तेरे? क्या बात कर रहा है? अच्छा ठीक है यार, ठीक है बाबा, यहाँ पे बहरी हो रही है यार, इधर से हाँ हाँ OT-1 में चलेगा?
Below the neck is for the transfer arm.
Okay, sir.
बोलना है OT-1 OT-2, ठीक है ना? कुछ करना ऑडियो जैसे जो भी नाम तो है ही तेरे पास, OT-1 डॉक्टर इस बार डालिए तो चल गई है ना?
हो गया सॉर्ट आउट?
हाँ हो गया, मेरे वो कह रहा है बंद
बड़ा सारा ग्रीन सा ग्रासलैंड है ना, उधर
Okay, we'll be starting the operative session soon. अनुज OT में अनुज है? अनुज, let us focus on the OT setup. अनुज को बोलो. हेलो अनुज, मैं बात करूँ सर से. वहीं से बोलेंगे सर. सर बोलिए. हेलो. हाँ अनुज, कैन यू हियर अस? अच्छा अनुज, तो वहाँ पे जो OT रेडी है वहाँ का वो केस स्टार्ट कराएं. नहीं, पेशेंट अंदर कहते हो, प्रेजेंटेशन स्टार्ट कराओ ना. OT-1 कौन है? डॉक्टर जो रेजिडेंट है और डॉक्टर राजेश है. हाँ मेरे साथ. सर मैं खटवा रहा हूँ. ये फ्लावर से बता दो. ठीक है सर. So few announcements. First is that we have shared the link for the Day-1 schedule. In the link you will have the OT cases also. Against each OT case there is a link where you can actually open that PowerPoint presentation of that case. So this is for your reference. So I would like you to go through it, and it will open in the portrait mode better if you can open that, because it's a long table. And I will now request Dr. Rajiv to start the case presentations. So in case you want to refer to the case at any time while it is being presented, you can always come back and see the case, and we will try and have that case number also displayed on the screen while that OT is going on, so that there is a connection and you can actually understand what is going on. So I request now Dr. Rajiv to moderate for the case presentations.
Thank you, sir. With this, we start our case presentation session. I request the chairpersons to kindly occupy the chairs. Professor Mahapatra sir, Professor Ashish Bindra madam, Dr. Shantanu Bora, and Dr. and Dr. Ravi Sharma. Ravi is available. Shantanu, please. OT-1, Dr. Dwyer sir will be operating, and OT-2, Dr. Ashish Tandon will be operating. OT-1, Ravindra, can we connect to OT-1? Anuj? Anybody from OT-1, please respond. Yeah, Bindra madam, can you please take over? Resident OT-1 Puranjay, yeah, you can start presentation. Ravindra, please please show the Dr. Puranjay's slide on main screen, please. You might Shantanu, maybe you can come and sit here. It might obstruct the.
Slides visible here?
Slides, we are not able to see your slides, Pranjay.
Just a second, sir.
Have you connected the HDMI cable to your laptop?
Yes, sir.
Yeah. No, please connect HDMI cable to your laptop. We will be able to see your laptop directly.
Sir, we have connected, but there is some issue with the projection with HDMI.
Okay. Then you can start with this. No problem. Dr. Bindra, Dr. Mahapatra sir, Dr. Shantanu, Dr. Ravi.
What I would request is you please open it in your own phones, all of you. This is case 1, OT-1. Right, Puranjay?
Yes, sir. Yes.
Case 1, OT-1. You can, if anybody's got an issue, because MRIs and everything, you'll need to zoom and everything on your own because that is important. So here on the screen, it will not be that nice. So please open on your devices so that you can zoom in. If anybody is a problem, we can help you with that. Okay, continue, Puranjay.
Okay, sir. Thank you, sir. Good morning, everybody. So I am starting with the case 1 presentation. So case 1 is, she is 39-year-old female. She has complaints of lower backache with radiation to left lower limb
Since past 2 years. Examination, she has left SLRT positive with EHL of 4/5. Otherwise, she doesn't have any other deficits. She has hyperreflexia in bilateral lower limbs mainly. And on imaging, we can see L4, L5, L5S1 PIVT is there. If you want a detailed imaging, we have hyperlinked all the cuts in this link.
Okay, can you focus a little more on imaging? We are not able to see very well. It's like light, probably.
There is shining of light on your screen. So just tilt your laptop in a But this is looking completely black.
Yes, it's little better. Can you increase the contrast a little more?
1 second.
Oh yes, this is fine. Perfect.
Okay.
Okay.
So we can see L4, L5, L5S1 disc here. And this is paracentral disc compressing bilateral root foraminus, and on L5S1 we have central disc, and she also got C4, C5, C5-6 PIVT. Our plan is to give transforaminal root block for lumbar PIVT.
May I request Professor Day sir to kindly opine about the case and its plan? Pranjay, you can hand over the mic to Professor Day sir.
Yes. Sir is yet to join us, sir. He will be joining us soon.
Can you tell us again what are the chief complaints by the patient?
Ma'am, she has lower backache with radiation to left lower limb.
Okay. And can you please summarize what pathology can you see in the scans?
Ma'am, on sagittal cuts we can see L4, L5 and L5S1 disc. With on axial we can see root on L4, L5 level bilateral foraminal compression is there, and on L5S1 cuts we can also see there is a central disc bulge is there compressing mainly, but the bilateral compression is there but more towards left side.
Okay.
What is the canal diameter?
What is the canal diameter? Actually, lot of radiology.
What is the size? Most of the radiology is not good. Foraminal size. Is that foraminal size? Hello?
Hello. Ravinder, are you able to hear from the hall?
Concentric. Then your block may temporarily relief. Of course, no block is permanent. So you have to see what is permanent cure for the pain, right?
Pranjay, are you able to hear us?
see this X-ray, you see the black is the spinal cord, and anteriorly there is CSF space. Posteriorly you see the ligamentum flavum hypertrophy, right? There is no CSF. So you should take a supine and prone film of the MRI, because if you make everybody supine and prone, then the CSF will go to one side by gravity. So what you see here, you see suddenly there is nothing, you see the spinous process stop and go down, and as soon as you go down, you see there is no CSF back, posterior to the theca. But 41 you are connected, sir. So we don't know whether lumbar canal stenosis, what is the ligament, what lot of people don't give you information in the MRI, what is the size of the foramen, what is the canal diameter, what is the thickening of ligamentum flavum. They will say PID, impression, and take it clinically correlate. Send them back. I send them back. Go and get a proper. Taking so much of money, radiologists don't give a proper report. I don't accept. You see that how many things are there? Are they redundant nerve root? Anybody know redundant nerve root? I wrote 2-3 papers in 70s, 80s. Because if the nerve roots are redundant, they are painful. Redundant nerve roots are thick, hypertrophied, there is a demyelination and pain. It's not.
Pranjay, can you show the axial images? Axial T2. Are you able to hear us? Yeah. L4-5 level, we can see both of the foramina are blocked. We are not able to see any CSF signal in that area. But at the L5-S1 on the left side there is some signal seen, but that is also significantly ablated on right side. So there are two level blocks. L5-S1 central disc bulge is more, whereas L4-5 bilateral paracentral disc bulge is slightly more. Pranjay, has joined?
And is here one thing, why go to the clinic? There is EHL weak.
Yes, sir.
So if the pain is only symptoms, you give pain management. Here the muscle weak. If you let the pain go, what is pain? In third year MBBS, it's a collar, dollar, result tumor. Pain is a protective phenomenon. As soon as you get brain relieved, a big disc prolapse will not have any pain. So you are by see, you have to understand where do you send this patient for pain relief. Where the patient has a EHL weak and also the dorsiflexor weak, right? So he has already motor deficit. Pain management is not going to, it is counterproductive. If you relieve the pain, patient will easily walk around, then he will go on the common foot rest. Because there is no pain. So, are you harming sometime or, see, do you understand what I say? So, if pain is the only symptoms, no motor deficit, no diminished ankle jerk, no EHL weakness, then it's okay, pain is the only symptoms. He has motor weakness. Is that correct?
As Mahapatra sir highlighted it very correctly, radiculopathy has three components. It's first and most common is the pain. Besides that, we can have motor component like weakness in this which is present in this patient, and or sensory involvement. So all three can be present together, or they can be present in various combinations, 1+2 or 1+3 or 1+2+3, like that.
I have one thing is telling, jogs are 3+.
Yes.
The loading. So the X-ray can be. If the jogs are 3+, it is upper motor.
Yes, sir. But I think there was screening was done in this, there was nothing higher up. Hello, Puranjay, can you show the MRI once again? Whole spine, sagittal T2, can you show it once again?
Yes, sir. If there is lumbar compression.
Puranjay.
Yes, sir. Sir, sagittal I have put, sir.
We are not able to see your screen.
Just a second, sir.
Yeah, whole spine, please show the whole spine.
Okay, sir. Sir, just a sec, sir.
Hello? Please go back to your slides.
Yes, sir. I'm on.
Previous slide, previous slide. Previous. Before.
So these are accessories and examination, sir. Sir, whole cut side hyperlinked here, sir. It can be opened.
Can you tell about the jerks, DTRs, deep tendon reflexes? Yeah. Triceps is 3 plus, supinator is 3 plus, knee is 3 plus, ankle is 3 plus. What about plantar? Yeah, this one. There is a large disc. 3, 4, 5, 6, 3, 5, 6. So this is a case of dual pathology, cervical plus lumbar. So can we hear from Divya sir, so what is his final plan for this case? As there is an element of myelopathy also in this case.
Yes, sir. I am handing over the mic to Dr. Zoya, sir.
Yes, sir. हेलो पुरंजय
सर अभी सर को माइक लगा रहे हैं 1 मिनट.
अच्छा ओके विल वेट.
Can we see what's happening in the other OT?
Ravinder, can you take to OT-2 for a short while so that by that time Professor Devja is ready with his plan?
Hi Rajesh.
Hello. Yes sir, Dr. Ashish.
सियाम चलाने वाला कोई है? नहीं, ये तो मेरा बंदा है ना। देखो सी देखो, सुनो, ये है S1 देखा। So basically we are going to first demonstrate you the S1 root block, and for the S1 root block आप zoom out करके दिखाइए सियाम। तो the सियाम has to be in a chorded direction. मुझे foot pedal तो चाहिए होगा ना? Anybody who can handle this सियाम and show, give me the foot pedal. So these patients are generally done under sedation. So we give 1 or 2 milligrams of midazolam, and if the patient is very apprehensive and got a lot of pain, then you add some fentanyl also, 25 to 50. So that means you need to do it in the operation theatre set up with all the resuscitation facilities and possibly an anesthesiologist in attendance.
Sir, then do you ask the patient to be NPO or
we generally ask the patient to be 3 hours NPO. Please shoot, please.
Okay, sir.
So we are trying to identify the S1 foramen. Shoot, please. और थोड़ा सा ले जाइए. Corded. आपको C1.
So delegates wants to know your entry point, how from where you will enter.
जी, I am just going to tell.
Yeah.
Then we are positioning the C arm. Shoot, please, shoot. Shoot. Shoot, please. We are doing the left side, huh? Shoot. So that's the place where S1 foramen, you can see the opening of the, shoot please. Yeah, so now, shoot please. So that's the place where the S1 foramen lies, right?
Yes, sir.
And I'm going to give some local anesthesia there. सुन कर रहे हैं? Have you given some sedation? Some fentanyl also? एक और दे दो.
Sir, have we already given some sedation to the patient or no?
2 milligram of midazolam has been given.
Okay, sir.
Yeah. So we use a spinal needle.
Sir, can you, delegates wants to know the needle size you are using for this.
22 gauge, 10 centimeter spinal needle.
Yes, sir.
And you see, I'm going to just bend the tip of the needle a little bit.
Yes, sir.
Zoom करिए.
Sir, some needles are there with curved tip also. I have given curved tip needles also to the OT. You can use them also.
I'll check that. So we have just bent it so that the tip of the needle is in my view. So I just check the position of the needle with the tip, right? So
yes, sir.
After waiting for a couple of minutes, after giving local anesthesia, you insert the needle in the direction of the C-arm. Shoot please. So the direction of the C-arm is important. Check please. Check please. टांग में क्या है?
Left side from S1 from.
ठीक है. So once you are in position, you can इसको lateral में कर सकते हैं. Please shoot, please shoot. Shoot. So can we check in the lateral position, please? So as Dr. Dhruv said that you have to confirm in 2 positions. So this was a chorded AP view, and now we're going to check in the lateral view. So you can see whether the needle is in the foramen or not.
Yes, sir.
Lateral view, please.
Sir, the off midline, just off midline.
Table up, please.
Just off midline.
Yeah. So you have to be your own radiographer, because very few people will understand the intricacies of. So you.
Yes, sir. We understand that everything is in angles here.
Yeah.
So even if tilt of 1 or 2 degrees creates problems in this.
So you can now check the lateral view, and you can see the position of the needle. So next comes the confirmation.
What you are injecting, sir?
This is dye Omnipaque 300. So as check please, shoot please.
And is it diluted?
No, it is not diluted.
Okay, sir.
It is concentrated, and you now see the, please check the lateral view. So you can see the nerve, and then you make it again AP view to check whether you are in the right position.
Sir, वो along the nerve ही जा रहा है.
Right? So now we are again going in AP and सीधा करिए, सीधा करिए और shoot please. So that's the route. You can beautifully see the S1 route. Is that very clear to everyone?
Yes, sir. It's very well seen, sir.
You can see a beautiful route, and the dye is spreading right up to L5.
Yes, sir.
I put some more dye, and you can see even the L5 area is covered. Just for academic interest, I am putting this. Yeah. So once you put this dye, check. Now you can see it's going right up to L5. So that's the time when you have to give the drug. So we have triamcinolone. You have triamcinolone. This is 80 milligram. Yeah. So we will be giving 20 milligram at each route. Right?
Sir, how much amount of dye you have injected?
We have injected about less than 1 ml, 0.5 ml of dye.
Okay, sir.
And you can see a beautiful spread with 0.5 ml of the dye. Right?
Yes, sir.
So we now give the drug. So I will be giving about
Sir, delegates wants to know what drug you are injecting and dose and amount, how much you are.
Triamcinolone, and we are injecting about 20 milligram at each side. So when you inject it, it's a bit irritant. That's why we put some local anesthetic, like the local anesthetic which does not have preservative. We inject it over there. Little painful. Can you show the C-arm again, please? C-arm again. C-arm, yeah. You can see the good spread now. Beautifully the nerve has been outlined, and the entire S1 route is clearly seen right going up to the L5. So 20 milligrams of triamcinolone at this particular juncture. And this is a very important component of spinal intervention, the S1 route, because most often in the L5 S1 disc it is the exiting S1 route which causes more symptoms. Patient complains of pain on sitting. So this has a very dramatic effect, and within a period of 48 to 72 hours, patient starts getting relief, although the actual relief will come after 1 to 2 weeks. So that we complete the S1 route. Now we go to L5.
So when you are injecting the steroid, does it also have some contrast in it?
No. Contrast is only given early in the first stage.
Sir, delegates wants to know about the possibility of any allergic reactions to these medicines and how to prevent them.
See, basically, Omnipaque which you are using is a non-ionic dye. This has zero incidence of any untoward side effect.
Yes, sir.
So which drug you have injected?
Pardon me?
Which drug?
We use triamcinolone.
Okay.
Triamcinolone is more or less a non-particulate steroid, and it has a longer duration of effect.
So how much what dose?
20 milligrams.
Okay. And does it depend upon the level of the injection? Or
say it again?
Does the dose depend upon the level of the injection where we are injecting?
No. Dose depends on each nerve route. So we are going to target 3 routes now, S1, L5 and L4. So total dose of about 60 to 80 milligram is one which we prefer.
So one question. 60 to 80 milligram for one patient or for one route?
One patient for 3 routes. So 20 milligram at each route.
And 60
Sir, can you show us the position of APV for S1, sir? Like what how many degrees should be tilted?
The degree of tilt has to be depending upon what you see there. So we don't have a predefined degree. You have to see the foramen. So at whatever level you see, it may be 30 degree, 40 degree, you go for it. So now we are going for a L5.
So that means your technician, C-arm technician should be equally competent and well trained.
Yes, definitely. That's why I brought my own technician. Shekhar.
Thanks to you, sir.
Yeah, I think we should applaud Shekhar. He's with me.
I think Shekhar is there with you for doing all this work for you.
He's with me for last quarter a century now.
Yes, sir. Thank you, Shekhar. Thank you so much. Sir, do you use dexamethasone for injecting?
I personally don't use.
Thank you.
But yeah, there are reports.
So now which level are you?
Now we are going at L5. Please show it again.
So you block all the levels where there's a disc prolapse, or you try to...
No, because this patient has 2 level disc prolapse. The exiting routes at the L4-5 level and L5-S1 level are, you go by the MRI, you go by the patient's symptoms. So it is not just that I am deciding because there are 2 discs. थोड़ा सा और lateral करना.
Sir, delegates wants to know there are 3-4 steroids available like hydrocodone, dexamethasone, methylprednisolone. How to use and how to decide that which steroid should be used for this?
Basically, you have to use the depot preparation, and amongst the depot preparation, we have depomedrol, which is methylprednisolone. You have triamcinolone, which is like Canacort or Tricort, which you would have heard.
That means we can use both depomedrol or this Canacort, both.
But these are like dexamethasone, betamethasone are being used. They are non-particulate, but they are not depot preparations. थोड़ा सा और जाना चाहिए नीचे end plate. Now we are trying to square off the inferior end plate of L5. So he is tilting it little corded. So,
Professor Bindra, can you comment on this steroids?
Let him explain.
Essentially, steroids are your choice, basically. So whatever you are comfortable with. I am using it for last 40 years, the methylprednisolone and triamcinolone, so I am comfortable, and over the years, thousands of patients, So now you just please show it again. Show it again, please. Show it again, please. Show. So we are squaring it and just करो ना यार, या तो मुझे दो या करो खुद. Zoom नहीं है, थोड़ा अपनी तरफ ले जाओ. सेंटर करिए. अरे इसको मत खींचिए. हाँ सेंटर चल दिखाओ, शो में. हाँ ठीक है. So can you see now? मेरे को foot pedal दे दो यार. I'm depending on you. So I generally use a foot pedal to shoot myself. Show please. I don't call this shoot. So now you can see the foramen infraneural approach just below the pedicle. If you can zoom it, everybody can see it better. So I'm giving some local anesthetic. Can you give one more midazolam, please? Local anesthetic. More local anesthetic, please. Local anesthetic. Sister.
Pranji, you can give the Siam pedal to sir if sir is comfortable with that.
I hate to call shoot.
Yeah, I understand, sir.
So this is the Scotty dog view, sir. We are seeing.
Yes, this is the Scotty dog view. You can see the ears. एक मिनट में बताता हूँ. Just give me some time. Dr. Dhruv, can you just show that? अच्छा ठीक है. So I'll just show you. ठीक है, मैं दिखाता हूँ. Shoot, please shoot. So this is the ear of the. वहाँ से जाने का फायदा नहीं है. This is the face of the Scotty dog.
Yes.
And I'm at just shoot please. I'm at this shoot. Yeah, this is the eye.
Right.
Yeah. यहाँ पे आने से हो जाएगा. हाँ ठीक है फिर. Shoot please shoot. मैं कुछ नहीं कर रहा. Proceed.
So have you tilted the patient, sir, little bit?
So that this is the ear of the Scotty dog, which is the superior articular process.
Right.
Then in between is this is the pedicle, and this is the eye of the Scotty dog. Then you have the facet joint. This is the facet joint, and then we have the inferior articular.
Ravinder, you are out of focus.
Please do not move the camera when sir is showing.
Yeah,
then
please.
we have the inferior articular.
Can you repeat,
process.
sir?
Yeah, so we have the superior articular process as he is outlining. Then below is the pedicle, and the eye of the Scotty dog is one where the medial branch is. Then you have the complete face of the dog, and below the dog you can see a needle wherein we are going into the foramen. So that's the foramen. And then you have the facet joint, Dr. Dhruv, facet joint. That's the facet joint, and by the medial side of the facet joint is the inferior articular process of the upper vertebra. So my needle, you can see presently is just below the pedicle at the 6 o'clock position. Now I'm shoot please. Yeah. So I'm going to change the direction to the infraneural. Show please. Check please. Shoot. 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 So you have to go very gently into the foramen because Yeah.
Sir, this needle which you are using to just put the local?
No, this needle is going
This
into
is the final needle, sir.
No, this is the final needle, not local. Local has already been given. AP, please.
So how much
So we'll go in the lateral view to see whether we inside. First the AP view. Shoot, please, shoot. So then you see the lateral recess. Yes. Now you can see the lateral recess. Maybe I have to go a little bit in now. Yeah. So that's it. So that's my final point in the lateral view. Now I will check in the AP view. Now I'm going to check in the lateral view whether I am inside the foramen and what distance I am in the foramen so that I am not touching the nerve.
Sir, just for confidence level, how much should of the needle should be inside and how much should be isolated for tension?
That you cannot describe by millimeters and centimeters, but you have to be just at the mouth of the foramen. The lateral recess you can see.
Yes.
That's the lateral recess, so you have to be just there. If I go a little bit in, I am going to touch the nerve, which would be bad because patient will jump and you may cause injury to the nerve. But yes, you check it in the lateral posture. Now you can see in the lateral, we are in the foramen. Yes. थोड़ा सा इसको वो करना, सुन, रिलैक्स हटाना, उधर ले जा. Yeah, check please. Yeah. So now you can see in the lateral view that we are lying very nicely. So I'm going to give the dye in the lateral view only.
So 0.5 cc of this.
0.5 cc of the. Check please. Yeah. So you can see the dye spreading in the epidural space, and you can outline the nerve over there. Check please. Yeah. So that's the nerve, and now we go in the AP view to check, and then we go in the. No, it is all fluoroscopy. Everything is based on your fluoroscope. So there are no fixed distances like 5 centimeters, 6 centimeters, like in the olden time when we're doing blind. But here we are doing under fluoroscopy, so that whatever you see. So that's the AP, and you can again, you can see beautifully this the dye, the nerve. So this is like this is the best approach. You can use the infraneural approach, subpedicular. This is a safe Karman triangle. You are outlining the nerve, and the interface between the disc and the root, the dorsal root ganglion, and the interface between the disc and nerve is the important area. So we have targeted that, and now the drug is going in. So similarly, 20 milligram of drug is going in here.
So suppose this needle gets into the nerve, into the substance of the nerve.
No,
how will you know that?
So that will be the most painful. That's why we don't give a lot of analgesics. We don't sort of knock off the patient, because into the nerve is a disaster. So even when you approach the nerve, patient will shout, but into the nerve would be total disaster because you will cause a lot of injury to the nerve. So that should not happen, and that will not happen if you are controlled in the last few centimeters of going into the foramen. So I put in the drug, 20 milligram, and just flushing the needle with saline and local anesthetic. We put Xylocard, just very minimal amount. Check please. Check. Now you can see the dye has spread nicely, and you can see the root. Okay? Is that okay for everyone? So you have seen L5, you have seen S1, now we go for the L4.
So sir, Xylocard you put after you put in triamcinolone,
Yes.
a little bit.
Yes, just about 0.2 ml of Xylocard,
Okay.
because these drugs are irritant and patient may have pain after the procedure, so just local anesthetic will take care of that pain.
So how much sir you put Xylocard?
ठीक है. Pardon me, sorry?
How much Xylocard sir?
0.2 ml of
0.2.
Xylocard. So I am taking out this needle and we are going for this final one. Now you check in the AP now. Let's start with the AP view. इसको central करो. So perfect AP. This is perfect AP. The inferior end plate, the superior end plate. Yeah, that's the spinous process. Then these are the two pedicles. Below the pedicle, the lamina. Yeah, the lamina, the pedicle, then the interlaminar space, and then you have the end plates are totally squared. So this is, I am not bothered about the upper one and the lower one. There may be parallax there, but my vertebra where I have to do the procedure has to be squared. And now you can see the foramen. So right, now we are going to turn it little oblique. Slowly and gently, please. Show it. Shoot, please. So now you can see the foramen now.
So obliquity is towards the side you are doing.
Yeah, on the right side, yes. So now you can see the pedicle. Shoot, please. Shoot. हाँ. और थोड़ा सा, हाँ. थोड़ा और मेरी तरफ करो. Little more lateral. थोड़ा ऊपर करो. Yeah. Shoot, please. Shoot. So this looks okay. You can see the Scotty dog, not as good as what you saw in this, but fairly okay. Yeah.
Yes, sir.
This is the pedicle. Now shoot, please. Shoot. So shoot, please. Shoot. Shoot, please. Shoot. 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 Yeah. So that will be my area where I am going to give some local anesthetic. Okay. Any questions?
No, sir, we are good.
You are all mesmerized, huh?
Yes, sir.
Very good.
It's a very, very nice demonstration, sir.
And hopefully from Monday onwards or whatever day you reach back home, you're going to do the first case.
Yes, we hope so.
Shoot, please. Check. So I'm little off.
How long patient will be pain-free, sir?
See, it depends. So it's not the injection which matters. It is the post-injection rehabilitation which is important. Check, please. So you have to get a tunnel view.
After some time if pain occurred, you will repeat as injection or you will refer for surgery, sir?
So it all depends, Basically, as I tell, these procedures are very easy to go. But the most important is the post-injection rehabilitation. Like you do post-surgical rehabilitation, the post-injection rehabilitation is also a 3 months job. The posture, the exercises, how to sit and how to stand, till what extent you have to give the drugs, reassurance, psychological reassurance, everything counts. So, our repeat rate is very low. We repeat not only more than 30 patients. So now this is another technique which I wanted to show. I am touching the pedicle. For the beginners, the best technique is this. Touch the pedicle and redirect the needle into the foramen. So this is touching the pedicle and now I am redirecting. See now. Show please. Yeah. So redirecting the needle into the foramen. After touching the pedicle, save. So as soon as you leave the pedicle, you are in the foramen.
So you move it little laterally while on the pedicle.
Yeah, and below the pedicle.
And below the pedicle.
Shoot. नहीं, pedicle को नीचे आ गया मैं ना, नीचे आ गया. Right? So I am in the AP view now. For the sake of time, I am not going to show you this. This is the AP view, and now we'll shoot in the eye. Yes, shoot please. So this is beautifully done, going into the epidural space. That's the nerve.
Somebody's head is coming in the way of X-ray.
What? Who is coming? Head is coming. My head. Okay, sorry. You roll my head now. Yeah. That's okay?
Yes, perfect.
So you can see the dye going into the epidural space also.
Yes.
Although that's not desirable, but if you have a central canal stenosis, then that is very much desirable because ligamentum flavum is hypertrophied and there is an inflammation there. So the epidural component can take care of that. So if it is a central canal stenosis along with the root sleeve blocks, I will give an epidural also. But if it is just an isolated disc pressing on the nerve, only root block. So finally I am giving the remaining 20 milligram of the drug. Okay. And then signing off with this local anesthetic saline mixture, little bit, 0.2 ml.
So sir, this procedure is a transforaminal block or just a root block?
No, everything. This is, the terminologies are different. Root sleeve block, transforaminal, selective, nerve root block, they all mean the same. So this is over now. If there are any questions, till we put the second patient, you can ask me.
Sir, as the root will go just below the pedicle, wouldn't it be safer to target the lower half of the foramen then
Yes,
go up?
definitely. As I said, for the beginners, just below the pedicle is a safe triangle. So you can target that. But if you want to be very safe, the infraneural component is the best one. Infraneural component covers the entire nerve, and you have a very good spread, and the interface between the disc and the nerve is beautifully covered. So that is preferred. But as a beginner, you may not be able to precisely in a tubular vision go there. So in that case, you can go subpedicular also.
Sir, with this we are putting two things. One is steroid and second is local anesthetic around the root, outside the foramen. Am I correct, sir?
Around the root?
Yes, outside the foramen.
Yes, I am outside the foramen, but my drug is going inside the foramen.
Yes. Okay. Is there any possibility of blocking other roots also because of the spillage into the interspinal canal? The amount of drug is very low.
Can you just focus this? If you see here, there is a bit of drug going into the epidural space, but it is going down. So it is going towards the, show that marker. Somebody was showing that marker. Marker जो आया था. दबाना. So, अरे एक marker दबा. अच्छा. So you can see it's going in the epidural space, but as I said, if it is a central canal, it is very good for us. Our target is not the interlaminar space. Our target is the root. So if it goes there, no problem. I mean, we are not giving local anesthetic, it is only steroid. And we are this is a dual disc, so no issue. And sometimes you can do two roots with one block only. So if you go at L4, you can block the L5 also.
Two things: how you declare your injection as successful, and till how long this effect of pain relief will be expected to him. Because this is not a therapeutic procedure. This is just a pain relieving procedure.
Yeah, this is like a pain relief procedure, but essentially, please try to remember this is a curative procedure also, because if the disc is not big enough for the surgeon to operate, and it is the radicular pain which is, there are lots of prostaglandins and other inflammatory mediators which are lying there. So I am sort of nulling them. I am sort of taking care of them. So those inflammatory markers go away with the help of steroid. Patient gets relief. He gets mobility. He starts doing purposeful mobility activity and exercises, and everything is okay. So you are giving the disc time to shrink. Not every disc bulge we people operate. So it is giving them time of 2 to 3 months, so that the mobility is there, muscles are strengthened, and the disc retraction takes place.
Actually, the pain relief breaks the vicious cycle.
That also,
and,
of course.
And once the vicious cycle is broken and patient is rehabilitated, many times patient become totally symptom free without any surgery.
Absolutely. But having said that, I'll give you an example of my own boss who came to me with a foot drop. I referred the patient to Dr. Kale. I said, no, foot drop, sir, you have to go for surgery. He is 80-year-old, so Dr. Kale said, no, there is no point, the foot drop has already happened, so let us keep it conservative. He came back to me, we did a root block, and to my surprise, after 3 weeks, the foot drop, the EHL was 4/5. So to my surprise. So if it's an immediate insult, which is causing pressure and edema, you can take care of this with the help of steroids. So early the intervention, better the result. In the past we used to say that more the nerve root irritation, more central sensitization, and more it becomes chronic, more it becomes difficult. So even if you operate a patient after 6 months, the results are not good. But if you do the intervention or even surgery early on, then the results are fantastic. So you may even reverse the motor deficit. Although that is not my indication of giving it, but once driven to the wall, patient doesn't want surgery or surgeon doesn't want to operate, you do it and you get the result. Not in every case, but we have seen in number of patients.
Thank you so much, sir. Thank you. It was a very nice demonstration. Just take Dr. Mahapatra last question. वो दबा दो.
How much radiation you have got in last 30 years?
Sir, please repeat the question because they might not have.
How much is the cost to the patient for each injection?
and how much radiation he has got in last 30 years.
Sir, Professor Mahapatra is asking about the cost of this procedure, including the infrastructure, and second thing, how much radiation exposure patient gets during this procedure.
Not patient, surgeon.
Basically, the radiation exposure to the surgeon.
I mean, I am doing it for last 40 years. I use my thyroid collar, I use my C-arm, and I am alive in front of you. So I do almost 10 patients in a day. So it is okay. I mean, I don't know what will happen to me in future. But if you protect yourself well, so you can have a goggles to protect your eyes. You can have a double lead apron.
Point is taken, sir. Point is.
No, I'm just telling
everybody should be having proper radiation safety. Dr. Duraj, I know many radiologists do fluoroscopy without bothering their own radiation. And I know my friends getting cancer.
The exposure to radiation is, I think, less than a minute. It's less than a minute. 60 seconds, less than 60 seconds. I think not even 60 seconds, 30 seconds or so.
Alright, thank you, sir. We shift because actually we have 10 to 14 cases. So if you want to see only 2-3 cases, it will become 230. So I think we should move on quickly. See the various facets of pain. Thank you so much, sir. We shift to Dr. Ashish Tandon.
Yes, sure.
Dr.
Are you ready with the presentation? Case 4. You can open case number 4 on your mobiles to see the history and examination and imaging.
Sir, are my slides visible, sir?
Case 2 and 3 गायब हो गए?
Yes, sir, yes.
Okay. So we are moving ahead with case number 4 now. He's 71-year-old gentleman with the known case of...
Your voice is less. Can you ask them to increase the volume?
Yes, sir. So is it better now?
Better. Better.
Okay, sir. He's a 71-year-old gentleman with known case of hypertension with complaints of neck pain radiating to bilateral upper limb. His symptoms is more towards right side. He also have lower backache with no radiation. On examination there is no deficits and other reflexes are also normal. So on imaging he got C5, C6 and C6, C7.
First show the X-rays. Yeah. There is cervical spine straightening is there on the lateral X-ray. Okay.
Yes. So we can also have reduction height at 2, 3, 4, 5, 6 levels on lower cervical disc. So now going with MRI on sagittal cuts, we can also see straightening is there, and disc is prominent. This is we can see at C5, C6 and C6, C7 level. So disc is more central only, and his symptoms is more towards right side. He also got lumbar disc, but he does not have any radiating pain. So for now, plan I will hand over to Mike to sir.
Sorry, there is no back pain?
No. Sir, his symptoms are milder only, sir. He got backache, but there is no radiation, sir. His chief complaints are neck pain with radiation towards right side mainly, sir.
Your volume is less, so we are... Chief complaint is cervical neck pain?
Yes, sir.
But no back pain?
To right side, sir.
Sorry?
With radiation to right side, sir.
Understood, but no back pain?
Sir, lower backache is there without radiation, sir, but it is mild only, sir, occasionally.
Okay. All right, can we have Dr. Dureja?
Yeah. Okay, now we are ready now.
Puranjay, please give the mic to Dr. Dureja so that we can discuss the plan with sir.
So, as you have seen the MRI and the symptomatology, which is neck pain radiating to the right upper extremity, little bit of radiation to the left, but majorly to the right upper extremity, and he has some paresthesia also because of this radiation. There is no sensory deficit, a little bit of sensory in terms of paresthesia, but there is no motor deficit. So we checked all the reflexes, biceps, brachioradialis, deltoid, everything is...
Please no crosstalk here, please.
Pardon?
Sir, continue, sir.
Yeah, sorry. So no motor deficit, and his radiating pain is troubling him for a long time, and as you can see from the MRI that there is a lateral recess compression of the nerve, and it is essentially the radiculopathy which is troubling. So as we were discussing in the morning, we have abandoned the cervical root sleeve block which we were doing about 20 years ago because of the spinal artery being very close to the nerve. So we are doing a cervical epidural, and as we will demonstrate, you have a fairly good spread along the nerve roots. So this is a C5, C6, C6, C7 disc pulse. So we will be going from C7 T1 interspace. Can we have this C-arm, please? Any questions so far?
Sir, here the spread will be upwards.
The spread will be laterally and upwards.
Okay.
Because I want C6, C7 and C4, 5. Right. The spread will be upwards.
And again, do you sedate the patient in order?
Yes, we do. We do give midazolam 2 milligram.
Okay, sir.
And that's it. Because you give local anesthetic and patient is quite comfortable, but yes, midazolam has to be given. Right. And you can see the position of the C-arm.
Yes.
You square off, and we have squared off. It is little corded. The direction is a bit corded. And you can see the interlaminar space where we have already given local anesthetic. Right? Push, please. You will add the C7 T1 interspace. So we have to hold the head properly so that the patient doesn't move during the procedure. So somebody will be holding the head.
So you're giving in midline, sir?
Yes, this is internal minor.
Right, sir.
Always internal minor.
So C7, D1. Right, sir.
आपको जी 5 मिनट के लिए पोजीशन बस, हाँ नीचे कर लीजिए सर. अब हिलाइए मत, है हिलाइएगा मत. या सो वी यूज ए स्पेशल एपिड्यूरल सेट. एक मिनट दिखाइए इधर, कैमरा प्लीज खोलिए. ये दिखाइए, इधर दिखाइए. Yeah, so this is a special Portex epidural set which has a catheter, which has a needle. यहाँ पे ड्रॉप कर दीजिए, यहाँ पे ड्रॉप करिए. So this is a loss of resistance syringe with which we see the epidural space. This is the needle. If in case required, we have a catheter, we have insertion of this. So if the dye is not moving up to the desired, you can use a catheter. So this is a standard 2He needle, 18 gauge,
okay,
which we are going to use, and this is the syringe which will help us in finding out the epidural space.
Understood, sir.
Right. Okay. So we are proceeding. हिलेगा मत जी प्लीज. शेखर आप ही कर दो ना. ठीक. चेक.
पीआईपी में एक्सरे दे दो.
ठीक है जी. तो my needle is directed little bit on the right side. As you can see, I am putting on this syringe, loss of resistance syringe. Check. Check please. So I am going middle right side.
Case 4, case 4.
So now I have reached the ligamentum flavum. Check please. I can feel the ligamentum flavum. So now I have to be very careful. Yes, that's the loss of resistance. Okay? As you saw, I am showing you again. There was a bounce back, there is no bounce back.
Right,
check,
sir.
Check please. Yeah. So my needle is purposefully directed towards the right side, and we are now going to show you the position of the needle in underlateral. आप हिलेगा नहीं. So we are in the epidural space on the right side because we want to bathe the right-sided nerve roots starting from C6 to C4. We check it in the lateral position, vis-a-vis the position of the needle in the epidural space. The syringe is used for identifying the space. Ligamentum flavum is the feel which you have to have. With experience, you have to have the feel of that, because there you have to be fiber by fiber, cutting the ligamentum flavum with the needle fiber by fiber, because if you do a thrust, then you can enter into the dural space, which is not desirable because the spinal cord lies there, unlike lumbar area. So you have to go fiber by fiber. As soon as it's a thinner space, थोड़ा सा हाई डाउन करो. हाँ, तो shoulder will be coming in between. ये आ रहा है, ये हाँ. और नीचे जाओ, दिखाओ. शोल्डर आ रहा है बट थोड़ा सा ऐसे ऑब्लिक. या दिखाओ. ठीक. So we are just So we are just trying to show you in the lateral view. या ये बीच में वो आ रहा है, थोड़ा सा आ जा. और जा, नहीं और जाओ यार, लैटरल जाओ, और जाओ. आप दिखाओ, अपनी तरफ लो। अरे यार लैटरल पे, हाँ आप दिखाओ, यस, और दिखाओ। So
Sir, in lateral view, how you avoid shoulder overlap?
You have to remove you have to take the shoulder below, the hands below. But at this level, the shoulder generally obstructs us.
Yes, sir. Because many of the patients, especially if short neck is there, you won't be able to see at this level.
So, yeah. So now there's time to see the spread of the drug. Shoot, please. इसको अभी AP व्यू करिए फिर से, अब मेरी तरफ लाइए, AP व्यू. Yeah. So now again after aspirating, I am giving my dye. ये dye है ना? Show please. Yeah. Now you can see the spread. There are some vacuolated areas because of the air which we pushed in, and now I will again. So the dye is preferentially going on the epidural space on the right side, and I am giving local anesthetic to show you the, no, not local anesthetic, sorry, no local anesthetic, only saline.
So what is the possibility of puncturing dura during this needle insertion?
See, basically as I said, now you can see the roots. The ligamentum flavum, feel of that ligamentum flavum is important. So there is an empty space, then you have the ligamentum flavum. There you go very, very slow. It is narrower than the lumbar space, the epidural space. Okay, but with experience, the incidence is very low, but it can happen. But if you should not be very violent to go deep in. Show please. And now I'm going to show you the roots. Yeah, you can see the roots now. You can see the C7 root. You can see the C6 root. Can I have more dye, please? More dye.
That means while passing the needle, you have to move very, very slowly and feel the tissue.
Absolutely. Absolutely.
That is the crux of this technique.
Yeah. Yeah. Shoot, please, shoot. I'll put some more dye. Yeah, you can see the roots now. This is the C7 root. Then you have the overall. This is the C6, C5. This is C5. There are lots of electrodes which are hanging in between. I am putting some more dye for you. Check in, please. Check, please.
Till higher up, till what level can you see by injecting this?
See now the roots can be seen beautifully. Can you show these roots? Yeah, this one. This on the other side also, on the left side also. Yes. Putting in more dye has shown. So you can put a catheter and go up to C1. Why not?
Yes, sir.
Anywhere. Show please again. Show please. Now you can see the roots on the left side, roots on the right side. The desired area was C4-5, and I can see the roots on both the sides. Right? Any question? The same drug, 80 milligrams of triamcinolone, which I am going to give. Okay? This is 80, no?
So you said, sir, again same thing, 20 mg triamcinolone.
Yeah, here it is not root, no? It is epidural, so I am giving 80 together so that it bathes all the nerves.
Okay, understood.
Can you
This is
please
full 2 ml of dopamine.
Yes. So you can see now the drug from the epidural space has migrated into the roots only. So that's why the root block which was done earlier has been abandoned, because you can beautifully see this. So why take the risk of puncturing the spinal arteries? Right? For the sake of showing you, I can even put a catheter. So this is the catheter which we use, and so I am putting a catheter. Catheter is in now, and we're going to connect it. We have the dye. No. No. No, high volumes are not required. Just about 2 to 3 ml is required. So with this filter, with this connector, catheter is inside, and I'll show you the catheter also. Check, please check. Yeah, you can see now the catheters are moving on the right side. Check, please check.
So this catheter has gone down or up?
No, it's gone up,
Okay.
You can see it's gone up, right up to C1 now, C2. Yeah. Or preferentially on the right side it is going. Yeah. 40 milligram.
Sir, we are not able to make out where is the catheter. Can you highlight it?
Okay. Sure. Continuous करोगे, continuous.
Is it a radiopaque thing?
Continuous करो. No, it is not radiopaque. Continuous करो. Yeah, that's the catheter.
Is there any mark, dot or mark, or what is there?
No.
How
This is not a radiopaque. We have radiopaque catheters, but this is not. So the dye spreads, but it goes rightly. If you can see, the dye is spreading right from this place to this place and going down. I don't know whether you'll be able to appreciate there.
We are not able to appreciate it here, sir.
Check, please, check. Yeah. No, you can see the catheter probably. Yeah, this. Yes. So he does have some symptoms on the left side also, which we can take care.
And like the catheter has gone up, had you directed the bevel upside?
Yes.
And can we do this for the down also?
The bevel is always directed up. If you want upper segment, you can direct it down. Put a catheter, it will go up to thoracic 6, 7, 8 also.
Okay, sir.
From this level. Okay?
Okay, sir.
So we
And this entry point is the standard for all cervical epidurals, or
you can
tailor it up or down?
You can tailor it up and down, but the favorite site, the easiest sites are C7, T1.
Okay.
You can go C6, C7 also. Sometimes C4, 5.
Because it's easier to identify C7 prominent spinous
identify also, and the interlaminar space is quite, in the upper segment this is very narrow.
Yes, sir.
Yeah.
Thank you, sir.
No,
the audience?
only if it is not going up. If it is going up, there is no need. I just wanted to, just for them.
Dr. Dureja?
Ji.
One question that in this case you did not give Xylocard after the
yes,
steroid.
Generally we don't give because we don't want to do a motor blockade of the cervical nerve roots. They are important roots, so I don't want to cause any motor deficit.
Right.
So specifically it is an epidural, so even if I give 2 ml it can cause some motor deficit.
Right. Thank you, Dr. Dureja. Thank you.
Regarding complication of this procedure, is there any possibility of patient developing extradural hematoma because of the catheter moved so much?
Not really. We haven't heard of it, not seen it. Only the dural puncture is the only thing which can happen, and that too is a manageable complication.
Okay, sir.
Otherwise we do it in the OT, we use all sterile aseptic precautions.
Thank you, sir. Thank you, sir.
And because this is not a weight bearing disc, the results are very, very good.
Okay, sir. Thank you, sir. Can we move to OT2?
Yes.
Shift to OT2.
but the
Go for it, but the cool nations have come into this just to break this pattern.
Just to get a perspective, how many of neurosurgeons are there in transforaminal identify us that you need to have the radiological
all of you for this ISPNS live, sir.
The 2nd September editorial, and this is just to complete the figures that maximum of the mechanical pain, 15% is neurogenic pain, non-spinal conditions and visceral pain, and these are things. But very important to remember that back and neck pain are not simple nociceptive
Well, sir, I request Dr. Dureja sir and Dr. Ashish forces, the co-organizers who have been
Please start. So now we are to case 5. She's a 58-year-old female, known case of hypothyroidism. She has mainly complaints of lower back ache radiating to left lower limb. She has a long history of 15 years. Currently also she has right buttocks and with radiation to lower limb, and she also have upper limb symptoms mainly towards left side, but she is debilitated by her left lower limb symptoms. So we will be addressing that today. Otherwise her examination is within normal limits. Reflexes, hyperreflexia is there in knee and ankle. On imaging we can see kyphosis in early kyphosis in cervical spine, and loss of discal spaces is there, and in lumbar spine also we can see loss of discal space here. On MRI you can see L4, L5 and L5S1 disc, and same we can address on axial cuts. Now I will hand over the mic to sir.
Dr. Dureja? So this is a patient who has, as you have seen in the history and on the MRI.
Can you increase the volume for Dr. Dureja?
Okay.
Ravinder?
Okay, am I audible now?
Yes, sir.
So, okay, so you can see by the history and MRI that this patient has predominantly back pain, and there is a radiating component on the left side. There is a L4-5 disc bulge which is causing radiculopathy, but primarily she is more concerned about the pain which she gets in the back on sitting posture. So if even in an MRI you can see there is a effusion in the L4-5 facet joint, and she has all the signs of like hyperextension, increases pain, local tenderness is there. So all the signs of a severe facet arthropathy. So we are targeting the facet joints by doing the radiofrequency ablation of L4-5 and L3, L4 roots, the median branches, and we'll be targeting the radicular component by doing L4-5 root block. So we are doing a cool RF of L4-5 and L3, L4 medial branches. Over to Dr. Dhruv, please. Yeah.
Okay, sir.
So you can already see on the image that we have given some local anesthetic at the eye of the Scotty dog. Since we are using a 17 gauge needle, this is a 17 gauge needle for cool RF. We have given this local anesthetic so that the patient does not experience pain because of something closing.
Good morning everybody. Thank you so much for the we can actually give plexus blocks. We can do about the stoppage of transmission from that particular point. So these are the guys who were responsible. Transmission is taking place of the current only through active tip, and to complete the circuit we have
5 to 10 mm. So big lesion, so you can be spot on also. You can have a tubular vision. So now you can see this is like exactly on the eye of the Scotty dog. The dorsal medial, the medial branch from the dorsal rami crosses this and then supplies the facet joint. Even the facet joint, you can see there is a infusion in the facet joint, so it's a diseased facet joint. So we hit the bone and then we check it in the lateral position. So this is the final position of our needle on the eye of the Scotty dog for the medial branch, the branch of the dorsal ramus, which is supplying the L4-5 facet. So once you put the needle there, we turn lateral.
So it is, right now we're hitting the bone, sir?
We are hitting the bone, yes, we are hitting the bone.
Before I go into fluoroscopy, a few concepts about fluoroscopy which I always have gathered over the period of time. So fluoroscopy is, we are trying to connect top to bottom for a late urological dye. Thank you. Any questions?
Whether you, because if you cross that groove, you may go into the foramen. So, yeah, we are not in the foramen. थोड़ा सा नीचे करेगा सियाम, सियाम नीचे करना, सियाम नीचे. अच्छा, stable up please, stable up please. So just to check, we are not close to the nerve. In any case, we are going to do the stimulation also. Bus, check please, check. Yeah, this is exactly the place where you want the needle to be. And now we are going to do the stimulation. So we cannot deeply sedate the patient because patient cooperation is important while doing the stimulation. So we tell her that we will be doing the stimulation and there should be a local, yeah. So impedance, can you check, somebody can show the machine please?
What are the parameters and what?
So you check the impedance. 715. Yeah. So we want to, yeah, coming down. That's okay. Around 500. So we check the impedance.
What should normally be?
Around 500, maximum 500 to 600. Shoot please.
So here it is like it's coming 800, 900. We need to reposition.
Yeah, we are repositioning now.
Till it is very close to the nerve.
Absolutely. No, the bone.
To the
Here
bone.
the nerve is not in.
To the bone.
Yeah, to the bone. Okay. Now it's 6:30. This is fine. Yeah. छोड़ दीजिए. So we can in the interface between the bone and the needle we can put some saline to see the interface, but yeah.
What is the impedance right now, sir?
It's around 800 to 900.
Okay.
Yeah. So now it's yeah. Now the impedance is gone below 300. 300. So.
Okay. So you put in saline.
Yeah, but just put in saline between the interface of bone and the needle. So
Okay.
that takes care of the impedance.
Okay.
So now we do the stimulation. So first is the sensory stimulation at 50 hertz, and as we told in the morning, 0.4 to 0.5 volt. You check whether there is any radiation of pain to the leg and all. Although you have confirmed under lateral, you have seen under AP, but still you have to do a sensory and motor stimulation. आपको कुछ करंट आ रहा हो तो बताइएगा. We are starting now. धीरे धीरे. आप कैमरा है सर? कैमरा है सर?
हाँ sir, we can see.
हाँ जी. 0.4.
पैरों में तो नहीं जा रहा आपके?
पैर में तो नहीं जा रहा जी. बिल्कुल नहीं. और डालिए. और जाइए. कहीं पैर में कहीं लोकल आ रहा है वहां पे? ठीक है. और बढ़ाओ. हाँ, आप कहाँ पे आ रहे हैं?
पीठ में आ रहा है, पैरों में तो नहीं जा रहा. कमर में ही है ना, कि पैर में नहीं जा रहा.
अच्छा. कह रहे हैं कि पीठ में ही है पर पैर में ज्यादा तो नहीं फील हो रहा. ठीक.
What should be the ideal response, sir?
Still about 0.5. There should not be any. There should not be any response. Only local response. That's it.
Okay.
कुछ नहीं है, so she doesn't have anything. So then we do a motor. So motor you may have some fasciculation locally, but again, yeah. आराम से. जाओ जाओ जाओ. मोटर है ना, जाओ जाओ. Yeah. So now you can see the twitching here. आप हाथ हटाइए. और बढ़ाइए थोड़ा. So you may see, yeah.
No sir, these are electrospinal group of muscles.
Yeah.
Multiple as well. That supplies the median branch.
Yes.
So it shows that we are at the median.
So this is, you can see these fasciculations, which is the erectospinae muscles fasciculating. So yeah, this is again confirms that you are at the medial branch.
Right, sir.
Right? ठीक है जी. Stop please.
एक बार final shoot करिए. Here we are.
Yeah.
वो जो है that is the tip of the middle. इसके आगे जाता है the probe. No point less than point. I think fine. Sir, do you want to satisfaction?
Yes, sir. So after you have, you are satisfied that you are on the nerve, then you, because the ablation part is painful, so you can give some local anesthetic before you start the ablation. But only after confirming that you are at the median branch. So just about 0.5 ml of, not much, don't give very much of local anesthetic, just 0.5 ml, because it can spill into the root and later on cause a problem to you. So just about 0.4 ml of lignocaine or bupropion. बस ज़्यादा मत दो. ठीक. Right. So we'll wait for the local anesthetic show the effect. दूसरी नीडल डालनी है अभी. आ गया. पकड़ लो. यहाँ पे थोड़ी पोजीशन मेरी चेंज हुई है. ठीक है. ठीक. चलो शुरू करो. So we are now starting the lesioning. Now the cool RF has a special property that the temperature will not go beyond 60 degrees.
Okay.
Unlike standard RF where you can go up to 80 and 90 degrees. Pulsed RF is 42, but here it is C, and you can see some water flowing. आप वो machine दिखाइए please. So that's cool RF basically means that the temperature are cooled down. So you don't allow the heat to develop at that particular place, so that no damage to the structures is done. Yeah.
And we see the time is set to 2 minutes 30 seconds, sir.
Yes.
So that.
So the first lesion will be for 2 minutes, 2 minutes and 30 seconds. And now the lesioning is going to start now.
Right, sir.
Once the temperature is 60 degrees. Now. So now the lesioning is starting. As you see the graph.
Yes.
Now. So the countdown has started now.
Right, sir. And does the patient feel anything?
No, we have already given local anesthetic, so she is not feeling any pain. आपको कोई तकलीफ तो नहीं हो रही ना? ठीक है. 2 minutes and 30 seconds.
So, how much does this machine cost, sir?
Machine cost. बोलो भैया. सरकार. $80. So that's a government cost, please. 80 lakhs.
80 lakhs.
प्राइवेट में तो आम टेस्टिंग होती है ना, तो आप हमसे लेके ले सकते हो. 3 मशीन दिलवा दूंगा आपको.
What machine you are using, sir, at your place?
I've got 2 machines, Smith Nephew and Cosman.
Sorry, which ones?
Smith and Nephew and Cosman.
And what is their cost, sir?
सर हमें मत खुलवाओ सर, मैं इनकम टैक्स वाले नहीं हूँ, आप छोड़ दो। सर वो 14-15 लाख की एक मशीन होती है सर, वो तो एक महीने में निकल आता है कॉस्ट। हाँ आती नहीं है, मार्केट में अभी 20-25 लाख की आती है।
Sir, any Indian manufacturer do?
नहीं सर, नॉट सो फार। चाइनीज मशीन एक आई थी पर वो मार्केट से जल्दी निकल गई। Conventional is like standard going up to 80-90 degrees. Here it is 60. But this machine can also give conventional RF.
And sir, this radio frequency RF catheter which you put in,
Yeah.
what is the costing for that? How many cases can you do?
No, this is a disposable catheter, so we have 2 needles in it. So this is about 35,000-40,000. 25,000 please.
RF needle?
This kit. RF needle is only 1,500 rupees.
1,500.
Yeah.
That can be used here in the
normal RF machine. So now, since the facet joint like L45 is supplied from a branch above and branch below. So if you want to do a complete ablation of that facet output, then you have to do two branches. So we've done L45, now doing the L3, L4. L3, L4 facet is normal, but there is a branch which is coming from L3, L4 to supply the L45. It tweaks from the dorsal MI. So we have to do the L3, L4 too. So we are now going to do the L3, L4.
So this is the RF needle that has been written, which is costing 1,500 rupees, and the catheter which is ideally supposed to be disposable.
Yeah. You can do a ETO.
You can. How many cases can we use it, sir?
Sir, मैं तो practice में तो नहीं मैं reuse करता हूँ. But मतलब 2-3 क्योंकि blunt, the tip of the needle gets blunt. So if you're doing trigeminal and if you're hitting the foramen navel wall, you may cause some damage. So when you are having CSF and all, I don't reuse it. But 2-3 cases you can do.
Right.
Now you see now दिखा रहे हैं. So you can see now we are again at the eye of the Scotty dog.
X-ray नहीं आ रहा इसमें. Show the X-ray.
X-ray.
Show the X-ray, Ravinder.
X-ray दिखाओ. रविंदर कहाँ गया? रविंदर तो है ही नहीं है.
अनुज.
हाँ.
X-ray क्यों नहीं आ रहा? हाँ. Yes, sir.
All of you for this ISPNS live.
The knife has gone a full circle now, 3 times. No pain or continuation.
अरे क्यों कर रहा है तो? देख नहीं रहा तुझे? देखो. हाँ ठीक है. बोल आगे. देखा. देखा.
Exactly, I could feel I'm going a bit round. Lateral.
एक मिनट चेक कर. ठीक है. Lateral. So we are right at the eye of the Scotty dog. This is a 17 gauge needle. Produces a lesion of 15 mm. Yeah. So you can go spot on, but otherwise if you are using the standard RF, then you have to be lying close, parallel to the bone. Then you can go from a segment below. क्या कर रहे हो? Very lateral, यार.
So nothing will change for standard RF also, sir?
Pardon, sir?
If you're using standard RF,
yeah,
nothing changes in terms of technique?
No, there is, as I said, that you have to, this is a spot on needle, tubular tunnel vision, but there you have to go from a segment below and the tip of the needle should be like touching the bone. So it has to be a oblique insertion of the needle.
Okay.
I'll just show you. एक कोई needle दिखाना मुझे. एक कोई needle है. हाँ. Shoot please, shoot. अरे अब तो वो lateral आ गया ना. मैं आपको दिखाऊंगा अभी।
राइट सर।
क्या कर रहे हैं?
शेखर साहब क्या कर रहे हो इधर? हाँ शेखर साहब को समोसा खाना है भाई। Yes. So now you can see the facet joint there. That's the facet joint, and just close by we are the needle is there. So just the ideal position for that. आप वो डाल लो। Hello? Impedance 420, 418. So absolutely fine. And ठीक है जी, तो do the sensory now. Sensory. अभी आपको थोड़ा करंट देंगे, आप बताइएगा। कुछ भी करंट आए तो बताए। No, nothing. No, we don't give local. Not now. So 0.4, 0.5. कुछ आ रहा है जी? कुछ आ रहा है लोकल, वहीं पे ही आ रहा है ना? हाँ जी? हैवी लग रहा है, बट लोकली। टांग में तो नहीं जा रहा? नहीं जा रहा। We can increase it a little bit and see. थोड़ा सा और दीजिए। बढ़ गया जी थोड़ा? ठीक है। मोटर? So now there will be muscle fasciculation of the erector spinae group.
Sir, what is that contrast like ring thing we see on the X-ray?
Contrast नहीं है वो, ये needle के ये जो components हैं।
What is it? Sorry sir?
ये probe के components हैं। आप ये कैमरा दिखाइए इधर।
अच्छा, it is the probe component.
हाँ जी, ये देखिए अब।
हाँ हाँ, ठीक है ठीक है। Right sir. Understood.
तो मोटर हम बढ़ा रहे हैं। कुछ आ रहा है जी? बढ़ाइए। तो आप इधर फोकस करिए थोड़ा। ये फोकस करिए यहाँ पे। ये फोकस करिए यहाँ। इधर फोकस करो सर, फोन पे बात कर रहे हो। नहीं, जूम करो, जूम इन करो। बढ़ाइए।
हाँ.
You can see the muscle fasciculation. Or bro?
Yes, little bit sir.
Yeah, now you see.
Yes.
But nothing going on the
So this is again confirmatory that you are on the middle branch. You can see now?
Yes sir.
चलो एक मिनट में आपको वो भी दिखा देता हूँ जो स्टैंडर्ड आरएफ दिखा भाई, दिखा। एक मिनट आके दे दो। बंद कर दीजिए मोटर। अब बस ज्यादा मत देना लोग। बस इनफ। ठीक। So till we wait for the local to show the effect, I'll just tell you that you have to go, इस यहाँ पे आ रहा है, दिखाइए सर।
हाँ, yes sir, we can see.
So you have to go a segment below.
Right sir.
And then your needle has to be just parallel to the bone.
Okay sir.
और दिखा ना, और दिखा भाई। हाँ इसे दिखा तू दिखाना भाई। हाँ दिखा। So now I have to दिखा और दिखा। So something like दिखा।
Yes, now we can.
दिखा। So here. So it has to be parallel to the bone, touching the bone, so that you get a maximum area for ablating the nerve.
Oh, okay. So there we were putting in perpendicularly in the cool RF.
Yeah.
Here we are perpendicular to the bone.
हाँ.
Right sir.
ठीक है.
Understood sir.
चलो we are now ablating. तो अभी अगर यहाँ पे तो ये करना ही हमने, आप दूसरे ओटी में चले गए?
हाँ फिर जाए। Any questions?
Yeah.
Yes. Mike, हाँ, ये नहीं।
Lesion started. We have started the lesioning. Any questions?
Yeah, so the question is for L4 for L4 joint we are taking the L3 route.
Yeah.
So if we had to go for higher joints we would take one route higher.
One route higher.
That is the question.
So actually, sir, for a one facet joint, we are going for a L3, let us say L4, L4, L5, we are doing two entry points.
Yes.
Two entry points. One
Yes.
for L4 medial branch and one for L3.
Yeah, that is because there is a tweak coming from L3 to L4-5.
Okay. The two levels are involved. That is why you are taking through two levels.
No. Two levels are not involved. One level is involved, but there is a dual supply. It is not just one medial branch. It is just branch from above also sends the twig. So if you are doing only one level, you are not doing the branch which is coming from above.
Right.
So for L4-5, I'll do L3, L4. Supposing we are both involved, L4-5, L3, L4, so I'll do 3. 4-5, 3-4 and 2-3.
So for upper twig which is coming below, can you show the entry point on X-ray?
Same. You have to block the medial branch.
Okay.
Same.
Okay.
Thank you, sir. Thank you.
Thank you.
We will shift to next OT.
Yes.
OT2 shift. Anuj?
Yes, sir. OT number 2, you are connected, sir. OT-1 we are with you, Purunjay. एक मिनट सर माइक लगाया केस OT-1.
So we are going ahead with the case number 2. 35-year-old male who underwent endoscopic L4 L5 discectomy.
Is it case number 2, right?
Yes sir, originally it was case number 2, but we are taking as case 4 now.
नहीं
Pehla.
Carry on.
Yes sir. So patient underwent endoscopic L4 L5 discectomy in 2019, then but his developed recurrence of symptoms, lower backache radiating to bilateral volume, but his symptoms is more towards left side only. He also got 50% sensory loss in left L4 and L5 dermatome. Otherwise, his power is normal and reflexes are normal. On MRI, we can see at L3, L4 level, partial narrowing is there, and at L4, L5 level narrowing is more towards L4, L5 level. So,
Dr. Dureja is there?
Sir, doctor.
There seems to be a little bit of far lateral disc actually, if you see on these L4-5 levels.
Yeah.
Dr. Dureja?
Sir, yeah, he just gone to the washroom, sir. Yes, sir, he has come.
So what we want to know is, sir, welcome back.
जी सर बताइए.
Sir, in this case, we can see there is some subtle foraminal stenosis with maybe a far lateral disc or whatever, and previously operated case. What is the reason to do a epidural lysis in this case?
Because if you would have seen a contrast, we don't have a contrast MRI. You would have seen that there are some epidural adhesions and fibrosis.
Okay.
So in order to take care of those, we have a specialized catheter actually, which is a RAX catheter, which unfortunately we don't have at this moment. So we do this adhesion lysis. So basically it will be more diagnostic, where we put a catheter in to see whether there are some filling defects in the epidural space, which indicates that there is a fibrosis and adhesions. So we want that we diagnose by putting in this catheter, and then you have some agents like hyaluronidase, hypertonic saline, and of course steroids, which you can put to clear off these adhesions.
So what would you prefer, sir? What agent do you prefer?
So we prefer hypertonic saline. We also give hyaluronidase, and we continuously do the infusion, putting a catheter for 48 to 72 hours by putting saline and local anesthetic. So breaking the vicious cycle, breaking the adhesions really helps the patient. Because surgically also you can't help for these epidural fibrosis, etc. So we have a special catheter also, wherein we negotiate these adhesions and try to clear up with saline. So it's like a hydrodissection which we do with saline, but if you use hypertonic saline, the adhesion lysis is much better.
So this is technically a failed back syndrome patient.
See, I prefer, because I work with surgeons, so I don't call this failed back. Please don't mind that. Because I once did the mistake of labeling a patient failed back, and my surgical surgeon friend was very unhappy because it was not his fault. So it is not a failed back because of the surgeon, it is because of the patient or whatever the reason. So I use post-laminectomy persistent pain syndrome, the terminology. And I would advise everyone, you people may be using this word, but I don't use, because I have to live in a private environment where I don't want to annoy my friends. I mean, I'm very honest about it.
Right, sir, right.
Because it is not the fault of surgeon all the time. There are other reasons. Sometimes it is sacroiliitis, sometimes it is a facetal hypertrophy which causes pain, not entirely surgeon's fault. So no failed back, please. The terminology is out of my my vocabulary.
So your plan in this case is, sir?
I'll do a caudal epidural.
Caudal epidural.
Yes, and then I will, local lady. And then I will put a catheter to see What is the level? Level L45. So, see on please. So at the sacral cornea, I am giving this local anesthetic. Camera on, please. Camera. So you enter into the caudal space through the sacral cornea, sacral hiatus, and then enter, and then we do the epidurography, and then we put a catheter, then do epidurography, and try to target the filling defects. Please, see on. Sure. If you do a contrast MRI, then you can see it very well. Yes. So whenever you have a patient who has had a surgery, we prefer to do a contrast MRI because that gives a better view on terms of epidural fibrosis, erythroiditis, all these things.
Right.
So can we have the CM please? You keep looking for it. Sit down and wait. So just give me a minute. So the presentation is like bilateral leg pain or back pain. Bilateral leg pain and back pain also. And all the paresthesias and everything. So the post-laminectomy pain syndrome generally manifests with persistent back pain, leg pain, burning sensation, paresthesias, and they are like, we call them as a spinal cripple. Because not one, I had a patient who had 7 spine surgeries. Till Professor Banerjee said that enough is enough. You go for various things like we did a spinal cord stimulator in that patient.
Dr. Dureja?
Ji sir.
Sir, there is a question that if the pathology was higher, let's say L2, L3, L1 level,
yeah,
would we still do the same caudal block?
No, I would have gone from a higher level.
You would have gone through the higher
level. Gentlemen, raise the table, please. Table, please. Yeah. So if you can see, थोड़ा ऊपर लाइए, ऊपर जाइए सर, ऊपर जाइए ना. Yes, bus. So I am using this epidural needle, 2 needle, the same one which we used for cervical epidural. दिखाइए.
So now we are to case 5. She's a 58-year-old female.
You see the direction?
Now I will hand over the mic to sir.
From that particular
Exactly. Yes, show please. And now I am going almost parallel to the. So now the lesioning is starting. As you see the graph.
Right. Yes.
Live. No. Live. So the countdown has started now.
Right, sir. And does the patient feel anything?
No, we have already given local anesthetic, so she is not feeling any pain. आपको कोई तकलीफ तो नहीं हो रही ना? By putting a dye. Aspirate.
Right, sir.
Please. Yeah, so the dye is spreading nicely. It is going up to L5. Let's see in the AP view now. What is the next case? Failback. No, not called failback. No. ऊपर चलो. नहीं, ऊपर जाइए सर, ऊपर. हाँ, ठीक. So I am going up to L5.
Right, sir.
Most probably there are lesions there. So I'll put some saline first. See whether I can break the adhesion. Yes, it is going a little bit. Show me please. Yeah, it is spreading up. So to go up to under pressure, yes. Good volume of saline under pressure. Then we will put the catheter now because our target is L45. So this is a normal catheter, but you have a Rax catheter which is radio opaque, which has got a steel sort of a stellate in it, steel wire in it, which will help us in negotiating the. So
This catheter we can use in the cervical also, sir?
Yes, we use this catheter. I think you were not there that time.
And
So
what is the cost for this?
this is simple, about $1,000.
Okay.
So now can someone show this? So I'm showing you that my die is going on the right side, but
Right
there
side.
is very little die on the left side.
Yes, sir.
So this is the filling defect which I was talking.
Right.
This is a typical Christmas tree, but Christmas tree, you can see these leaves on the right side, but left side only at about one level you can see, but not here.
Right.
So now I have to reach that area. So my bevel should be on the left side, right side rather, right or left side? Yeah, my catheter is going in. 20 mark, 22 mark. Let's see now. Okay. So this is what the die now. Now have a look at what you were seeing earlier, and now the die to see whether we have reached the, yeah. Now you can see my catheter is bathing the, show please, show. Yes, hold on. Now you can see the spread of the die, which was not there earlier on this side.
Where is the catheter, sir? We can't.
Catheter is difficult to see.
Right.
See, this is the catheter. It's going like this.
So your head is coming in the way.
Yeah. So this is the catheter going.
Right. We
Yeah.
can see it. Yes.
You can see a thin line. I'll put some dye and just show you. Just 1 second, please. दिखा दे रहा catheter दिखा. कैसे दिखा? Show. दिखा. Do you have some hyaluronidase here? Do we have hyaluronidase here? Hyalase over. Right? So now I'll try to see if I can go a little further up.
How much further would you like to go, sir, ideally?
Because the lesion was at L4-5, I'm at L5 upper border. If I can go a little bit further up. No, there are adhesions, so it is, my catheter is not going up. I'm trying from a different angle. Yeah. So this is the maximum I can go. Let me see, it is about 22-23 centimeters. Check please, check. Check please, check. No, I think beyond that adhesion. So now I'm going to put some saline to break these adhesions. This could be hypertonic saline, but we have normal saline. Check please, check. Yeah. Now you can see the catheter also. Yeah. So it is pushing up now. Yeah. Going up now. You can see I've crossed the upper border of L5. Yes. Check please, check. Yeah, I'll put some more dye. Can I have some more dye, please? Check. Yeah. Yes, it is going on the right side now, right up to the lower border of L4. I'll put a dye and show you. So saline you can use up to about 15 to 20 ml more saline.
So you said hypotonic saline, right?
No, hypertonic.
Hypotonic. So 3%.
This is normal saline. You can go up to 9%.
9%.
Show please, show. Yeah. Now you can see I am going up to almost the lower border of L4. Show please. Yeah. So some more saline.
How much saline you said? 20 cc?
15 to 20 you can go easily. Show please. Show. Yeah. So it is opening up. Still lesser dye on the right side, but still you can see that there is a dye now. I am just clearing up with saline. Yeah, clearing up with saline, but it is going up to L4 now. See this is the dye on the right side at L4.
Right, sir. Right, sir.
So I am putting my drug also now. We don't have hyaluronidase. I would have loved to know hyaluronidase. So I am giving some triamcinolone. So I'll give 40 first and then 40 at a different place.
If you were to give hyaluronidase, how much would you give, sir?
1500 units.
1500.
Show please, show. Yes. So it's cleared up now. That means we have bathed that area where we expect that there would be epidural adhesions and a little bit of fibrosis. So quite happy now. After putting the drug, I will again put my dye to check the, yeah, show me please, show, yes, show, yeah. So again I will try to reposition the catheter more on the right side. And see, check please, check, yeah, check, yeah, now I'm going quite up, high up to L4. I think he would be having more symptoms on the right side, is that right? Of both the legs. So I'm putting my remaining drugs, check please, check, yeah. Remaining drug there. Again some dye to check. Show please. Show. Okay. So the remaining drug I am giving, then clearing off with saline. I think we have done a good bit of epidural adhesiolysis as we call it. The ideal drugs would have been hyaluronidase and hypertonic saline, but even a normal saline would do the job. You have to be a little careful with hypertonic saline because it has some neurolytic properties, so don't give very high volumes of the hypertonic saline. Check please, check. Yes. So the right dye is totally cleared off, that means we are having a good spread there. And now a little bit on this side again, on the left side, which we were not focusing till now. Yeah. About 10 ml, 5 to 10 ml. Sure, please check. Yeah, okay. So quite satisfied. L5 roots, nicely done. Even going up to the L4 roots. Okay. Right.
Lunch is also ready, so whoever want to go can start the lunch because it's a small area. We cannot have all the delegates together.
So just show the last time I showed you the lateral dikha do. I'll just show you the catheter and dry spread in the lateral and then we finish off. Is the next case ready? दिखा उधर रेडी है ना दिखा भाई चेक 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 थोड़ा ऊपर जाओ.
So what are you doing right now, sir?
No, I'm just showing you the drug in the और ऊपर जाना है ऊपर जा. I'm just showing you the catheter and drug spread in the lateral view. L4-5 level पे दिखाओ. हाँ. So this is the dye which you can see, and the catheter also you can see it lying in the epidural space.
Yes, catheter we can see.
You can see it. You can see. Right? So we have, you can see the four.
Catheter seems to be in L3-4 space.
Yes, L3-4 space. So that was the target, and you can see the 4 and 5 and S1. All. Right?
Right, sir.
Thank you.
Thank you, sir.
Thank you
Any
very
questions? If not, thank you so much, sir.
Thank you.
You can come down for lunch.
Okay.
One more case. कौन सा case? नहीं इसी उनके या उसमें को अच्छा we shift to OT2. We shift to OT2.
Yes, sir. OT2 you are connected. Pawan ji, सको माइक लगाओ स्वानी सर को.
Dr. Ashish. Dr. Ashish.
Yeah. Hi.
हाँ.
ऐसा है लगाओ.
Yes, Ashish.
Yeah, hi, Deepak. So we are taking up this patient who has low back pain with spread to both the lower limbs, left more than right. And there's an element of claudication as well.
Right.
So if you can show this, there is ligamentum flavum hypertrophy at L4-5 level with bilateral lateral recess.
Can you zoom in more?
Zoom kar denge. So there is an element of lateral recess, again left more than right.
Right.
Okay, and on यत् केवल महोदय
पूछ लेते हैं. हाँ, there is a question for you. Ashish? Yes, Ashish, question for you. Can you hear me? Hello? OT2 में रखना जरा, OT2.
Sir, OT2 connected, sir. Yeah, hi Deepak.
Ashish, the question was that if some inadvertently if you puncture the dura, do you
हेलो राजेश सर, कोई कैंप माइक लगा दो राजेश सर, कोई डॉक्टर हो तो.
OT1 में शिफ्ट कर लें?
यस सर.
और उसका लेबल OT1 के मैं OT2 लगा देना, बिकॉज वो केस OT2 का था. जो भी केस नंबर है और OT2 लिख देना उसमें.
अभी ये नेक्स्ट होने वाला है सर.
ये जो नेक्स्ट ईयर है ना,
ओके सर,
उसमें अब OT2 लिखना, बिकॉज वो कंफ्यूजन हो जाएगा.
ओके सर, ओके.
दिखाना था. Is it transmitting?
No, we are not able to see anything. Shift to
ट्रांसमिट तो नहीं हो रहा.
हाँ.
Yes, audio connected sir.
Dr. Deepak, are you listening to me?
Yes, yes.
Camera focus.
Can we turn the mic off?
Yes, absolutely. Can we discuss the patient? Minder? Puranjay?
हाँ जी सर, सुन रहे हैं आपको.
हाँ.
So I have a case. Brief clinical history is to be given by my. So they're preparing the one, but I have evaluated the case. Patient is a 46-year-old female. She had operation for IDEM at D6 7 years back, and then she had some lytic lesion at C2, which is ill-defined. I did not find her proper bony cuts for the CT scan, but according to the patient, she said that this has remained the same for last 6-7 years.
Sir, please show me slide, full slide.
Slide show कर दो.
On the mic.
Puranjay?
You want? Yeah, so as we were saying that previously operated for D6 IDM and pain is now there. Where's the patient's file? I've written the history again with my hands also.
Okay, continue. Minder?
Yes, sir.
Continue.
Yeah, no, because there is a disparity between the history that is written here and what I have taken. So that's why I am wanting the file of the patient. And we also have to do properly position the patient before I do it. Because, no, the last page. Yeah, because you're saying it's 4 or 5 months of pain, but to me she said there's occipital neuralgia for last 4 years. And sometimes it becomes so severe that she's not even able to talk. Visual analog score is 7, but 5 days a week it goes up to VAS 10. She also has got left-sided C6 dermatomal pain, where the VAS is 7.
Okay.
So I'm trying to do 2 blocks. One is the greater occipital nerve block. I have examined the patient. She only has got tenderness at greater occipital nerve on the left side. And this pain also goes and triggers the supraorbital nerves. So when I'll do my presentation, I'll tell you why this happens, and the pain also causes a trigger deep inside the throat as well. So because C2, C3 and the descending nucleus of fifth nerve, they communicate, and the pain in the deep throat and the facial pain, they unite together. So trigger can be reciprocal. If patient has got a pain in the occipital region, then pain can go into face or into the deep throat. And I have taken the video of the patient as well, that she said that the pain goes from here and goes up to here. So which is classical C2, C3 distribution. One more thing that I would like to do, that she has got a pain which is spreading here, and there are some peripheral blocks which can be given even for a central neck pain, both in the upper limbs and lower limbs. So if I press between the fifth and the metatarsals here, then the pain radiates up to the neck. In this case, it's going up to the elbow. So I'm planning a deep block here, which will be diluted xylocaine, but it goes up to the dorsal root ganglion and can relieve the pain. I have several videos of such patients, so I'll be discussing them when I have my presentation. So right now we will have a patient. I will do a left-sided greater occipital nerve block and a peripheral C6 block.
Is there anything to see on the imaging in this case?
Imaging I do not find, because I had the films. I always prefer DICOM images on my laptop so that we can zoom them. Is there an axial for?
But is there any thickening of the outside?
Yeah, so you can see that C2 has got a thickening and the canal is severely low here.
Yes.
But this is not a bony window. Of course, there is but then suddenly here it's normal caliber. So, yes. And then here also, if you see, there is some lytic lesion going on. Patient says that this lesion has been there for many years and it is not changed with serial investigation. So I don't know if the radionuclide scanning or something was done, because that's no record over here.
Okay.
Although if such a patient with such a canal at C2, because C2 is one of the widest canals, why it is so tight here? And then I would also be questioning as if I do a block, how long is going to sustain? Because when I'm doing primary migraine cases, I am getting relief for up to 6 to 8 months. And we started in last year when we started with auriculotemporal neuralgia. And since then, we have now done 93 cases of blocks. And I have got patients relief up to 1 year. So I could do only one surgery because patients with nerve blocks are getting such wonderful results. But in such a case, first of all, I'm not finding that patient has got any long tract signs. She is able to walk.
Right.
So in this case, actually, she should be actually having a lot of ataxias. So those things are not happening. So I think more investigation should be done. And in such cases, first of all, if I have to evaluate, I want DICOM images on my laptop. I have my own Radiant software, and I go deep into that so that we can see in 3 axes as what's going on with this.
So your plan is.
So right now,
has she got any stigmata of CVJ? I mean, a short neck or any?
No. She
nothing like that.
She has a long neck.
So sorry, your plan is.
So right now, she only has got pain on left-sided greater occipital nerve. Pain, severe neuralgia is there. So I'm doing a GON block on left side.
On the left side, sorry, you're doing a
greater occipital
nerve block.
And on left side, I'm doing a C6 peripheral block.
C6.
Yeah, it has not been discussed.
Right, right. The one you were saying in the anatomical snuff box.
Yeah, anatomical snuff.
Not anatomical, yes.
Yeah.
Yes.
So if you press here, the patient has got a C6 problem, the pain goes directly up to neck. In her case, it's going up to elbow. But this is variable. During my presentation, I will show you such cases where if many times in severe cases, you press a patient at the sural nerve and patient gets a pain all the way up to the neck. So whole spine pain can be there. So these are peripheral nerve blocks which are also used for central discs.
All right.
Yeah. And so I'll pause my mic for a while so that I can give instructions here.
Okay, okay. We can have the OT view so that we know what's happening. Can you focus on the patient? Yes, sir. Greater, sir. Yes, sir. Very easy, sir. We have done that. Those who had not had the lunch, please have the lunch because we're running a little late. So we'll start as soon as this OT finishes. We'll start with the talks. Okay. So here you can see for the positioning of the patient, we just have a pillow at the head end and we have a bolster at the abdominal chest end. There is nothing else.
So occipital blocks, hello, am I audible?
Yes, yes, you are fully audible.
Occipital blocks are, all headache blocks are done in OPD setups. We do not need sterile room for that. And even the peripheral nerve blocks can be done in the theater setup. Are you able to see my laptop?
Yes,
Projection?
yes, 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 very nice.
Yeah, so there is a greater occipital nerve which is 2.5 centimeters from the external occipital protuberance. But usually I don't go for measurement because they can be slightly here and there. The lesser occipital nerve is 5 centimeters from the midline. But as I'll show you in my presentation that we always go with clinical, I press certain points from where these nerves are coming and patient tells us that yes, my pain, this is exactly my pain. You are reproducing my pain. And then this pain sometimes refers to, like in her case, this pain is also going into her ear, inside the ear. So there is a sensory branch of the facial nerve. So she is having referred pain in the ear, having referred pain in the left eye as well. In advanced cases, many times you have seen that patient also complains of pain going into the face from these headaches. So we will just make this patient sit on a chair so that she can bend forward and we can palpate her bony landmarks and then we can do. Otherwise, the simple thing is palpate the external occipital protuberance and the mastoid, and 1/3 of medial and 1/3 lateral are the locations of the greater and lesser occipital nerves.
So you said that 1/3 lateral and 1/3 medial, meaning?
Yeah. So say this is the. Are you seeing my arrow?
Yes, yes, yeah.
So from here to here, from the mastoid process,
Right.
you know, this is 1/3 and then 2/3. At 1/3 of this distance,
Okay, 1/3 of
greater occipital nerve.
1/3 from the greater occipital protuberance.
Yeah. And then 2/3 will be the lesser occipital nerve. You get me?
But it is the point of injection
Point
that
of
we
injection will
understood.
be here. In her case, this will be only here because she is not having pain in
At a line which is parallel to the greater occipital protuberance.
Yes. So you see here there is this nuchal line.
Yes,
Inferior nuchal line. There will be a depression. You will feel that, and when we press, the direction of your pressure is mostly 45 degrees, and that's where the patient feels severe pain.
Okay.
Because the idea is always to reproduce a pain, any patient's pain. So, and then we did it nicely. I have also done a video recording of that, which we can show. But
so today, Dr. Mahendra, you will be showing in prone position, or you can?
no, sitting position is
Sitting
okay.
only.
Yeah. Sitting is okay. We don't need, so just a chair is required. Basically, it's not even a theater procedure.
Okay.
And that's why, you know, the beauty of these headache blocks is that you can do it in, you can do many cases in a single day. Patient gets a fantastic relief and a long-term relief. And I've got so many happy patients now. So, and you can do it all within 10-15 minutes. So,
Very
rewarding procedures.
Correct.
Can we make a sit there quickly? I wish we had more migraine cases where then, because now I don't want to push several points and they are not very difficult. The thing is that, you know, for a neurosurgeon's caliber, these cases are too simple cases and we don't want to do them.
No, definitely. I think this is the first time we are having this workshop, so we try to get different variety of. Next time we'll have more cases for you.
Hospital nerve is one of the most common trigger points, and this trigger point in her case can be handled later on if we don't know right now what kind of pain relief she will get, what duration, because there is some problem deep inside. Then we can either go for a neurolysis or we can go for ganglionotomy or ganglionectomy at C2. So,
And what do you inject?
So injected, we are using usually Xylocaine 2%, but Xylocaine with adrenaline usually is very acidic. So I use for, say, if I am using 10 ml, 10 cc, though she doesn't require, she requires only 3 ml. So 9:1 ratio, we also use soda bicarb, 8.5%. So in this case, I would be using maybe 3 cc of Xylocaine, 0.5 to 1 cc of bupivacaine, and Xylocard and steroid also, Kenacort or Triamcinolone, whatever it is.
Sorry, can you repeat? So for this case, you will be 3 ml of
3 ml Xylocaine.
3 ml Xylocaine.
0.5 cc of bupivacaine.
Bupivacaine.
Yeah. Then 0.5 cc of soda bicarb.
0.5 cc of soda bicarb.
Triamcinolone.
And triamcinolone.
Triamcinolone, yeah.
Okay. All these 4 drugs you mix together.
Yeah, we mix together.
So logic for using soda bicarb is to make it alkaline.
No, if anyone has injected himself Xylocaine, any experience? I did once for my viral wart and I got such a severe pain, and then I researched about it. If you slightly warm Xylocaine, then it becomes painless. That's one thing. Second thing is you can mix soda bicarb, so it neutralizes the severely acidic Xylocaine with epinephrine. And there are papers for that.
Okay.
Yeah. Okay, so let me prepare.
Sure.
Can we have gloves? Okay. आराम से हो आप, इतना कुछ लगाने की जरूरत नहीं थी वैसे. थोड़ा सा नीचे करेंगे सिर को. कितना नीचे कर सकते हैं? Gloves? Yeah. What about mixing? Yeah, just prepare.
So Mahendra, you already prepared your this cocktail?
No, we've not. Because you started ragging me.
No. Some resident can start preparing it.
Yeah, I just said. So just like 5 cc. We don't need. I need spirit swab also. Do we have a marker pen? Marker pen. Not required. Not required.
Mahendra, there's a comment in the group that few studies use ascorbic acid. Are you aware?
No.
No.
But soda bicarb is anyways handily available.
Yes, that is true.
Yeah. So where's the marker pen?
So this you are marking the external occipitary protuberance.
Yeah.
And we are doing on the left side.
On the left side.
Right.
Left side ही पेन है आपका.
Always better to reconfirm.
So in Kenya, usually we are lucky because the most of the patients do not have enough hair. So if we,
The second point is mastoid, right?
Yeah. Second point is mastoid. So if you see here, this is coming to be 1/3.
Right.
But then there may be anatomical variations, and this is the 2/3. So this point and this point, yeah.
So
are you able to see that?
Yes, at the level of the superior nuchal line you will make.
Yeah. So I'll press.
अच्छा, you'll press and see the trigger point.
यही है दर्द. आप बताओ कहाँ पर दर्द हो रहा है? जोर से बोलना. यही हो रहा है ना? और ये दर्द आपका आगे आंख में भी जा रहा है. कभी कभी आपने बोला कि आंख में भी जाता है पेन. कभी कभी जाता है ना. अभी दबा रहा हूं तो कान में अभी नहीं हो रहा. नीचे हो रहा था. एग्जाम जैसा हो गया. थोड़ी देर पहले भी हो रहा था. ठीक है. और अभी आपने बोला कि आपको 7 का वो है ना. अभी आपको जो मैंने स्केल बताया था उसमें आपको 10 में से 7 हो रहा है अभी पेन. ठीक है. स्पिरिट स्वैप. Yeah, did we make a mix? Xylocard है 3 cc ले लीजिए. एक सेपरेट प्रिपेयर करना है Xylocard ओनली. हाँ 2 cc and 2 cc distilled water. So one of the peripheral block which I was saying about her C6 is because in the dorsal root ganglion there are pseudo bipolar neurons. Pseudo bipolar neurons.
Right.
And so if patient has got pain because of a toxic annular tear or because of some compression, the pain is going centrally and is also coming peripherally, which is perceived as pain in the local dermatome. If you block those peripheral nerve endings, it has got a soothing effect in the central nervous system also because of this nature of pseudo bipolar neurons.
Okay.
So it gives a wonderful relief to the patients even with symptomatic disc compression. Particularly if you are seeing some, something called as chemical neuritis, which comes because of toxic annular tears, and the nucleus is releasing toxic chemicals like interleukins. Yeah, we are ready? This is what I wanted, yeah. Do we have triamcinolone also? Or even dexamethasone can do. Any steroid will be okay. Triamcinolone sometimes just becomes, we are using triamcinolone though, we can use that. So with the peripheral block with significant operable disc, I have found patients having a pain relief from few days to up to 6 months.
Okay.
Yeah. Recently, I will show you a video of a patient who I did about 6 months back. She was not even able to walk, but once we did that, she has all gone for Hajj. And she says these are magic injections because I am doing injections in the ankle region, and patient is having, she becomes pain free in the low back, and the radiating pain also goes.
Nice, nice.
Yeah, are we ready?
So Mahendra, what are we waiting for here right now?
We are waiting with the drug.
Achha, the drug combination.
This is what? इसको भी दूर रखो. What is this? Triamcinolone. इसी में mix करो. इसी में mix करो. Triamcinolone दे दो.
So your thumb is actually at the superior nuchal line, or at the trigger point.
Just, yeah, at the trigger point. So I would only loosely follow the landmarks here, because most important thing is always you can have a third occipital nerve, you can have a greater occipital nerve, lateral occipital nerve. So all of these things we can find, but then the trigger sometimes can also be myofascial. So we have to know which is the trigger point. In chronic cases of headache, usually because there is a free anastomosis between the lateral, the frontal and the posterior nerves, patient gets pain almost everywhere. So I have got headache patients, 24 years of daily headache, devastated life only because of headache. And we were able to give her 80% relief only with the first set of injection. But gradually they come down to the trigger point. So in such chronic cases, if you are doing an injection and you are doing a block, then initially we tell them that you have to now notice all these trigger points you know. Now you have to tell me when headache starts, from where does it start? Yeah, thank you.
Okay.
Okay. The bevel should always face the scale, yeah? So we know how much we injected. यहीं दर्द है ना आपको? है ना मीना जी? यहीं दर्द है ना आपको? ये सही जगह? क्या भी दर्द चला गया? चला गया? एम्स की कृपा है. फिर से चेक कर लेते हैं. ये वाला, ये वाला स्पिरिट अगेन. लगेगा. So I'll go to about, we'll aspirate about would like to infiltrate the subcutaneous space, and I can feel a bulge going around.
So do you touch the bone and then give it, or you just come given this?
No. I am just putting my finger on the trigger point so I don't lose it.
No, what I mean to say is that needle where you're injecting,
yeah,
does it go right up to the bone?
Yeah, you can go to that. You go all the way to the bone, then you come back side.
Right.
Yeah. We will wait for a while. Now that
in her case there was only one trigger point, right?
Yeah, only one trigger point. आपके दर्द को वहां पे आराम मिल रहा है? अभी कुछ फर्क पड़ रहा है कि दर्द ही नहीं हो रहा है? एक आपको यहां पर लगाएंगे, ठीक है? So you go where the two metatarsals meet, you go more on the index finger side.
Right.
Okay.
Right.
Yeah.
How deep?
But here you have to go around up to 0.75 or half of the needle, because you have to go almost to the metatarsal.
Again you touch bone here? No.
No, here we don't touch bone. And here it has to be diluted xylocaine.
Can you again just say the entry point?
It's very rough. There is no fixed point here. You just go there, because the idea is wherever the two metatarsals meet on the medial side of the second metatarsal, you have to go here.
Okay. And here you are just giving pure xylocaine.
Yeah, diluted xylocaine, not our own xylocaine, but diluted xylocaine does the good job here. Because right now patient is in a certain psyche that she anyways feel just because of touch that there is.
Sorry?
She says that anyways even before injection she was pain free.
She had got relief.
Yeah.
That's a sign of a good doctor. Any questions?
Yeah.
For occipital nerve block and peripheral nerve block?
Although I am going to cover into my presentation, which is at 4, so we are going at length with the headache blocks, even the peripheral blocks.
Thank you, Dr. Mahendra. That was excellent. Thank you so much. तो OT बंद करवा दो.
कैसा लग रहा है?
हाँ. Yours is first. You're loaded है. Schedule.
SI joint blocks for demonstration.
SI joint to maybe tomorrow. I'm not sure. I will check and let you know.
Right.
Do we have Greja Prasad here? No. Dr. Mahapatra is here? No. So, I will request, we have some very interesting talks. I would request the speakers to please limit themselves to the time allotted. The first talk will be by Dr. Debesh Bhoi, which will be on transforaminal epidural steroid injection. Okay, good afternoon. Thank you very much for the invitation. Thank you very much, Dr. Deepak sir, for the introduction. So my topic given to me is regarding the transforaminal epidural steroid injection. And since morning, I think we've already seen the many injections, that is the transforaminal epidural steroid injections, facet injection and all. So we'll just discuss about the technique and how basically executing this transforaminal injections in a patient with a back pain or a disc herniation. See, if you consider, obviously, it is the lumbar radicular pain or radiculopathy is it is very commonly encountered complaint, and most of the thing that the patient goes to a neurosurgeon, a neurologist, a orthopedician, pain physician. So the patient's load, if it's the low back leg incidence is very high. So obviously somehow the patient has multiple types of pathology that leads to a low back leg. And one of the things is that the herniated disc, or because of the phenomenal stenosis, is one of the most common cause that lead to basically inflammation or irritation of the spinal nerves or the dorsal root ganglia. So the disc herniation basically causes something, changes in that area that causes pain. So why there is pain basically? Is it only the compression alone that does cause the pain or something else? Because if you've seen, because suppose a surgery has gone, the patient normally suppose disc surgery and all, in the post-operative most of the numbness or something is there, not like the pain. So if in this disc herniation basically, it's not only the compression, it's only the inflammatory reaction that is going on around the nerve roots. So the highly inflammatory material that is present in the nucleus pulposus, basically with the first layer is A2 or nitric oxide metal proteases. So when there is disc is disrupted, this material that is there just come out of there and deposited around the neural structures, and they just elicit a neural or chemical inflammation that leads to pain or intense pain. And if it is going along the nerve root, that becomes a radicular pain in the patients. Intramyocardial corticosteroid, so the patient when they go for the conservative treatment, then obviously the patient is offered the interlaminar corticosteroid, and if it's the interlaminar corticosteroid means the steroid is deposited in the dorsal part of the epidural space, or the posterior part. That sometimes fails to reach the segmental nerve radius, because if you see the disc is the more ventrally, and obviously the herniation that is coming and involving, that is the more ventral part. So if a drug is deposited in the posterior part, sometimes the drug may not reach to the target area. And if a nerve is getting irritated, it's ideal to deposit the drug close to the nerve. So that's why, in this case, the transforaminal corticosteroid injection is done. So that the drug should be very much close to the involved nerve root. And so obviously the indication is any pain that is radicular in origin, it's from the irritations and the inflammation of the DRG and other neural structures. If you see the irritation, once there is inflammation in this, in the foraminal area, you can see the nerve root is getting affected. And this is the area that basically we want our drug to reach. So if you see the drug is, this material is herniated out from here, and it involves a chemical inflammation at this area. So our just motto is to reach the drug at this part. Even if you see the lumbar epidural of this disc, in the case of disc herniation also is a very good level of evidence in case of transforaminal injection in such cases as a conservative treatment, the first before at least in the surgery. In MRI also you can see before, so you can see the different your hernial disc is bulges there involving the transversing root and exiting nerve root. If you see there's the disc bulges there, and obviously this is the area where the DRG is getting compressed sometimes. In this case it is just a disc is bulged. So that means even if you see it is not causing a mechanical compression, but still the disc has the hydration is lost. That means the normal disc, if you see the annual purposes is white, but in this case it is black. That means the disc desiccation and the disc is bulged. So that causes inflammation. So even if there is the significant compression is not there, but still there is a chemical inflammation that is irritating the nerve and the DRG. So the traversing roots is also in this case free, but that is the area that the lateral recess and exiting root area that your disc material can involve, and that causes inflammation.
In this case, if you see in the left side, you can see a significant disc bulge is there, a disc herniation is there, just irritating the nerve. That if you, in this case, if you are finding such cases in my brain clinic, obviously we can post this patient as transforaminal steroid injection. If you see it may not be a significant caudal compression or thecal compressions, that is, the patient doesn't have any, but the pain is very severe. So the patient in this area, the fit is the criteria that you might go for a transforaminal injection, and patient will very good relief in this case. So before patient will have subsequently cauda or some other involvement. So let us see the technical part basically. How basically you can execute or reach this part, if you say on middle or in this case. So if you see the foraminal part, if you see from lateral side, you can see this is the formed by the pedicle, above one, the upper one, and the middle one, down one in this case. Then the posterior you can see the supraarticular process and infraarticular process above and superior below. And also in the front side you can see the lower body and the disc in the front. This is the area you can see your nerves exiting route is there, and this part is occupied, or if the disc is herniating, that part is involved, and that is where you are going to reach. So what is the content of the this foramen basically? It's not only the root and this there. Along with the root, it's also there the vein, the fat tissue is there, and the artery or some reticular arteries are also there in this case. That's why sometimes it is very, you have to be very cautious when giving the transforaminal injection. If you have to be very careful not to injure any artery, or if you are using a steroid, a particular steroid, make sure the drug should not go enter into your artery or clogging your blood vessels. So next is how to proceed in this case. Any procedure is obviously the informed consent is very important in the patient who is undergoing a transforaminal injection, because the injection or needle is very close to the nerve. So obviously the patient should be aware of that. There might be nerve injury, sometimes patient has pain. So you are putting a needle close enough, suppose the patient moves or something, the inadvertent needle is inside, then nerve injuries might occur. You are depositing steroids. So there are so many steroids are available. That is the particulate, non-particulate. So there are also complications related to the steroid also. Obviously then infection is another chance that if you are not take the proper asepsis. The checklist must be, obviously you can take the history of allergy, because you are also using a local anesthetic for the skin infiltration, for also the drug. Coagulation studies sometimes very important if the patient is having some blood thinners like antiplatelet or anticoagulant. In that case, you have to strictly follow the guidelines as per your American Society of Regional Anesthesia or pain intervention, and also there is single society that have given the guidelines that the drug should be stopped as per your standard guideline. In some cases, the patient has suppose cardiac origin and taking some medication, then obviously you take the physician opinion also regarding the stoppage of the medications in those cases. Is there any contraindication? Yes, obviously the uncooperative patient, sometimes it's difficult, you might abandon if this patient is not cooperative properly, because normally you don't go for a general anesthesia for such injections. Bleeding diathesis, coagulation or abnormalities, local set infections. There might be some of the relative contraindications, sometimes technically difficulty if the patient has had severe degenerative disease or a large disc displacement, or sometimes a facet hypertrophy. So the needle steering might be sometimes difficult in those cases. So let's come to the fluoranatomy. Obviously, I think the injection has been very well described by Dr. Ashish and I think the researcher. So let us again just revise this how fluoranatomy that normally in this case we see for or look for. The first thing that we are going to do of step one is the true AP view of the total body. And the lower, and in this case in the injections we do a squaring of the plate, that is the lower end plate squaring. That means this is the first is the true AP, means that it's maintain the symmetricity, that both the pedicle is equidistant from the midline. That the first, that is true AP we are going to do. Then we are going to look for your inferior end plate squaring. That means it should be, if it is not squared along that, it might be in the oval shape. So you make it one line so that the inferior end plate is properly square. Then you can look for the circular shadow on the lateral side, the other pedicle, that gives a shadow like this, and obviously there faintly you can see the transverse process. So this is the area that we are going to see for. Now once you do AP view, then subsequent second injection is once you mark which nerve we are targeting. Depending on that, then you go for ipsilateral oblique. So the same side you are doing now, or the patient is going to have this oblique in this case. So what I going to see in this case once you do oblique. So in this case, we normally a very good description of the Scotty dog. That means if you make image like this, you can identify basically different structures accordingly if the anatomy is good enough. So if the superior articular facet can be identified as your ear of the top, transverse process which is node, and the eye that normally the Dr. Dureja also described as a medial branch or the medial nerve. Pedicule you can see that infra-articular facet of the hand is forelimb, and hind limb is the ear pars. So this basically we make this image first so that we can identify which type of injection we are going to do it. And the transforaminal injection, the injection area is normally just below the mouth of that area. Now let's come to the ones who identify this. There are the different approaches. So what are the different approaches for the transforaminal injections? If you know, there are normally 3 approaches. There is one a safe triangle approach, a supramural approach. That means the injection is above that. Retromural and the inframural or Camden's triangle approach. So if in this case you see, once you do a gauge open like this and the nerve root in this foramen, you can see the first is the subpedicule, just below the pedicule, that is above your nerve root, that is the supramural injections. Second is the retromural, it's just the needle is just on the posterior side of the nerve, that's the retromural injections, and the lower one is the retrodiscal or supramural or inframural injection. So these are basically 3 approaches we do normally for transforaminal drug deposition in this case. So let's come to the safe triangle. It is a misnomer, it is not really a safe triangle, but still the name per se, how the safe triangle is made, or normally in this case made. If you see in that approach, one line is going to the subpedicular line, the one line parallel line, another line in the lateral border of your pedicule, that is one line, and the hypotenuse angle is formed by the nerve root itself. So this triangle, once it is formed, this is go at this 6 o'clock position of the pedicule. That normally our target point for a transforaminal injection. So once your Scotty dog appearance, we make this triangle and then go just exactly at the 6 o'clock position of this pedicule. That is a safe triangle approach in this case. So in this case, basically you are not injuring or try to avoid it from the nerve root. That's why it is a safe. But this is again, if you are not vigilant, this is the area that the blood vessels are there. So that's why it is not really safe in sometimes if you are not taking precautions in this case. Second is the Camden's triangle. Obviously, it is a inframural in this case. You can see the disc is there. So the medial border is formed by the vertebral end, then the vertebral border. Then the lower again over the pedicular line, and there's another your hypotenuse third border is formed by the nerve root itself. So this is basically the same approach you normally would do for your disc injection, something like that. The same exactly this position is done for the disc injection or any disc procedure is done. So that's why this approach sometimes has the risk of entering the disc in these cases. So this in this case, this is yes, sir. So again, I just regard the safety concern because there are so many blood vessels under your medullary arteries there in this case, so that's why it is a little bit riskier. And one of these your artery of identification, the radicular anterior radicular medullary artery. That's normally if it is injured, that may cause hematoma, or sometimes here the steroid is entered. In this case, that may lead to infarction that is very grave, may lead to paraplegia in such cases. So needle entry, obviously, as I described, look at the 6 o'clock position. You can see the Scotty dog at the just below the head. That's the entry point in this case. And this, once you're in the epi view, you can see the needle. Then you confirm your needle in the lateral view. Once it's in the lateral view, you can see the needle position in the foramen. You can see the needle is exactly in the superior, dorsal superior part of the foramen. That is your if you're doing a safe triangle approach. So once you do that, then you can see. Look for the dye and then look for the dye spread in this case. So the final deposition like that. In case of a Camden's triangle, this is the supraarticular process, and in this case, a middle entry just retrodiscal and just lateral to the supraarticular process in this case. So this is the entry point, just right or lateral to the supraarticular process in this case. So here basically we are entering the lower part of the foramen. This is that is the infraneural, and mostly the sometimes if you are doing an infraneural injection, it also involves the traversing routes also. So that the supraneural is mostly involving your exiting route. So another again, sometimes you do a weevil is little bend, so there is sometimes if there is less space, and some little steering also help in this case. Just hitting the transverse process in the pedicule and just steer towards your foramen. You have to be very careful because sometimes the patient might be jump hitting injection, the immediately you drop because you might be hitting the nerve root in that case. So that to avoid any sort of movement or any case of abuses. Next, the dye spread is very important. Once you finally position, you can, after putting the dye, look, the dye should be spread around the medial border of the pedicle, and if you just look for the volume, how much you need for that sitting at the medial skin, and also the drug is going to the epidural space. If you give more volume, obviously the epidural space will spread will be there. So this is the ideal spread of the drug. So is there any other spread that can be, you have to be careful obviously, because in this case DSA is there, so you can see around the medial side of the pedicle this drug is spread. There might be some of the aberrant spread also, suppose the arterial spread or a venous septic. In this case, if you see the drug is midline to the AP view, like this is the arterial spread. Sometimes if you are doing an extradural, a disc is there in the foramen, that is the actual disc is there. So that might sometimes you can take a picture of like this. That means the very significant disc material that has been extruded in this case, and the dye spread is going to the disc also. So this type of spread sometimes you can see also. Subdurals, obviously in this again there is a chance by the subdural dye spread also. In this case the dye is more stick appearance like this in the posterior side. The homogeneous spread, in case of epidural spread there will be air pockets will be there, but in this case it is a homogeneous posterior in this case. If the intrathecal spread, you can see the intraneural injection has been occurred in this case. You can see the ventral thecal site in this case like this. Okay, yes. Again, once you depot the drug, might be obviously selection depending on this. This dexamethasone is very safe because it is a non-particulate steroid in this case. Recovery obviously up to recurrence. Most, if you are using a local anesthetic, most of the patients recover well. If not, then obviously you have to look on the diagnosis. Here the complication that is very important because the paraplegia has been documented through case reports in this case, but it's not only the particular steroid. Sometimes even the severe disc compression is there. Even slightest transforaminal drug deposition might sometimes aggravate the situation, and in this case, even if there is no infarction, this is basically the patient also land up in paraplegia. So they basically have to be careful. So obviously the summary to transforaminal, this is again you can think of this transforaminal injection before going for surgical intervention as a very good treatment modality in such cases. Thank you. Sorry for that.
I think time is up, so we have no time for question and answer. I think next talk is by Dr. Dureja. Dr. Dureja is there? Yeah. If you finish early, then we have a question.
I will. 5 minutes. I've spoken enough now. So can we have the slide, please? Yeah. So I'll be talking about another important pathology, cervical facetal pain, and this is often a underdiagnosed cause of neck pain. I mean, we have a large number of population who is suffering from this because of injuries or because of other reasons, but generally it is underdiagnosed. And if you have patients with chronic cervical pain, almost 50 to 55% of patients may be suffering from this facetogenic pain. And of course, in our younger population, it is a major source of pain and disability and even socio-economic impact because they are not able to work sitting on a computer or other things. The anatomy, of course, all of you know that this is the joint supplied by nerve from below, nerve from above, as we were discussing. This is the branch from the dorsal ramus, and the joint has a capsule. Joint has a synovium, so there is a synovial fluid too. Sometimes when you have a facet arthropathy, you can withdraw fluid, and there is an effusion, and just decompressing the joint gives a fantastic relief to the patients. And if it is persisting, then we knock off the nerves. As you can see, you are doing a radiofrequency ablation of one above and one below. So, of course, I am not going into the detail, but this is the anatomy, that this is a joint from the superior and inferior, like we showed you in the live workshop. It's a synovial joint which has a capsule. So you should not be, the importance of this is that it's a very thin capsule. So intra-articular injections, repeated, should be avoided because you are disrupting the capsule. So median branch block would be a better option than repeatedly puncturing the capsule and causing injury and making the joint unstable. So it contains, the function of these joints is of course flexion and extension, and while limiting the rotation and preventing the vertebra from slipping over each other. The sensory nerve is the medial branch from the dorsal spinous rami. The typical presentation of a cervical facet joint is an axial neck pain. Patient will come and tell you that I get pain in this part of the neck. You ask him, it's radiating down? No, not much radiation, not radiation. Unilateral sometimes, very rarely bilateral. But of course, there is a limitation of extension. He says, as soon as I do this, I get a very sharp pain. And when I rotate my neck, also I get a very sharp pain. If you examine the patient, you may not find much except that if you are right on the facet joint, you may elicit a tenderness. And of course, whiplash injuries, sudden injuries in the cars, and various other sports injuries can result in this. So it's an ipsilateral axial neck pain, dull pain, but the sharpness is only on movement. There is a referral pattern too, because the nerve supplies some areas. So I'll show you that C1, C2, C2, C3 can come up right in the ophthalmic, the occipital division of the nerve, and there are C4, C5 can even go up to the scapula. Secondary to trauma, sometimes we do not know, maybe bad posture, using big pillows can also lead to this. Typical morning stiffness, they get up with a very stiff neck, and they are very much worried because in the morning the neck is so stiff that they don't feel like getting up from the bed. And of course, extension and rotation results in more pain, and there are no neurological deficits, absolutely no neurological deficits. So this you can see is a normal facet joint, and this is a diseased facet joint. We have osteoarthritis and various other reasons which could be cause of this degeneration of the facet joint, generally seen in elderly patients, like the arthritis of every joint. You can have misuse arthritis of this joint. Secondary to trauma, sports injuries, whiplash injuries. Secondary to inflammatory conditions, yes, we do get a lot of patients of rheumatoid arthritis and ankylosing spondylitis who keep complaining of pain in the one side of the neck, and that is because of the inflammation of the synovium. So this is more of an inflammatory. So in these conditions, probably an intra-articular injection of steroids would be better off than doing a medial branch block, because this is going to come again and again. And subluxation of facet joints due to spondylolisthesis is also one of the rarer causes. The pathophysiology, of course, the inflamed facet joint, the surrounding muscles go into a spasm, so it's a muscle spasm pain. Hypertrophy over a period of time can itself cause pain. Thickening of the capsule again can result in pain. And then degeneration, osteophyte formation, rubbing against each other, they can also be the cause of pain. So these are some of the pathophysiological factors of cervical facet chain. It's often a clinical diagnosis. You may do MRIs, CTs, perhaps CT may give you some clue, or a bone scan can give you some clue, but who is going to get a bone scan for a neck pain? Typically non-radicular, as I mentioned, worse in the morning or during periods of inactivity. So you can see that painful extension and lateral rotation of the neck is generally the provocation for more pain, and if you do the simple test, you will find that the pain aggravates. Now this is what I was talking about the referral pattern, and you may have the pain referred to C2, C3 from the C2, C3 facet joints, C3, C4 side of the neck, the commonest presentation. C4, 5 can even go down to up to the scapula, and C6, C7 facetal pain can go right below the scapula too, and this is the area of C5, C6. So if you clearly take the history, they will tell you that it is referred. Never on the trapezius or never on the shoulder like a radicular pain, but it is basically around the spine, so paraspinal areas where this referral pattern is seen, and by this referral pattern itself you can localize which particular facet joint has been involved. So that's the importance of a good history and good physical examination to come to a diagnosis, so that you confirm it by doing a dorsal branch or the medial branch of this particular. These are some of the morning we had discussed: differential diagnosis, myofascial pain syndrome, cervical radicular pain, cervical disc degeneration, and of course injuries. Clinical diagnosis: MRIs do not give any information unless there is a very severe arthropathy or fluid. Diagnostic medial branch is one of the gold standard approach to diagnose this. A simple test, I think tomorrow maybe we'll try to show you live, and you have to do 2 diagnostic blocks in order to go for a radio frequency at different intervals, and if both the 2 diagnostic blocks are positive, then you go for a radio frequency ablation. So we are now even doing radio frequencies, of course, one regenerative therapies. So if it's like and spondyloarthropathy, you can inject PRP solution into the facet joint, which is a regenerative therapy and really can help these patients. You should be aware of the anatomy. So this is what you get after squaring, and these are some of the structure. This is the facet joint. This is the articular pillar, which we have to target. This is the place where the dorsal rami would be seen, and you have to target that. So important to see the structure, the facet joint, the lateral mass, the lamina, the spinous process, and this particular the articular pillar is the most important thing when you have to place your needle for radiofrequency ablation. This is a facetal joint injection. As you can see, the spread of the dye in the facet joints, and this is the place where you are going to do a diagnostic. So you right in the middle of the articular pillar, you will place your needle, and remember you have to give very low quantity of local anesthetic. You don't have to give a high volume, one that it spreads to the root, which are very close. The root is just around. So you don't want to call it a root block, because there will be some motor loss and sensory loss, and in any case you will not be able to know whether it is pain relief because of the diagnostic branch or something else. So that is to be avoided. And then you do a radio frequency ablation. This would be the exact position of putting your radio frequency cannula. Do the stimulation as we saw in the morning. We do the stimulation, sensory stimulation up to 0.5 millivolt, 0.5 volt. If you don't get a stimulation in the arm, etc., that is a confirmed position. Motor, you will see the fasciculation in the muscles. And then you can do at different levels. This is the AP view, and this is the lateral view, where you are putting the needles on the middle branches, and then doing a radio frequency ablation. Thank you. Finished in 8 minutes. 7 minutes.
Question now question. Okay. Before you ablation, do you have a small stimulus to confirm it? No?
Yes.
So
always sensory and motor both. So sensory will go
any monitoring do you do, like sensory evok potential, motor evok potential, or cardiac monitoring?
No, obviously everything is done, because this is a very sensitive area. Vagus is there. You may have a vagal attack, and also anesthetist and
cardiac monitoring.
Yes.
Any sensory evok potential?
No, not sensory evok potential. Only cardiac monitoring.
Any other question? Any other question?
So what is the duration of regeneration of the medial branch?
So that's very variable. Over the years, what we have seen is sometimes the regeneration can take place in 3 months' time. But sometimes even after 5 years, patient comes and I am okay. Today morning I got a call that he's a famous cardiac surgeon in Patna. I did it in 2016. So 7 years he was okay, and he was saying just 3 days back I had a pain, so I think I'll come back for the RF. So 7 years there was no pain.
It's not regeneration of that nerve, it's the other nerve take over that.
Right.
Actually, when I was in general surgery, Dr. Nandi used to tell, he had published a paper in 75, recurrent nerve to the facet joint in lumbar pain, local pain. And he had published a paper in 75 or something in British Journal Neurosurgery. So still the role is there, right? Dividing the nerve to facet joint, right?
Yes. The surgical division
goes to local anesthesia.
No, local anesthesia, of course, but surgically, of course, now with radiofrequency. Yeah, there was not there.
I'm talking 75.
Yeah, I know. I've done phenol injections on the nerve also, but very carefully, because it should not dissipate.
I was in general surgery. Any question? If there is no question, give a big hand to Dr. Reja.
Thank you.
It's a great pleasure to have you here. You have contributed to the immensely to the knowledge of the people. Thank you very much.
Thanks.
So one question. So one question, if you
Dr.
allow.
Mohan, yes. Dr. Mohan, please.
Good afternoon. Thank you, Dr. Raji, and organizing team for their kind invitation.
We have not yet started the MD pain medicine or diploma.
So we have started fellowship in pain medicine 4 years back.
MD.
MD is
But that will involve multiple specialty, from medicine to anesthesia, surgery to pediatrics to gynecology, multi-specialty, nahin? Super specialty, DM.
No, sir, DM pain medicine has been started in AIIMS Rishikesh. I think 4 years back they have started.
Robbie Kumar started.
So we are planning to start in near future, but right now we are doing fellowship in pain
No
medicine.
problem. I just want to know where are we?
So I will be presenting on sacroiliac joint injection, basically fluoroscopy guided. As you know that the sacroiliac joint has a great variability external contours, and most of the time this is auricular in form. It's a C shape in male patients and L shape in female patients, and usually the articular surface extends from the S1 to S3 foramen and sometimes up to S4 also. And as you know, it's a diatral joint that has some synovial component. And the SI joint itself serves as a major shock absorbent force transducer that is implemented during the weight bearing activity. It's very important joint, one of the largest joint in the body. And coming to a little bit more on anatomy, that's a probable form, and it's about 20-degree ventrolateral to the dorsal middle at S1 level. As you can see this here, it's very difficult to penetrate the needle for SI joint. But this is more or less orientation is surface less oblique. In prone position by posterior approach, one can approach this joint for any injection. And this obliquity is different from person to person, while the propofol form remains constant. But and this have very multiple ligaments are there, especially anteriorly and posteriorly. That gives some this enhanced stability by increasing the friction of SI joint and contribute to the self-locking mechanism. And especially the lower part of the joint, those ligaments they offer proprioceptive feedback with rich plexus articular receptor. This part of the joint is very sensitive and has a number of nerve endings. Coming to different causes of SI joint pain, that some most times unilateral, it may present in ankylosing spondylitis, tubercle psoriasis, then Reiter syndrome, inflammatory bowel disease, and if it's a bilateral, you can have chronic non-traumatic sacroiliitis. But most common painful SI joint presentation is usually in mechanical lesions with trauma, and sometimes additional lumbar arthropathy and fusion. If patient has had some surgery, those patients can have SI joint dysfunction. Coming to symptomatology, usually these patients have painful catching and increased pain while they are having some loading in the lower extremity, and pain may be induced by simple movement like trunk shift, sneezing or turning in the bed, or especially if the patient is ascending or descending in the staircases, and if the provocative landing after a jump or hop. And in this patient, pain is usually not provoked by Gauss maneuver. And these patients, especially pure SI joint dysfunction, they never have any paresthesia, numbness or weakness. Now coming to evaluation, it's basically clinical diagnosis is very important most time, but we go by clinical diagnosis only. And there is a battery of tests which can be performed, especially those may be manual compression tests or provocative tests. Basically, one can do dorsolateral pelvic compression if the patient feel pain and have a finger. You can have finger test if the patient complains that I am having pain in that part of the SI joint or buttock, that means the patient is having some SI dysfunction. Especially axial femoral compression test can be done, and forward flexion, there is some Waldorf phenomena can be performed. And there is a battery of provocative tests, though they are not any more specific or sensitivity, especially Gillette test, Patrick test, that is Faber test, then Gansler test. They have some relevance, especially in SI joint dysfunction, and midline settle test. But all these tests, they are not confirmatory. and they have shown some very little diagnostic early compared to, and the standard gold standard is give some SI joint injection to confirm the diagnosis of SI joint orthopathy. Coming to SI joint innervation, that have very complex innervation, that this usually that nerve supply that medial branch or dorsal ramus of L5, even L4, then lateral branches of the dorsal ramus of S1, S2, S3, and sometimes S4 also. So it's a very complex, and the orthopedy is very important, especially you are doing some, apart from after conducting or performing SI joint, diagnostic SI joint injection, if you want to have prolonged relief in those patients, you can perform some thermocoagulation. Why fluoroscopy? Though these injections can be performed easily by SI joint, this ultrasound guided SI joint injection, but fluoroscopy is gold standard for performing SI joint injection, because one can have specially designed joint and venereal, and it improves the precision, accuracy, and clinical outcome. And most time we use fluoroscopic C-arm to conduct these blocks. Coming to injection technique, basically it's an interarticular classical oblique ridge by posterior approach, and as I said, it can diagnose the course of pain. Usually this blocks are performed prone fusion fluoroscopy and strictly steroid technique used. And in classical oblique approach, the C arm initially placed in direct anterior posterior so that you can view the SI joint total. And once you have visualized the SI joint, you can have two lines, two joint line. One is medial joint line, one is lateral joint line. So basically you align both the lines to make a single line, and for that you have to tilt the C-arm in contralateral oblique view so that there is alignment of both anterior posterior joint line. This is the classical P oblique view approach. You can see that slightly contralateral oblique view is there. You can see that that in this view, fluoroscopy view, more or less this is anterior joint line, this is the posterior joint line, and at the lower one third of this, lower half of this, there is a single line. So this is posterior joint line, this is basically anterior joint line. So target area is posterior one third of this joint line. This is the marker where we have to insert the needle. This is after inserting needle and giving dye. You can see that there is a very good spread of dye from anterior superior to inferior aspect of the joint. In lateral view, you can see that there is a clear delineation of the whole of the joint by the radio contrast material. In this, for SI joint injection for diagnostic, we usually use 2 to 4 ml of xylocaine 2%. And if you want to convert this block as a therapeutic block, you can use some steroids, especially dapamidrol or dexamethasone. You can use up to 8 milligram or dapamidrol 80 milligram. As a big joint, safely 2 to 4 ml can be used in total. And complication, needle tip may not be injured. It can go in the pelvic viscera. One has to be careful. At all time, the needle should be closer to the bone. And as there is chances of infection, hematoma can occur, but most of them it's very safe, easy, and very quickly can be performed. And it's a very good role in diagnosing the pain generated in SI joint. Thank you very much.
Any question?
Okay, now it's not a question, it's rather a comment, and I would request all of you to read something called as Laslet's cluster. So see, when we are in the OPD, the patient is not going to tell us whether he has a disc problem, a SI joint problem, or a hip joint problem. I have missed quite a number of AVN of the hips and SI joints. So there's something called as Laslet's cluster. It's a cluster of 5 tests that you perform. You need to perform in all of your patients. So what Laslet says that if 3 of those 5 tests which Sir has shown, if they are positive, then it is suggestive of a SI joint pathology. And then you go forward and get a SI joint MRI as well. So Laslet's cluster is what is now the benchmark for SI dysfunction clinically.
Very good, sir. Actually, the area of buttock, this area, we perform any test, okay, even Faber test, Patrick test, if there is a L5 S1 arthropathy, facet arthropathy, those patients can have similar type of problem. So we have, these are diagnosis of exclusion. We have to exclude all these different entities one by one. And in SI joint, the classical picture is usually in most of the patient, the patient can pinpoint that pain side by finger touch. And if, especially with that Gensler and Faber-Patrick test, if the patient complain of pain in entire aspect of this, that means it's a hip pathology. But patient is start telling that it's a posterior aspect of the or gluteal region, then is most of the time it's because of SI joint or facet joint arthropathy.
Here I would like to add one more thing, that many times when patients are too old, like I had 4 patients who were 85 plus, and they have pain everywhere, and MRI also shows so many, it seems like pain is coming from nerve compression or SAP syndrome. But when you take the patient on table, try to push the points and tell them from where the pain is coming, and they can tell you exactly that it's coming from sacroiliac joint. That's one of the most confirmatory thing, that the pain is coming from sacroiliac joint.
And that can be confirmed by direct SI thrust.
Any other question? Very common problem. So if there is no other question, thank you very much.
Thank you, sir.
Require question. Yes. Post-pregnancy sacroiliac joint pain. What's the remedy and treatment?
So yes, absolutely, and it is because of the ligament laxity that is the cause of the pain. Generally, typically starts between, not immediately after the pregnancy, it may start about 6 weeks to 8 weeks later on, and continue up to 6 months or so, at times longer. So obviously, apart from counseling and reassurance, a good lower down tight corset helps these patients a lot. Only uncommonly do you require to block such a patient, because they generally do well with physio and a good corset.
Thank you very much. Next one.
So, hello everyone. So I think most of the people have come out of post-lunch hangover and they are awake now. So I would like to thank the organizers also for giving me this opportunity. So we are going to talk about stellate ganglion block. Slide please. The blocks are not, as you are seeing in this picture, these are not these blocks. We are basically talking about the pain intervention on the stellate ganglion, and this will provide interruption of the sympathetic efferent fibers to the upper extremity, head and neck. The few important anatomies, these are longus colli muscle. Then this is the C6 transfer process, such as neck anterior tubercle, C7 and T1. This is common carotid artery, then subclavian, this is vertebral, and this is the superior cervical ganglion, middle and inferior cervical ganglion. So stellate ganglion lies here. So its utility is to determine if the pain is sympathetically mediated or not. What happens in sympathetic mediated pain, that due to abnormal connection between sympathetic and sensory nervous system, there is pain. We come to know if there is significant pain relief after block, it means there is significant component of sympathetic immediate pain, and we, after giving block, we can determine if neurolysis or surgical sympathectomy could be beneficial. So the sympathetic fibers for the head, neck and heart and upper limb arise from the thoracic spinal cord T1 to T8. These ascend through the sympathetic chain and synapses in the superior, middle and inferior cervical ganglion, as you can see here. In 80% of population, the inferior cervical ganglion is fused with the first thoracic ganglion, forming the cervical thoracic ganglion or the slit ganglion. So, and nearby this is the vertebral artery, which goes anterior to the C7 tubercle but goes in the transverse foramen from C6 upwards. So this ganglion measures 2.5 centimeter long, 1 centimeter wide and half centimeter thick. This slide is the level of the C7 and T1 anterior to the transverse process of C7 and first rib and longus coli muscle. This is the longus coli muscle. This lies anterior to these muscles, and the borders are the longus coli medially, then the scalene laterally, then subclavian artery, then vertebral artery posteriorly, the transverse processes posteriorly, the carotid artery anteriorly, and the nearby structures. This is the phrenic nerve, the vagus nerve, the recurrent nerve, and the brachial plexus. So this is a very useful block, and there are so many indications for this block, starting from the complex regional pain syndrome of head and upper limbs, the peripheral vascular disease, the upper extremity embolism, the post-herpetic neuralgia, the chronic post-surgical pain, hyperhidrosis, Raynaud's disease, scleroderma, orofacial pain, phantom limb pain, the atypical chest pain, cluster or a vascular headache, post-traumatic stress disorder, the Meniere's syndrome, intractable angina, and the refractory cardiac arrhythmias. But there are still few contraindications. The one is recent MI, the anticoagulant patient or coagulopathy, the contralateral diaphragmatic paralysis, because then you may block the same side ipsilateral phrenic nerve also, the cardiac conduction block, the contralateral pneumothorax, because you may puncture the pleura while performing this block. Then glaucoma is one of the contraindications, and if patient is having severe emphysema. So there are few techniques. There are 4 techniques basically. We will be talking about the 3. One is surface landmark technique, the fluoroscopic technique, the USC guided or the CT guided. So as we have discussed that the ganglion lies in front of C7 and T1, but most commonly this block is performed in front of the C6. So why we need to choose C6 for the landmark? Because as you can see here, this is a C6 transverse process and this is C7. The vertebral artery goes in front of the ganglion. So the most likely you may puncture this artery and you won't like to do this. So that's why we choose the C6 transverse process to give the blockage, because then the vertebral artery goes posteriorly in the transverse foramen and through that ascend upwards. Sometimes this may not happen, but most likely this happens, and that's why the C6 is considered more safer for the landmark targets. So in this view you can see this is the trachea, then esophagus, this is thyroid, this is the C6 transverse process, that's a sagnic tubercle, the vertebral artery posteriorly in the transverse foramen, then this is the inferior thyroid artery, this is stellate ganglion, then carotid, then vagus, then IJV, and few things. So what is the position? Patient should be supine with slight head extension. Then a carotid cartilage is palpated to find the C6 level. We then move laterally and downwards to feel the C6 sagnic tubercle with the finger compressing the carotid artery laterally. So after sterile percussion, skin and subcu tissue pressed against tubercle, the needle advanced perpendicular to the skin posterior direction to hit the C6 tubercle. Then once we hit the bone, then we withdraw a little bit 2 mm, so that we are just out of the longus coli muscle but still beneath the prevertebral fascia. After 1 mm test dose is given, after negative expression of, look, we need to check for the negative expression of 3 things. It is very important for the blood, for the CSF and the air, because anything may come from this place. You may be in the lungs, you may be in the CSF space, or you may be in the one of the arteries. Then you can give the local bupivacaine or ropivacaine 8 to 10 ml, and patient to be assessed at least 30 minutes post-block. Then the same procedure can be done the fluoroscopic guided. The landmark and patient posting same as for the surface landmark. What is the advantage? That bony delineation is better than, and the procedure can be performed with fluoroscopy either on C6 or on the C7. Few like to perform on C7 and few like to perform on C6 because they think that C6 is still safe. So when we are giving local, what it will do if we injected a right place, the local or your neurolytic agent will trickle down and it will block the stellate ganglion. So oblique fluoroscopy technique is most commonly used, and the contrast is given to confirm the needle placement. If there is proper facial pain, you are in the exact position, the local will spread and contrast will spread both up and down side. If you are in the muscular, so next slide. So this is the honeycomb appearance. If you are given a block just beneath the prevertebral fascia and anterior to longus coeli, but you may see this kind of appearance, standard appearance, if you are in the longus coeli muscles, and then your block may not be that effective. Then you can go to the USC guided. So this is how you give the USC guided block. The carotid sheath and stellocleinoid muscle to be retracted laterally with transducer, presses applied with the linear transducer probe. The needle is inserted directly toward the chest segment tubercle, then it's withdrawn again, and after negative expression LA can be injected and spread to be visualized with the ultrasound. So again this is trachea, this is esophagus, the longus coeli muscle, prevertebral fascia, this is thyroid, carotid, and all. So why this route is preferred? Why ultrasound is preferred? Because in either you are giving fluoroscopy guided or surface landmarks, you are going perpendicular to the skin. But as you can see here, this is cricoid, and just near this there is esophagus. So sometimes you may puncture through esophagus because it is not necessary. In up to 40% of patient, esophagus may be just lateral to the trachea instead of being behind the trachea. So it is better to use ultrasound so that you may avoid puncturing through the esophagus, or immediately there may be inferior thyroid artery. So esophagus or inferior thyroid artery may be damaged with the previous techniques. So this is sonotomy. This is sternocleidomastoid muscle. This common carotid artery, the IJV, the longus capitis, longus coeli muscle. This is a transverse process, and just behind, in front of longus coeli muscle and behind the common carotid artery, there is a sympathetic chain. This is our target. So and this is the needle entering, and this is spread of our local anesthetic. This is longus coeli muscle. So the C7 anterior approach can also be used. This is nearly identical to the C6 approach. So what advantage? The needle is closer. Local agent may with more reliable and consistent blockade, and it may be useful if your previous C6 block the C6 level has been failed. And for this you require either fluoroscopic or the USG guided approach, because surface landmark you can't use here because the tubercle is very small and you may not feel it. So what may be the various complications? The complications are numerous, so this to be done very meticulously. It may be from vascular puncture of the common carotid or interjugular, thyroid artery or vertebral artery. The needle puncture may, few nerve roots may be damaged like vagus, recurrent brachial plexus, or the phrenic. There may be pneumothorax because you can see the dome of the lung just nearby. This is the stellate ganglion, and just lungs is just nearby. So there may be thyroid injury. The esophagus or tracer puncture may be there. The transient Horner syndrome, which we many times we see. Then intravascular injection may lead to the generalized seizure, and then infection, and there may be paratracheal hematoma. A few references for this. Thank you.
Thank you very much. Any question? Any question to him? Anybody? No? No question? Thank you very much. Okay, next one. Group. Dr. Group is there?
Yes, sir. USG. ये फर्स्ट देखिए, लगा के देखिए, कलर वाला वो. हाँ जी.
Good afternoon, everyone. So I am back. Last time when we were back, I came, we discussed the easy part, which was the fluoroanatomy. Now we would be talking about sonoanatomy. The anatomy remains same. The only challenge it poses to us is because again a new technology comes in play. Therefore, the challenges are there. But if we are very clear with regards to anatomy, things can become very easy. So just to give you a brief, as I told in fluoro, I am repeat here, when we are doing intervention specifically in the domain that we are, bone is our friend. That is one. Here we have one more enemy, if I may say so, that is a vessel. So whatever you are doing ultrasound guided, always have a bone at your base that yes, this is, or any structure around it, and always try to avoid any vessel. With regards to spinal pain, fluoroscopy is the gold standard. And why I say so? Because there is a direct visualization of the needle when even it goes below the bone. That is what you must have seen when we were doing those interventions. So for experts, you can do all those interventions under USG also, but the basic problem remains that once it goes below the bone, then the needle is not seen and it becomes more of a blind. That is one. And second thing is, as I said, wherever there is dye, there is going to be drug. So if you are not be able to push in the dye, you can never be sure about the position, which is just not possible with sonology. But it does have some advantages. So what does that do is, for people, we know that radiation has its own set of side effects. Therefore, radiation exposure reduction is one big thing. And for most of the things clinically, what we are doing in a day-to-day practice is we are doing a hybrid technique. So what I will be doing is I will be putting a needle under USG, and once I am sure about it, then I'll put in the dye and use fluoroscopy. Second, there is an increasing role, a lot of evidence is coming up for facial plane blocks in chronic pain. And now for that, the best drug, the best set of technology is definitely sonology. Then there are certain interventions where, for example, in cervical root, we talked a lot about it, that we should not do it on the fluoroscopy, but that can again be done by USG guidance. Sometimes you can use for scanning also. Sometimes the muscle is something which I feel that you can definitely scan with great precision with sonology, so that is one. Secondly, somebody was asking about post-pregnancy. I would say there is a subset of patients who come up to us who are, during the pregnancy, they have back pains. In those, you cannot go for fluoro-guided intervention. Just in case if you have to, then definitely USG is the indication of choice. As I told you, what we can do, one, caudal epidural, with greater confidence we can do cervical selective root block. It was demonstrated. So again, it can be done. Cervical facet, lumbar median nerve block. SI joint is one thing. Another thing here is newer blocks for chronic pain is the plane blocks that I was talking about. Now, interestingly, when I talk about PRP, so again, the basic major subset of patients are non-specific low back pain, and in non-specific low back pain, we can't find anything, and there they found out is that what happens is the erectile spinal group of muscles, or multifidus in particular, is the one which has atrophied, or that is weakness. So for that, we do exercise. Along with that, we can even consider doing a PRP in the muscle for its initiating its growth. So how do we scan? Now again, as regards to any sonology scanning, you need to follow a protocol. That is one, try to follow it and keep repeating it so that it becomes your second nature. That is one. Second, again, we are converting a three-dimensional structure into a two-dimension. Therefore, you have to confirm anything in two dimensions always. So what we do is, one is a long axis, another is a short axis. So when we are doing a structure, we always go from long as well as a short axis. That is one. Third, something I always do is I always have a zero. Means when you are doing things sonology under USG, you tend to get confused whether you are doing shoulder, whether you are doing hip, whether you do spine, because there are multiple layers. So always have that zero, and then you can start all over again. Now just imagine we are moving from lateral to medial. So if we go from lateral, we start moving, there is a group of muscles, and the first bony structure that we will encounter would be the transverse process. From transverse, we will be going to the facets, lamina, and the spine. Right? So for me, the zero, when I am doing a scanning of the ultrasound, is my transverse process. So bone is my friend, I see a bone, that is my zero, and then you can go medial or lateral, wherever you want to go. So medial, you will have facet, lamina, spinous process, where if you go lateral, you will have muscle layers. Until you reach the middle, and once you have done that, you can always have a short axis. So this is long, this is short axis, you can have at the spinal level as well as the interspinous level. So long axis view, we start with 3 muscle view, then 2 muscle, then for what we always call as then we come to the transverse process, facetal view, laminal view, and the spinous process. Now these are the images. So once you are at the transverse process, so again bone, hyperechoic, with an acoustic shadow, it won't let anything go by. So you will get these straight lines. So this is a classical trident sign, which is for the transverse view. You move medially. So just imagine the anatomy. You are moving medially from transverse process. We have come on to the facets, facetal line, and there it becomes like a hump. So this is where the things start to get interesting, because we are at the facet. So just in case if you are interested, you want to do a facet block, these are the facet blocks that you can consider going. That is one. Now from the facetal line, we are again moving medially, and what we get is a laminal view or the sawtooth appearance. Right? So this is a lamellar view. Now this is something, if you have not done sonology, it can be challenging. So the next view is, so in sonology what is actually happening is, I am throwing sound waves and I am again catching it. So even if I change the direction of the sound wave slightly, the image that I will get would be different. So so in this case, here I am just straight, where here I have not moved the needle, but I have just made it slightly oblique. Therefore, what I see is the dura. So dura, this is the posterior complex of the dura, and this is the anterior complex of the dura. So same place, just changing the direction of the probe, changing the direction of the sound waves being given and being getting back. And then this is the short axis view. We are at the right at the spine. So we have the spine, we have the facets, and we have the transverse process. So again, this was something I said, you start from this, from 3-4 centimeters from the midline, you keep on going, you see the transverse process, and then you see the trident sign. You move still medially, you come at the level of the facets, you have the facetal thing. Then once we have the facets, then you move still medially, you come to the lamina. When you are in the lamina, you won't be able to see because there is an acoustic shadow. But the moment I change the direction of the sound waves, there you will be able to see these complexes. Excuse me. There you will be able to see the posterior and anterior complex where of that thecal sac. Again, this was this. So once the sound waves travel from the lamina, this is the anterior complex, this is the posterior complex, this is epidural space, this is your CSF. This is the short axis view, right on the spinous process, lamina, and the transverse process. Here, now from when I am at the spine, we just move little, and then what we get is the facet. So these slit-like openings on this is a facet. So if you are in a hurry, the patient is not able to tolerate that position, you do not have fluoroscopy. So this is something which I strongly recommend, is something that you can start doing, where you scan and do a facet block in the short axis view. Caudal epidural, again simple. You just start from the sacrum,
just go down. So once you go down, you will see these beautiful cornuas, and between the cornuas, you will see the sacral hair. So we just need to introduce our needle right there. So this is a short axis view, this is long. So once we scan, we get the short axis view, we make it long, and that is how we, just 30 seconds, sir. So just we will introduce the needle right up. So what I generally do is, if I'm doing this as a hybrid technique, short axis view, I introduce the needle. Once it is in, I get the fluoro and see how we go for it. Now, SI joint again can be done, superficial joint. Now the other thing is the common, most common interventions that we are doing left, right and center, that is an erector spinal block. I won't go into the details. The simplest way is just hit the transverse process and give a lot of volume. So around 15-20 ml of local anesthetic can easily be given just by hitting the transverse process, and you will get a good spread, and the erector spinal block would happen. So this is the transverse process, so it can be given right from the thoracic to the lumbar region and good for non-specific kind of low back pain. Just carry home message, limited lumbar spine intervention, definite role in facial planes, and for subset of patients and indications, you can definitely think about it. Thank you so much.
Thank you very much. Any question? I have a little comment. I don't know how many of you know, the first ultrasound came to AIMS in 1980 for abdominal ultrasound. And there was no ultrasound available in the world before 1979. Usually it was used for the navigation for the ships. Ultrasound started 1940s for navigations of ships. That ultrasound was translated to medical ultrasound in 70s and 80s.
Yes.
So AIMS had the first ultrasound, abdominal ultrasound in 80. We got our ultrasound transcranial Doppler in 81, and that is PCD for the blood flow, and cranial ultrasound in 85. So we had to have a temporal window, occipital window, orbital window. So ultrasound has a tremendous role, and the pediatrician use it very frequently to the fontanelle.
Yes.
See, if you go to any pediatric neonatal unit, for every brain problem, they will sweep on transfrontal lap. I don't know how many of you know.
Yeah.
You send anything of pediatric for brain problem, say I will get an ultrasound, neonatology, right? So I think it's a very important, which is very underutilized because we have CT scan and MRI. I still think intraoperative ultrasound is a very important thing to find out bullet, foreign bodies and all this.
Sir, Sir, in chronic pain, the game changer has been ultrasound. The reason is simple, because all these investigations are static images. So for example, a patient comes to me, a player comes to me who says that, doctor, when I throw, that is the time I have pain. So I can actually mimic the movement and do a dynamic scan. Now dynamic scanning is something which is the future of scanning. Right. Apart from needling and everything, obviously precision is there. So for example, not related to spine. So if I have a tear of a rotator cuff supraspinatus, I can do it with precision. Even diagnosing it, I can mimic. So dynamic examination is something which is the thing for the future.
Not only that, it can be repetitive.
Yes, sir.
It's cost effective.
Yes, sir.
It can be done on bedside.
Yeah.
You don't have to push a patient for MRI, CT. So ultrasound is a bedside, repetitive, confirmative test. Very, very, very. I think we all underutilize ultrasound.
Only problem is, before I start the second talk, is that especially in center setups, daycare centers, getting a PNDT is a hell of a job. So that is a big challenge. But rest, the scanning and everything, it is definitely...
all medical superintendents, they give an undertaking during purchasing of a ultrasound. This machine will not be used for protective. If somebody thought that's the question, we all thought even red light, driving a red light. What's about ultrasound?
No,
so all of us have driven red light, ne?
Fine.
So anyway, next
time, sir, I was not there, so next topic would be mine, sphenopalatine ganglion block. Okay. I'm so sorry, I'm boring you repeatedly. So now the sphenopalatine ganglion block, it's a simple block done for orofacial pain. Now for me, orofacial pain was not such a big identity, because most of our pain practice is restricted to spine and joints and everything. And very recently, around 2 or 3 years back, I was invited by one of our leading ENT specialists from Meerut. And I said, sir, I have 2-3 case type ke hote hain, kehta tu aa to. And then he called me, and that was the real time where I found a lot of patients coming with varied presentations of various orofacial pain. That is one. Second thing, as we famously or infamously were discussing about the various complications post-surgery where the patient continues to have pain, in the same way, what the ENT surgeons suffer is that sometimes they do a surgery like a simple mastectomy or ethmoidal or sinus surgery, and the patient comes to with a lot of orofacial pain, which they are sometimes not able to understand. And along with that, those set of patients also have symptoms which are suggestive of sympathetic or parasympathetic overactivity. So in those subset of patients, this block or these kind of blocks can really help us. So with that background, let us start. So where are we doing this phenopalatine ganglion block? Don't worry, you can text me, you can have my this presentation, nothing great. I have not reached to that level where I do something very great, but you can have it. Cluster headache, atypical headaches, phenopalatine neuralgias, CRPS, neuralgias of the face, and sometimes in cases of orofacial cancer. Everything starts with the anatomy. It is this ganglion is present in the fossa. The fossa is present in the pterygoid and the sinus. The lateral opening is the pterygomaxillary fissure. The medially we have a palatine bone. It has also an opening, interestingly, in the nasal cavity to the sphenopalatine foramen. So basically, for us, we can enter this space either externally or even through the intranasal route. Or more important thing, the sphenopalatine ganglion is located in the superior 1/3. So when we are trying to do an intervention of this of the ganglion, we always try to target the upper 1/3 of the ganglion. So now this is the famous reverse triangle. So this is the space that we need to target. Even in fluoroscopy, when you will be I'll be sharing the images, this is the reverse flask thing that we need to target. That is one. Second, regarding the complications, so any structure which is present here, right from zygomatic nerve, the infravital, alveolar, lesser palatine, greater palatine, all these nerves along with the arteries are the ones which can be damaged if we are not careful during the procedure. Now, how do we do it? First is, and the easiest thing is the intranasal approach. Classically, patient of cluster headaches comes to us, severe headache, which is very cyclic, and sometimes the patient even cannot come to the hospital before it subsides. So what do we do? Or if the patient comes to us, obviously we give oxygen, and then we go for a sphenopalatine ganglion block through an intranasal approach. The point is to get the local anesthetic in the fossa. So what we do is we just introduce local anesthetic. Now this can be done by a pedette, this can be done by a syringe, this can even be done, what I was taught and what I think was we just soak a gauze piece in local anesthetic, ask the patient to have an extended neck, put it in, place it for 5-10 minutes, patient is comfortable, the pain settles down. This is something that we even tell the patient that this is something like a first aid that we can do it at home also. Only precaution is that we ask them to keep a liberal part of the gauze piece outside so that they can pull it out. But sometimes what happens is, now that is for cluster headache, sometimes the pain either doesn't subside or there are atypical presentations of this kind of patient with severe burning, itching in the facial region, or the patient has repeated attacks which are responding to these phenopalatine ganglion blocks, but they have a tendency of coming back. In that, we can consider going for a diagnostic block. So before that, just see again, as a trigeminal ganglion block, the phenopalatine ganglion block is what I call it is a technician's block. So for example, if you can get this image, your job is done. You just need to introduce the needle in this position. But if you are not able to appreciate this, you can never do it, because this is a very narrow space and there is a lot of overlapping. So how do we do that? Now here the patient is lying supine. Second, the position of the CM is going to be lateral. Now the challenge, as I said in my previous talk when I talked about fluoroanatomy, was getting a perfect AP. In this, getting a perfect lateral is a challenge. We really want the right and the left to superimpose to give us one image. Now there are various ways. So some people talk about concentrating on the eardrum so that you get the eardrum. Some talk about mastoid, but some simple trick which one of my teachers told me was that ask the patient to put up a stethoscope. So ask them to put up a stethoscope, ask them to hear their heartbeat. They are also relaxed, and you just need to align the stethoscope. So now that becomes, because that's a huge thing, so you just need to get a perfect lateral image where the stethoscope is matching. You will get this image, and you just need to introduce it from lateral to medial. Now this is what I was talking about. You get a lateral image, this inverse was appearance, and then this is the lateral image. Now this is again because this palatine bone is very small and fragile. Therefore, once I am inside the foramen, I get that feeling that I have entered the fossa. I make the patient, my CM AP, excuse me, I get the CM in AP and introduces gradually, making sure that I do not puncture, because this bone, palatine bone is soft, and even with a 22 gauge spinal needle, there is a possibility that you might pierce it. Lateral, as I talked about, perpendicular, yeah. So positioning, it has to be supine, lateral view, rotate the head to get a true lateral view. So you can take any structure, as I told you, the eardrum, the mastoid, or try the stethoscope. Enter point is inferior to the zygomatic arch, just in front of the coronoid process. Now this is something, again, sometimes people struggle because in a closed mandible, you cannot go in front of the coronoid and it is blocking. So sometimes you even have to ask the patient to open their mouth. So the moment they open their mouth slightly, that also makes our job easy, and we are able to identify the vase. So what people who are starting, please take these small tips, utilize it, and do not try to introduce before seeing the vase, otherwise you might struggle. AP view, lateral valve, we have already few tips which I have found is perfect lateral image is something which holds the key for the procedure. One can move the coronoid process, just ask the patient to open the mouth slightly, and then your thing, that is second. Third thing, which I was even discussing with doctors who were there with me in the OT, as a beginner, there is no harm in bending the tip so that you are oriented when you are introducing it, especially in fluoroscopy. So that bend tip gives you an idea about orientation, that is one. Secondly, don't target the fissure or the any foramen, try to target the bone. Go close to the bone, hit the bone, be rest assured, and then redirect and go in. So that is the 3 things. Regarding the RFA, so firstly we go for a diagnostic block. If the patient has relief, then we go ahead with a radiofrequency ablation. So ideally the tingling sensation should be at the tip of the nose. Excuse me. But if the tingling sensation is in the teeth, it means that you are too anterior. Right? So ideally it has to be at the tip of the nose, but if it is anterior, you just like to pull it, redirect it posterior side to make it slightly posterior. If the tingling is at the palate, it means that you are down, you need to move more cranial. So these are the small tips and tricks which I will request, and thank you so much.
Now only 1 or 2 question, anybody? We are already half an hour late. Any question? No question. Thank you, thank you very much. Ashish?
Thank you, sir. So I'll be summarizing the whole day's program, spine blocks for neurosurgeons, and I'll try to emphasize on certain particular blocks which have not been discussed at a greater length. So why should I learn blocks? It helps clinch diagnosis many a times, and especially if we are taking up the patient for surgery, and it is definitely a part of the treatment algorithm. What are the blocks I would be talking about? Erector spiny block, it's a pain block. Transforaminal block we have already discussed in the morning and we have demonstrated it as well. Facetal block, that means intrafacetal injections. Then medial branch blocks for facetal pain. Epidural blocks, the various types we have already discussed. Caudal block and SI joint block, they have already been discussed, just the previous lecture was on that. So why blocks? Because there is a poor association between imaging and the cause of chronic pain. So that is why the blocks come into place, so that we are very sure that what we are targeting, even surgically, we are at the right place. And surprisingly, only in 15% cases, the source of chronic pain can be picked up through imaging alone. So, it is so less. We need to use diagnostic blocks more often. Now, how to go about diagnostic nerve root block? It helps diagnose the source of pain, pinpoints the pain generating root level or the facet joint. You can use lidocaine, which is a short-acting drug, small amount, 0.5 to 1 ml. And if the patient has 50, some studies would say 50%, but generally we agree that 70% is the mark. If the patient has 70% or more pain relief, we consider it to be a positive test. The diagnostic value of any diagnostic nerve root block or facet block is only moderate. So clinical imaging as well as the diagnostic nerve root block. The frequency of blocks that we can give is about 3 to 4 per year is safe for a particular level. And there should be a gap of at least more than 2 weeks. What are the contraindications? Anticoag, local site infection, systemic infection, pregnancy, use ultrasound only, and if there is allergy to contrast or local anesthetic agents. We have had an extensive discussion on the type of steroid. Again, I would emphasize that I personally believe in dexamethasone. The particle size is 10 times smaller than that of a RBC, and they do not aggregate. So dexamethasone is the drug of choice for me, and there's no difference in studies as far as functional or analgesic outcome is concerned between the particulate or the non-particulate steroid. The rationale for steroid use, I'd like to draw your attention to this: epidural steroid versus just bupivacaine injection in disc prolapse. Epidural steroid injection patients, 23% required surgery, whereas just the bupivacaine group required 67%. So obviously you need to use steroids. Rationale for local anesthetic, the viscosity is different. Local anesthetics is similar, and there is higher viscosity of the dye. So the dye would spread less, and the local anesthetic would spread more than the dye. The volume of drug would decide the specificity. So suppose if you're putting 4 or 5 ml, then obviously there will be extensive spread, and you cannot be very sure about the level of the block. And so lower volume for selective nerve root blocks and SI joint or facet blocks, and higher volume spreading to adjoining structures and decreases the specificity. Rationale of epidural steroid. Now this is very important. The SPORT trial, which is the spine patient outcome research trial, patients of disc herniation receiving epidural steroid, only 20% of them required surgery. Whereas without epidural steroid block, almost 57 to 60% required surgery. So sort of we can avoid a lot of discectomies if we are using the blocks. Now coming to transforaminal versus interlaminar, TF approach has better results, lower complications, and obviously better ventral penetration of the drug, because in these cases and at times with osteophytes or cysts, you may have anterior compression and the root is also lying anterior in the foramen. So transforaminal tends to deposit the drug there. In pregnancy, kindly use ultrasound. Now let us compare fluoroscopy versus CT scan. Now fluoroscopy is faster, widely available, easy to use, better non-axial view, real-time view of the flow of dye. And the disadvantage is radiation to the surgeon and obviously non-axial views. Whereas in CT you have excellent axial views and 3D views, precise view of where exactly your needle tip is. However, and also operator radiation is avoided, but the disadvantage is time taking, increased radiation to the patient, and real-time views are absent. So every time you tend to come out. So let's look at erectile spiny plane block. It is the new child around the corner. It was just started 2016. It's a facial plane block, and the drug is deposited below the erector spiny muscles. So I personally use for peri-op pain reduction for my lumbar surgeries, as well as if I'm doing thoracic surgery. However, it was introduced for thoracic surgery and for chronic pain. So it is ESPB block, like for all of us, it can be utilized as the multimodal analgesia. So it is part of the ERAS program now. The target is the tip of the transverse process. You can do it fluoroscopic or ultrasound guided. The needle rests on the tip of the transverse process below the erector spiny muscle. And I personally use 20 ml of, I use ropivacaine, 0.2%, deposited on either side. So if I am doing just an endoscopic disc or a tubular disc on one side, then obviously I'll just push in the drug on one. But suppose if I am doing some sort of fixation, I tend to push the drugs on either side. Now, what is the current standing? The conclusion is erector spiny block provides less opioid consumption, lower pain scores, and longer time to first analgesic in the perioperative period. So obviously, if you're using it, you can enhance the recovery. Complications, you can have partial lower limb weakness, complete motor block, priapism, local toxicity to the anesthetic drug because you're injecting a lot of it. Transforaminal blocks, we've already discussed at length in the morning, so I'm not going to that. Facet, I'll focus on a few very important aspects, which are practical tips. 67% of neck pain is secondary to facet, especially chronic neck pain. 48% of thoracic pain and 45% of low back pain. I must tell you, 10 years before, I hardly thought about facet as the source of pain. So many patients coming to my clinic. And this data sort of opens our eyes to the times we are missing the cause of the pain generator. This has already been shown, the presentation of facet-mediated pain. Basically, it's a diagnosis of exclusion, but the patient can come with lumbar back pain, aggravated on hyperextension, rotational movements. Uncommonly, it will spread to the lower limbs up to the knee. Generally, it does not go below the knee, so you can differentiate with the radicular symptoms. In cervical, Professor Dureja has already discussed, this is the pattern you will get, but no radicular pain into the upper limbs. Coming to intra-articular facet blocks. So facet as a source of pain, basically it's a diagnostic block, not very good therapeutic option. The causes of facet joint pain can be osteoarthritis, rheumatoid arthritis, Angst-Bond, segmental instability, trauma, inflammatory post-laminectomy, and post-spinal fusion. Again, I would emphasize that a good number of our patients, when we fuse, they complain of back pain, and we do not listen to them. We just keep on using analgesic, physiotherapy, and gabapentins and pregabalins. Please think about facet as a source and at least do a diagnostic block. Now, as far as intra-articular facet joint block is concerned, you need to push in less than 1.5 ml because otherwise there would be capsular rupture or leakage. For cervical facet, you can use a short-acting local anesthetic, whereas in lumbar you can go in for a long-acting one. This we have we've had so much of discussion since the morning, but you can see the facetal line here and you just need to push the needle straight in, do the dye. Let's look quickly onto the studies. I think my time is over, so let's skip this. Medial branch block, just one comment. So for say L4-5 facet joint. So the question is, suppose if you have a L4-5 facet joint, the supply is coming from, one is coming from the L4 ramus and the other is coming from L3 ramus. But to simplify L4-5 facet joint, you use L4 pedicle area and L5 pedicle area to block. Okay, so that will give you a good median branch block. To remember, these are the exceptions to the dual supply: atlanto-occipital joint, atlanto-axial joint, and C2-3 joint. They just have singular supply. Technique has already been discussed. The best is between the mammillary process and the accessory process, but the midline is good enough because most of the times on fluoroscopy this is not seen. Complications, this I would like to focus. Multifidus is supplied by medial branch, and it is very important for stability, so avoid more than 3-level median branch block because it requires innervation and instability. This we have already seen in the morning during our session. We did interlaminar, midline 2, we did one paramedian, and transforaminal we did several. So this we have already discussed, I need not go. Just the final slide on epidural and anticoagulant consensus. NSAIDs, no contraindication. Eclopidine, discontinue for 14 days before the procedure. Clopidogrel, 7 days. Ecosprin, 5 days. Heparin, discontinue 2 to 4 hours prior, check the PTT, and then you can go ahead. Warfarin, discontinue 5 days, get the INR normalized. Low molecular weight, wait for 24 hours after the last dose. So I think I'll sum up my lecture here in the interest of time. Thank you so much.
We would like to have some question.
Yes.
Any question to Dr.
Sir, because we are talking here about facet joint block. Facet joint problem is coming mostly because of the joint instability. So aren't we delaying a process which has to be fixed right now? The problem lies at the joint instability. We are not dealing with the joint instability and we are in fact blocking that pain which is arising from a defaulted or imbalanced joint. So we go for joint fixation earlier rather than we are just suppressing that pain. So the
Absolutely not. First of all, I'll sort of try to convince you that it is not a question of instability. Facetal pain is not secondary to instability. It is secondary to inflammation of like any joint. There is a synovial membrane, there is a capsule, and there is inflammation, which is the cause of pain. Only one of the causes is instability. But bulk of the indications we saw was more of inflammation, and we are trying to restrict the inflammation first. But secondly, if you said fusion, you are automatically putting stress on the adjacent joints and now they will be loaded. So why unnecessarily fuse the joints? So perhaps I think that is not the solution. Wherever you have facetal pain, go and fuse is not the way to go. Thank you. Okay, so see what is happening is you are blocking the sensory component and typically the nociceptive fibers. Previously when we used to cut it or there was chemical lesioning, it was sort of permanent. But when you do a RF, like for any RF procedure, RF tends to affect nociceptive C-type fibers much more than A-alpha fibers. So that proprioception sense tends to regenerate much faster, whereas the nociceptive fibers would be blocked for a longer duration of time. And that is what the principle is for using an RF. And just to clarify again, and that is specifically the reason why we use multiple diagnostic blocks to just confirm that yes, we are ethically correct in doing a RF of the medial branch.
When do you block the medial branch? What are the indications for medial?
Okay, so I think for facetal pain, I would say that it is one of the best choices, because intra-articular facetal blocks, I wanted to show the literature, is not very high quality. So it is the median branch block at 2 levels, which really gives long-term benefit. So that should be your ideal
indication.
Yeah.
Before therapy, I myself quit. Both of them fantastic, and the week before the hypotension is very static. I'm able to complete massaging very fast.
Yeah. Yeah. Yeah, it is an excellent block. I've been using for the last 3 years. Yeah, and I also find, but literature I would say is it does not say that all the patients would have excellent results. So, you have to go with a clear mind that, at times the patients might not do very well. So we are still, I would say the jury is still out, and it's a good, easy block. No harm in using it.
When do you give that, sir? How many minutes?
Structure for pain.
So,
your teacher, Dr. Bhattacharya, started Center for Acupuncture.
So these days also we have dry needling. I tell you, specifically the area you are showing for trapezitis. My trapezitis trigger points, I'll tell you that dry needling is one of the best, because, and again, it is the commonest cause of pain. So many neck pains come, they are really trapezitis and not truly neck pain. And dry needling, or you may use acupuncture, is really good for it.
What is yoga for pain?
So you are asking questions out of course.
See, Mahatma Gandhi, in 19, the Indian Institute of Naturopathy started in 1930. The Indian Institute for Naturopathy started by Dr. Mehta in 1938 in Pune. And even if now they called Indian, so there's a talk about mud therapy, heat therapy, cold therapy, mantra therapy, music therapy. There is a center for music therapy in Los Angeles. Anybody know? 1948, Center for Music Therapy started in Los Angeles. We do not consider that. That what is the role of mantra therapy for health and disease? In Nature Cure, when the Mahatma Gandhi wrote that book, it's a 40 pages book for 40 rupees. Please go for that book, Nature Care. He talks about cold therapy. We know cryogenic. We know heat therapy. For every pain you use heat. Go to spa for relaxing muscle. Then mud therapy. Mud. Then there is a Ramnam therapy. Then there is a mantra therapy. Everything is scientifically based, which was supposed to be nature cure. What's your concept in nature therapy?
Very poor, sir. I don't have.
We give medicine.
What? Yeah, cupping again is a upcoming thing. But we send it to the physiotherapist. Yeah. Thank you. Thank you so much.
Before we start, I can tell one I see very lot of geriatric patients. A person at 70 years take about 10-30. You are a long way away from 70 years. And a person at 80 years takes 15 minutes. Believe or not. You know that? And backache and pain is one of them. Sleep, diabetes, blood pressure, asthma, arthritis, backache, sleep, joint pain, spondylitis. People add all these in 15 medicine at 80 years. So try to be naturopathic than all pain medicine. You know, naturopathic can cure diabetes and blood pressure.
Thank you, sir. Thank you, chairpersons, for chairing this session on blocks. May I request the chairpersons to kindly felicitate the speakers. May I respect Professor Mahapatra, sir, Professor Dureja, sir, to kindly come on the stage and felicitate the speakers.
इसमें ज़्यादा टाइम वेस्ट हो रहा है. You should have put all the your.
May I request Dr. Devesh Bhoi to kindly come on the stage. Dr. Devesh, sir, please.
Actually, my work is my OP to reduce pain.
Dr. Mahapatra sir and Dr. Devesh sir will be felicitating Dr. Devesh Bhoi. Dr. Devesh Bhoi, additional professor in anesthesia at main aims. May I request Professor Mahapatra sir and Professor Dureja sir to kindly felicitate Professor Virendra Mohan sir. Professor Virendra Mohan sir and Professor Devesh sir are continuing the legacy started by Dr. Dureja in the Department of Anesthesia at AIIMS. May I request Dr. Mahapatra and Dr. Dureja sir to kindly felicitate Dr. Navdeep Sokal. I thanks Professor Mahapatra sir and Professor Dureja sir for this felicitation. Now moving on to next session. Next session is on neurostimulation, ablation and miscellaneous session. I request chairpersons to kindly come occupy the chairperson chairs. Chairpersons are Professor KVL Narsingh Rao, Professor Navdeep Sokal, Dr. Anirban Banerjee, and Dr. Ajay Chaudhary. I hand over the mic to chairpersons to proceed with this session's proceedings.
मैं बता रहा हूँ दुर्जय सर का कॉल दुर्जय सर ये वाला ये खोलो यार थर्ड ठीक.
Good evening everyone. So may I call the first speaker, Professor J.P. Dureja. His talk would be on epidural additional lysis using RAGS catheter. Professor Dureja.
Thank you very much. So basically this is what we demonstrated in the afternoon during the live workshop, and we are going to just give a brief description of what it is. And as we were discussing in the afternoon during the live workshop, that epidural fibrosis or epidural adhesions are generally defined as a non-physiological scar formation secondary to local inflammation. So whenever there are recurrent disc herniations, radiculopathies, there is bound to be inflammatory changes, and if it is recurrent, there is bound to be some fibrosis. This is because of the tissue trauma which happened in the epidural space. And of course, the major culprit is a surgery, and if you are repeatedly operating on a patient,
you are adding on to the epidural fibrosis and epidural adhesions. And almost it is said that 46%, although I hate to use this term, failed back surgery syndrome, 46% of post-laminectomy persistent pain syndrome, they have epidural fibrosis or epidural adhesions as one of the major cause for pain. And generally these patients who have fibrosis, either because of recurrent inflammation, because of disc bulges or because of surgery, they complain with severe paresthesias. They have leg pain like the one which we demonstrated to you, burning sensation in the back and the leg and back. There is a restricted mobility. We call them a spinal cripple because they are not able to do their activities of daily living. Their sleep hygiene is disturbed. The paresthesia are very unpleasant, and nothing much you can do with the help of medication. You may give high doses of pregabalin, you may give high doses of opioids, nothing works for them. You think that there is something in the mind, you do psycho-cognitive behavioral therapies, nothing works. Bladder and bowel may also be affected if it is the cauda equina which is being affected because of this fibrosis. Typical example, you can see the back of this patient who has been operated twice. A big laminectomy, discectomy and fusion was done once in 2014, 2019. This is nothing. I have had patients who had 7 operations, 7 surgeries of the spine, and he was ready for the 8th one till a neurosurgeon told him enough is enough. Now let's go for a pain management. So this patient presented with paresthesias, leg pain, back pain for last 1 year. Typical presentation of epidural fibrosis, restricted mobility, paresthesias in leg, unpleasant and lot of unpleasantness. So 2 to 4 operations, typical patient who would come with fibrosis would be MRI showing arachnoiditis and epidural fibrosis, recurrent disc herniation, non-restorative sleep, hardly 4 to 5 hours. And of course, if you do a subjective or objective evaluation, you will find that they are depressed and anxious because of the chronic pain. They have family problems, socio-economic problems, high dose of opioids. Unlikely that further surgery will help in management of pain. Often, as I mentioned, referred to as failed back, but it is better to call it as a post-operative chronic leg and back syndrome. And as you see, there is, the MRI would show you arachnoiditis and perineural fibrosis, epidural fibrosis, and I am sure as surgeon you would also agree with me that even another further surgery is not going to help. There is a recurrent disc protrusion, as you can see, the recurrent disc protrusion and lateral canal stenosis. All these are adding on to the problem. So basically you are left with no choice but to do something which is called epidural adhesiolysis. The diagnosis, of course, you can do a laboratory workup. If the patient has been operated recently, you may find some infection maybe. So just to rule out infection, because if you are doing any intervention, there should not be any post-operative infection. The best, as we were discussing in the morning, is a MRI with a contrast. So gadolinium MRI should be the best one to tell you whether there is enough of arachnoiditis or fibrosis contributing to the symptoms. So that's the best diagnostic test to find out whether a patient has epidural fibrosis. So once he has fibrosis, basically what do? Of course, surgery is out because any further surgery would add on to this problem. So we do a mechanical dissolution of this epidural fibrotic scar, which is resulting in axial pain or radicular pain, and which is refractory to conservative management. So of course you have given transforaminal steroids, you have given epidural steroids, but nothing is working. So what do? Basically you can do an intervention with the help of a specialized designed catheter which is called the RAX catheter. RAX is a pain physician in US who designed this catheter, and it is very helpful. All the morning we were doing with a epidural catheter, but this is a specially designed catheter which can move along the areas where there is fibrosis.
There is so much crosstalk here. Can we have some silence for the speaker? Everybody please quiet it down.
Wow, great. What a relief. So, so this is the C-arm positioning, generally done in prone position. And the best route would be a caudal route if you are targeting up to L4-5. But if it is L3, L4 or L2, L3, you may have to go through a interlaminar approach. But just like you put a spinal cord stimulator needle, you have to be going obliquely touching the lamina and then entering into the epidural space so that you can negotiate your catheter to the higher ups. But for L4-5 and L5S1 region, you can definitely go through this. So this is a RAX catheter, and you see this is a specially designed epidural needle which is curved, and this is the catheter, this is the stellate which is steel, and this then generally goes into the steel, the spiral tip catheter with a 15 degrees bend, and you can negotiate this catheter. Of course, on the fluoroscopy you see this catheter and you keep negotiating into the epidural space wherever you find a region after doing an epidurogram. Through the caudal root, the catheter is inserted. So first you put a dye, as you saw it in the morning, outline the adhesions and the targeted nerve root, like we saw the right-sided L5 was not being delineated. You put some hyaluronidase, about 1500 units, 10 ml of preservative-free saline, which could be hypertonic saline, along with 40 milligrams of triamcinolone. And then you keep the catheter there, and for 3 continuous days, admit the patient and continuously infuse local anesthetic hypertonic saline to break the vicious cycle as well as to break the adhesions which are there in the epidural space. And the same procedure is repeated after 6 to 8 weeks to get a very favorable results in terms of these adhesions. So this is what you see in a epidurogram, a typical Christmas tree appearance, but there is a filling defect in this region. So this particular area has to be targeted, and then we put this catheter in and then negotiate this. You can see the catheter going right up to the L5 nerve root, and we are putting the dye. You can see now the lateral recess is open, and you can see the S1 root also is getting open, unlike in the epidurogram which you saw no S1 and no L5. So this is how this adhesiolysis is done. This is the catheter through which, specialized catheter which has a filter also, which is put in, and then we tunnel it and then keep it for 3 days so that you can do a good infusion. Dural puncture can happen because this is a stellate which is made of steel. So if you are pushing it hard, you can and there are adhesions there, so you can produce a dural puncture. You can have the medications going into the subarachnoid and subdural space. Catheter can shear. This is a major complication because while pulling out the stellate, you can shear the catheter and some part of the catheter can remain there. This has happened. Infection, then of course hemodynamic instability, bleeding or aspiration from the epidural space, and of course there will be dermatomal numbness if you are using large amount of local anesthetic. Thank you so much. Thank you. In time.
We have time for 1 minute for the questions. If anybody has any questions or any comments are there. Yeah. Go ahead.
Yeah. I mean, like if you get a favorable result with the first procedure, you can repeat it after maybe 8 weeks. If you get a favorable result. Generally, this failback like post laminectomy persistent pain syndrome, where you expect adhesions, and you have done a contrast MRI which does reveal epidural fibrosis, or a patient who has recurrent inflammation because recurrent radiculopathy because of disc bulges, there also you can expect this. So those are also the patients where you can do it.
If a past surgery done properly,
Yeah.
proper indication, the failed back syndrome will not exist.
See, basically it is not a failed surgeon, it is the back which has failed. No? So don't think that it's a failed surgeon.
Inadequately performed surgery or inappropriately done. Suppose I have a joint arthropathy and you have to put the
Yeah.
disc. Not what happens. So before we do any surgery, understand the pathology. The pathology is the backache is not only disc prolapse, osteoarthritis, osteoarthropathy, osteoporosis, vitamin D deficiency, so many things, and we just jump to a small disc. And you know, cesarean and disc operation is the most unethical operation. You know that in the world. go to see that. Unethical operation in the world. 7 million unethical operation done in US per year, and mostly is cesarean and disc operation. If you don't believe, go to next.
Sir, I have a question. You told that you infuse the hypertonic saline over 3 days. So, do you give bolus or what rate?
Bolus of hypertonic saline, infuse normal saline.
Infuse normal saline. So at what rate you infuse it?
So basically, either you give boluses or you can give about 1 to 2 ml per hour. Of about 50 ml in 24 hours.
So continuous 24 hours?
Yes.
Okay.
With an ambulatory infusion pump. So you have those elastomeric pumps which we filled up with small doses of local anesthetic and saline and continue the infusion. And every day we give 20 milligrams of tamsuline alone.
Okay, 20 milligram tamsuline and 1 ml per hour.
50 ml of local anesthetic and saline for 24 hours.
Okay, thank you, sir.
How many, sir?
3 days.
3 days.
So epidural fibrosis is a real problem.
It is.
Many a times you repeatedly feel that. Isn't how far it is efficacious in those cases where?
To be very honest, it gives very temporary relief. It is not a permanent solution. These are the candidates where we are stimulator. So these are the most appropriate candidates for a spinal cord stimulation device.
Do you find in your experience like repeated epidural injection can cause epidural fibrosis?
Well, the literature definitely tells you. That's why like the American standard also, the Indian standard also, we don't go beyond 3 in a year. But my personal, I don't go even maximum 2 in a year.
So what we found in, surgery for prolapsed disc, when there is more than 3 injections, there is good amount of fibrosis.
It is there in the literature, but it has not been sort of validated in human beings. These are studies done in sheep where they did epidural injections every 4 weeks and they found some fibrosis. But in human beings, this has not been revalidated, or even MRIs have not confirmed that there was any fibrosis. But yes, surgeons' anecdotal experiences do say.
So I think we can move to the next lecture by Professor Giruval sir.
Yeah.
The CRPS and update.
Yeah. So Dr. Rajeev requested me to take this topic also because this is a very important topic. Slide down. Yeah. So this is a complex regional pain syndrome, a very common syndrome which we encountered in our practice. And this is like a typical patient who would come to you. In the 70s, these patients used to go to the rheumatologist because they had swollen fingers, trophic changes, not being able to move their fingers, and the GP used to send them to a rheumatologist thinking that it is a rheumatoid arthritis. So this is a typical patient complaining of severe wrist pain. He had a cast because of a radial fracture. And after removal of the cast, patient is complaining of burning pain, numbness, tingling, and you can see dark swollen finger, the inability to, you can see that the subtle change in the color of this, color of the hand. This is darkish, this is pinkish, and you can see the swollen fingers, trophic changes, etc. So this is a classical CRPS. This is an acute phase of CRPS. This is a chronic change. This is the stage 3 where the trophic changes have already set in. And again in the lower limb, it's an acute phase of CRPS. This can follow any trivial trauma also. An ankle sprain, patient may develop a CRPS. Or simple fracture, 2-3 weeks of plaster, and patient comes out with this. Why is it called complex regional pain syndrome? Because it's a very complex pain, varied and dynamic clinical presentation. Regional because it's a non-dermatomal distribution of pain, not in that dermatome where the pain occurs. Pain is out of proportion. It's a very trivial injury. Some friend holding the hand and twisting the arm results in CRPS. And the pain, the syndrome, because it's a constellation of symptoms. The constellation of symptoms are like pain, sensory, autonomic, motor, or trophic symptoms, which can no longer be explained. A trivial trauma, like you have just hurt your wrist and developing this. Paul Sudek, we used to call it as Sudek dystrophy. When I joined my MBBS, we used to call it as Sudek dystrophy. And Sudek was the one who in 19th century defined the signs and symptoms of reflex sympathetic dystrophy. He used to call it RSD or Sudek dystrophy, where there was an exaggerated inflammatory response, and then of course there was a osteopenia, osteoporosis, and all the associated signs and symptoms of dystrophic changes. The term CRPS came when this International Association of Study of Pain came, and they found there are 2 types of CRPS. CRPS type 1 with no nerve lesions, no nerve injuries, and CRPS type 2 where there is a nerve injury. And as neurosurgeons, you see a lot of patients with brachial plexus injuries, causalgias, nerve, peripheral nerve injuries because of trauma. These are all patients who have developed CRPS type 2. So type 1 initially is primarily warm, as you saw, pinkish and edema, that's a warm phase, and then it goes into the cold phase. So you should not allow the patient to go into the cold phase. The diagnosis should be at the earliest, and the treatment should start immediately. This is one patient which was sort of referred to me long time ago in AIMS only, from a neurosurgery department. He had a brachial plexus injury. He had a very severe allodynia that he had to always cover the arm for the hand with a cloth, and he used to keep pouring it. So that sort of a burning sensation he used to get. He had a history of trauma. The brachial plexus was injured. There was no motor movements, but the pain was really exhausting for him and very severe. So as I mentioned, acute warm phase and cold phase, and this is the diagnostic criteria. They should have at least one symptom out of this sensory, pseudomotor, motor or trophic, and at least one sign like allodynia or temperature differences, so you can measure the temperature, or there should be motor like decreased range of motion. So these are some of the self-reported symptoms, and these are signs which are observed on examination. If the score is 16, this is a patient who has complex regional pain syndrome. How to diagnose? Basically, you can rule out, like I said, rheumatology. So you can rule out by doing ESR, CRP to see. Initially, yes, in the warm phase, all these would be elevated. Anti-nuclear antibodies are a factor to rule out any rheumatological disease. And then the confirmatory test is a triphasic bone scan or X-ray. X-ray will show you localized osteoporosis. This is very significant osteoporosis, and a bone scan, triphasic bone scan, will show you the pooling of the dye in the third phase of the bone scan. And this is confirmatory. Any person with nuclear medicine experience will tell you that this is a typical bone scan of a patient who has CRPS type 2. Of course, you have infrared thermography. If you have this apparatus, you can take the temperature and you will see the difference between a normal and an abnormal hand, again confirming that this is complex regional pain syndrome. So the pathophysiology, whenever there is an insult like trauma, surgery, stroke, there is a classical inflammation, exaggerated inflammation. Then there is a neurogenic inflammation. That's why patient complains of burning sensation, autonomic dysfunction. That's why it's called sympathetically mediated pain. Central nervous system plasticity, psychological factors, all these contributing. So whenever you're treating CRPS, you have to take into consideration all these factors while considering the treatment part of it. Inflammation is very important, and sympathetic nervous system, like when we started, CRPS was like a sympathetically mediated pain, and we used to be told that you go and give a sympathetic block, patient will be better. But sooner or later we realized that it is not entirely the sympathetically mediated pain, only 50% is sympathetically mediated pain. The initial terminology, reflex sympathetic dystrophy, also mentioned that it is a sympathetic overactivity, but later on we found that it is an inflammation which leads on to this phase, and 50% of patients would be having a sympathetic overactivity. Multiple discrepancies undermine the possibility of sympathetic nervous system as a cause, like plasma catecholamine levels are lower. Most patients do not get a significant relief with sympathetic blocks. So that's why the terminology came in, sympathetically mediated pain or sympathetically independent pain. So doing a diagnostic block, if a patient gets relief, it says SMP. If he is not getting relief, it is a SIP. So we have various therapies, starting from medical therapies, like vasodilators, physiotherapy. In the acute phase, you can even put in steroid, like methylprednisolone, succinate infusions. They can really help. Of course, psychotherapy, sympathetic nervous blocks like stellate ganglion or lumbar sympathetic blocks can also help. Pharmacological treatment generally are steroid, bisphosphonates, calcitonin, vasodilators like nifedipine, and of course gabapentinoids are also preferred because there is an element of central sensitization. What we have got good results with a intravenous long-term ketamine infusion. Bisphosphonates are very good. As you saw, there is a localized osteoporosis. So immediately, as soon as you diagnose, you start the patient on bisphosphonates, either oral or parenteral, and they really work wonders. Tricyclic antidepressant, IV lidocaine,
calcitonin, very important again, gabapentin, nifedipine orally. Sympathetic blocks do work in the sympathetically mediated pain, so should be tried. But what I want to lay emphasis is on a new therapy which is called intravenous ketamine infusion. This is a stellate ganglion block, and you can see the patient is having a Horner syndrome. 3 months post-multimodal therapy after stellate, this patient is doing wonders. Now, ketamine infusion do have a role, and ketamine infusions, what we do is we give in a dose of about 1 milligram per kilogram body weight, and dissolve in normal saline and give it over a period of 4 hours. And every day we increase the dose. We give it for 6 to 10 days. We increase the dose by 25 to 50 milligrams to go up to maximum of 300 milligrams in 24 hours. And this is an NMDA receptor antagonist. Unfortunately, we do not have any oral drug which can block the NMDA receptors, but this works wonder. To be done under monitoring, to be done in a hospital setup, but fantastic desensitization, because NMDA receptors blockade happens, and the desensitization can only be helped with the help of these drugs which act on the NMDA receptors. Then mirror therapies are some sort of like whenever there are trophic changes, the mirror imaging graded therapy can help in mobilization of the, otherwise these trophic changes are very difficult to handle. So imagery, mirror imaging, like patient places a normal hand in front of the mirror, abnormal hand behind the mirror, he moves the normal hand, and involuntarily the affected hand also starts moving, and this is a very good physiotherapeutic or rehabilitation mode. So graded motor imagery, as we call it. So the carry home message is that CRPS is a constellation of pain, sensory, autonomic, motor and trophic symptoms. It is heterogeneous and a mixed pathophysiology. Some of sympathetic nervous system cause is there, definitely 50%. But the combination therapy helps, which involves pharmacotherapy, psychotherapy, physiotherapy, occupational therapy, and of course therapies like intravenous ketamine and sympathetic blocks. Thank you. Thank you very much. If there are any questions.
Sir, I think I'd like to add that hyperbaric oxygen therapy has a role in complex regional pain syndrome. It decreases inflammation and the swelling at the earliest and helps to rehabilitate.
Okay.
If there are no further questions, yes. Okay.
He described was similar to what we have discussed, and he had undergone multiple surgeries in the head. He had put it in behind the shoulder, the occipital region, in the back, and he said he had severe pain which is not responding to any other. We thought over and what we injected Ibuprofen and Ibuprofen right in the regional pattern wherever the cluster of threads were there. And retrospectively, I think that it was something of a
Absolutely. Yes.
See, that is the reason for retracted movement for long back, people have done frontal liquid to have the perception pain changed. See, when everything failed, if you go to olden literature, to treatment of intractable pain, frontal liquidotomy. So that the reaction to pain will not react. Prefrontal liquidotomy.
Yes, sir. And if there are no further questions, we will move to the next presentation by Dr. Energy on spinal neuromodulation.
सिंपोजियम बंद कर दे ये वाला Good evening, respected chairpersons, seniors, especially Dr. Mahabatra. Good to see him again, and my dear colleagues. So, what is neuromodulation? By definition, it is, the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents to specific neurological sites in the body, depending on the pathology and the need of your treatment. So this is the basic definition. Now, if we extrapolate this to, say, any neuromodulation for today's topic, spinal neuromodulation,
we can divide it into two broad groups again. One is electrical and one is chemical. In electrical, you have spinal cord stimulation, especially mainly or rather ethically used for pain. Then sacral nerve stimulation, some people consider it peripheral, but because you access the S3 through the spinal foramen, you can stretch it into this. And in the chemical group, you have intrathecal baclofen pump, intrathecal morphine pump, the first for spasticity and the morphine pump for intractable pain, especially oncological pain. But because of the theme of today's symposium and with respect to time, I will concentrate my talk today on my experience with spinal cord stimulation for pain. And I would like it to be an interactive session because I face many problems doing this, and would be glad if I get some answers from the August audience. So, coming to the basics. So, pain is like, it's just like there's a plethora of pain disorders. So, first and foremost, we have to pick up the right patient. For that, our basic, is this the marker? So, two important words, neuropathic and chronic pain. So, for any neuromodulation to succeed, the pain has to be ascertained as neuropathic. I will not go into the base definitions because the August audience is enlightened to it. Two words, chronic pain lasting more than 3 to 6 months, and it has to be neuropathic. Now, this cluster of pain, chronic neuropathic pain, is a tough nut to crack. There are various ladders and algorithms explained, but many cases, the last resort always falls on neuromodulation. So there has to be a sort of a running protocol. Different institutes have different protocols. In our pain clinic, what we follow is the patient with a chronic neuropathic pain should have at least tried judicious use of pain medications, physical therapy. Once these two are exhausted, not less than 2 interventions, whether it be a block or a corrective surgery. If these procedures fail, then the patient's, after ascertaining he has a neuropathic pain which is chronic, becomes a candidate for neuromodulation. And coming to the spinal cord neuromodulation, again from the same protocol what we discussed in the previous slide, there are two main syndromes which fall into that category. One is the failed back syndrome, which, Dr. Mohapatra has an objection with the term, but it is mainly, as you rightly elucidated in the previous discussion, it's mainly an improperly selected patient or an improperly done or overzealously done fusion rather than, a simple failed back surgery. So it's again goes back to the patient selection and the procedure selected. So that is one of the major indications for chronic neuropathic pain spinal cord stimulation. And second is, of course, CRPS type 1. The mechanism of action, it's still fuzzy. So there are various hypotheses which runs from stimulation of the dorsal column leading to gait control, increase in the concentration of the inhibitory neurotransmitters and decrease in the concentration of excitatory neurotransmitter with chronic stimulation, increased activity of the inhibitory interneurons, and also some supraspinal mechanisms which are implicated for the success. But the jury is still out regarding the exact mechanism of action, but it does work in properly selected cases. Now, why not an ablative surgery? Why such an expensive surgery? So there are definitive advantages. Not only it is a non-destructive and less invasive surgery, that is a given, but it is reversible. And if the pain increases or pain relapses, we can reprogram the device and go one up over the pathology. Almost, it provides you with a scope of a trial. Before you commit to the final therapy, you can have to do a spinal cord stimulation trial, which gives you an opportunity not only to gauge the patient response, the coverage area, as well as the response of the pain. It also provides an adjustment period of say around 5 to 7 days. And we have a thumb rule of a 50% reduction in pain in, say, a visual analog score. If there is minimum of 50% reduction at the end of the trial period, then you can counsel the patient that he is a reasonable candidate. Still, you can't predict 100% success, but you can say he is a reasonable candidate for a spinal cord stimulation. The dilemma starts here. What will you put? A percutaneous lead or a paddle lead? Now, my practice over the last 12 years has shifted, and now it started with purely percutaneous, and now it is purely paddle because of these very reasons. Unlike a percutaneous lead, a paddle lead provides less scope of lead migration. It's anchored to the You can connect it with, stitch it up with the surrounding connective tissue. So, because the migration is, there is less positional variation. And the footprint of a paddle is much greater. It gives you a better footprint, you can have a better coverage with a single lead. What I do in my trial periods, I use a paddle and then connect it with an extension wire. The extension wire is the one which is exposed outside for the trial. So if I get benefit during trial period, I don't have to take out the trial lead. I will keep the trial lead and just remove the extension wire and hook the trial lead with a new extension wire and internalize it. So there was always a danger with percutaneous leads that once you have a good trial, when you remove it, there is no guarantee once you are putting the final lead, you will hit the same spot. But a paddle lead negates that possibility. And of course, if you are doing a small laminectomy going in, an epidural scar is a predicament to the infiltration of the current into the dorsal column. So you can clear the epidural scar and hope for better efficacy of the spinal cord stimulation. So various reports are there in literature which confirm these advantages. We had our experience from Vedanta published earlier this year in AJNS, and it also verifies that paddle lead has got definite advantages over percutaneous cylindrical leads. Technological step is the simplest of all surgery which anyone can perform. So you just have to do a small laminotomy depending on the area where you want the spinal segments to be covered. For example, here I have put a quadripolar lead on a cervical for a upper limb CRPS. Here there is a dorsal paddle lead 565 configuration for a failed back syndrome. So the spinal segments you select according to the clinical the distribution of the pain. Under fluoroscopic guidance, we put the lead. It's a very simple thing. Do a small laminotomy, clear the epidural scarring, and just put it. The laterality you can adjust a bit. Suppose it's more unilateral, you have to shift towards one side of the center of the axis. That small adjustment, the simple adjustment you can do during the procedure. Once you have a successful trial period of say, at least 50% reduction in pain, the second stage after 5 to 7 days, you internalize the system, take away the old extension wire and connect the paddle lead which you have used for the trial with a pacemaker and internalize it, and that's the end of the surgery. Programming strategy, I usually use wide bipolar combination so as to have maximum pain coverage area, pulse width of around 210, rate varies depending on the response, and I tend to have different programs for different activities. There's a reason for it, I will come to that. So my personal experience, limited though, 31 cases, 23 were failed back surgery cases and 8 were CRPS type 1. The point here I want to make is, it's very all hunky-dory and rosy for the first 2 years. Patient will come to your follow-up and say, I'm doing fine. Problem starts after 24 months. As you can see, there is a sharp increase in the visual analog score scale after 2 years follow-up in my cases. So at the latest follow-up, the average VAS was 4.1. So patients are not doing that well, which they were doing at the start of the surgery or even up to 2 years. So this is something which I'm sure with doctors who are into spinal cord neuromodulation, this is something which is nightmare for us. The effect diminishes with time. There are various causes for that. Causes and hypothetical causes like maladaptive neuroplasticity, disease progression, diminution of placebo effect. But once you rule the obvious complication of lead migration and everything, you come to a point where you have to do something to the patient. There are some strategies which you can do, like periodic fine tuning of programming parameters, set different programs for different activities to negate habituation, on-off strategy, burst spinal cord stimulation. There are certain what is newer innovations coming up, like high frequency stimulation, not yet in India, and specific dorsal root ganglion stimulation for patients who are now refractory to even spinal cord stimulation. So what does the evidence say? I'll just conclude it in a short one, 30 seconds. So on long-term, utility of spinal cord stimulation, there is a plethora of literature. But there are two meta-analyses which I want to point out. One is by Duarte et al. In 2020. The conclusion was conflicting in long-term efficacy. Up to 6 to 24 months it was good, but in long-term there were, there were low to moderate quality evidence to say what happens after 5 years down the line. And most authors who were in these trials had conflicts of interest, industry-based. Another meta-analysis which had 12 randomized control trials in its parlance. See the last line. 11 of the 12 studies were industry-sponsored who told that the relief is more than 24 months. The only study which was non-industry sponsored, they said that the nerve stimulation method, they didn't find any difference compared to a traditional method or using an advanced spinal cord stimulation. So you can see the gray area. So if we have to have solid evidence based on which we predict to the patient that you will benefit this much and this is your prognosis, we need to have evidence also. And at present, till 2020, most studies are industry-based, industry-sponsored, and that leads to a great bias in concluding and confidently relating the outcome to the patient. Nevertheless, despite everything, if you have a good case selection, the results can be marvelous as well. The case in point is this present study. I will conclude my talk with this study. The 40-year-old gentleman was suffering from CRPS type 1, and it was so severe. It started on the left, marched to the around the neck and to the right upper limb, that he had developed reactive spinal myoclonus. Everything has been tried on him. Then after evaluation in our pain clinic, we offered a retrograde high cervical C1, C2 approach, paddle lead, and not only was he free from his pain, and we have now a follow-up of 72 months, because the pain went away, his reactive spinal myoclonus also disappeared. So these are some videos. You can see this patient was having such severe pain of CRPS that it was like a miserable life. Just to touch, a simple touch, he will throw into this vigorous spinal myoclonus. And this is the patient during the trial period, the second day of trial. You can see I'm touching him, there is no myoclonus, and the patient is quite happy with it. And next. Sound to this video. So there is a patient testimonial to this. I will skip it then. So the patient is saying that
about a week back with complaint of excruciating pain in both his upper limbs and the back side of the neck area, which he has been suffering for the last 12 years following a road traffic accident. Pain was severe, so much so that even to light touch, a feather touch, or touch of a clothes, it will initiate violent jerks or involuntary movements. Like he will be ferociously throwing his upper limbs back because of this very rare but excruciatingly nagging disease, what we call as complex regional pain syndrome.
डॉक्टर से मिले, कोई इधर बेचता था, कोई किधर बेचता था, उनके समझ में नहीं था कि मैं करे क्या। सबके पास आए, उन्होंने समझाया सब कि देखो इसमें।
With all due respect, Dr. Judeja was also one of those doctors. He gave him temporary relief with peripheral stimulation, but then couldn't carry on further.
ऑपरेशन चला हो, और उसके बाद मुझे अभी तक जल में 6 दाव के बाद जो मेरा टच सेंसेशन था वो 80% रिड्यूस हो गया है।
the retrograde high cervical spinal cord.
So I'll maybe
It's a pioneer in India.
So this case study was published in the BJNS, and coming to the conclusion, so spinal cord neuromodulation for chronic pain is on the upswing, but the most important thing is proper patient selection. The thing which I am being plagued with is someone give me some thoughts or some strategies to prevent the temporal diminution of effectiveness. And there should be proper clinical trials which should be industry independent to give honest outcome to the patients. And of course, with better understanding, neurophysiological understanding of the pain pathology and improvement in technology, we will have better results in future. These are some references. Thank you.
Thank you. Wonderful presentation. Because of short of time, we will move to the next presentation.
So next presentation by Dr. Siddharth Chowdhury. He is the eminent intervention pain physician in the Hyderabad, and he is our excellent president also. So Dr. Chowdhury, please. So he will be talking about non-invasive transcutaneous neuromodulation.
I'd like to thank the organizers for inviting me to talk on this gathering. We've talked a lot about interventional pain options, and we've talked a lot about interventional neuromodulation. So my topic is something slightly more esoteric, and once we can get it set up, I am basically going to be talking about transcutaneous non-invasive neuromodulation. So essentially it is going to be a mechanism where we modulate the autonomic nervous system to achieve, let us say, functional outcomes in certain disease processes. They may not necessarily be pain. We're talking about diseases which are, come under the purview of cardiology, urology, gastroenterology, even pediatric surgery for that matter. So if you'll bear with me for just a second. मैं आपको मेल कर दूं, ये जल्दी होगा तो
So we can move to the next talk. So we can move to the next talk. We can spend the time to rectify this session.
No, sir. So I think they're just looking for the cable.
Can we, if there is some technical problem, can we move to the next presentation? Dr. Dhruv called radio frequency and spinal pain management.
Yes, sir. Yeah, thank you so much. Okay, so this is my last presentation for the day. So today you would have seen me doing radio a radio frequency ablation. We only did one, and that was done by cool tip RF or cool lift radio frequency. So I will just start from where I left today morning when I was discussing radio frequency. So there I said that in traditional radio frequency, you need to be very clear with regards to anatomy. That is one. The active tip of the needle has to be placed in direction to that nerve. Right? So therefore you have to be very precise regarding the anatomy. Then what happened, and that was second, and the third was that we have to have a control over the temperature, because if we keep on burning or increase the temperature, there is going to be burning which will lead to charring, and that will effectively stop the transmission of heat or electricity leading to heat
in the surrounding tissue, and hence our radio frequency probe or the process will be not so effective. So imagine with that concept, what these guys did was they introduced a continuous water column at the active tip, by which the tip never got heated to an extent that the charring would happen. What advantage it made for us was, first was that we got a lesion which was, in a case of a standard RF, like a flame shaped thing, oval shape, and we had to be very close to the nerve or our target. In this case, and for people lazy like me, where you and you are dodgy with your anatomy, so if you are close to the nerve, this produces around 15 millimeter size of the lesion. That will make sure that even if you are here or there or not perfectly in direction, you can still achieve that lesion. That is one. Second is the charring, the chance of charring and everything gets grossly reduced. So with that concept, this cool radio frequency technology came into being. So what happened is, this is what I was exactly trying to explain, that you have a flame-shaped lesion and which is not there in front. So active tip has to be in direction with the nerve. Whereas when we talk about this, is there is a round lesion, that is one, bigger lesion, that is number two, and the third thing is that it is even in front of the middle. Therefore, when you could see me perform that medium branch, I could just be at the right at the middle to make sure that I could create that lesion. Whereas if I had to do it in the case of a standard RF, I had to be very sure that I was right in the place where the nerve is coming. Again, this is the temperature. This is 60 and 80. This is our sweet spot. If the tissue goes beyond 45, there is denaturation leading to ablation. So this is our sweet spot. So this is the entire thing where we can get that thing. This is the machine. This is the size that I was talking about. So 18, so entire thing comes out to be 50.
Okay, next one.
This is the particular lesion size. Now, one more thing, it is not, everything is not so positive about it. The few challenges what I have felt is that here it is a thicker needle, right? So it is, because it is a thicker needle, sometimes 60 also, subset of patients and indications issue that we need to be careful about. That is one. Second, not pertaining to spine, but sometimes if we are doing a radio frequency ablation of a superficial nerve, for example, a genicular nerve RF of a knee, especially the inframedial nerve, it is a very superficial nerve. So there are chances that we might damage there might be skin burning.
So aren't we delaying a process which has to be fixed right now? The problem lies at the joint instability. We are not dealing with joint instability, and we are in fact blocking that pain which is arising from a defaulted or imbalanced joint. So if we go for joint fixation earlier rather than we are just suppressing that pain.
Now this was something we probably have.
We are not dealing with joint instability, and which was
these are the cervical processes, not very to have a medium branch block. Again, very effective treatment. Now this is what I am doing it in a AP view. We can do it right in the AP view as well as in the lateral view. So this is what we call it as the articular pillar. We just need to be at the center of the articular pillar. This is what we did today. No, again, we go about the facets and everything. So there is something included which we can do for a discogenic pain also. We can do a bipharoplasty in which we are getting a bipolar kind. We are introducing two needles inside the disc, and both these discs are in the posterior annular part,
and where we are denervating the disc. So this is done for discogenic pain, where it is more of degenerative changes rather than debulking what is required in those spine patients. So a small thing, it's an effective method, gives us a large margin of error, and good evidence is there for long-term relief. But what Sir just talked about, I do believe that what of data that has come out in the recent past is company sponsored, and this is one thing which I always feel. But right now what I feel is that the results are equipotent to the ones of standard RF. Only thing is that you can be slightly more casual when we are doing it. Post-procedural pain, that is one thing which is a thing of bother. Thank you so much. There were a lot of questions when post-procedure, so if you have, please ask. We have a few. I can take, I think, a couple before we start. Any questions? Yeah. Very good. So the thing is where you don't want to create a larger size lesion. So for example, for a trigeminal, where you will never go for a cool because you want a smaller lesion. Something like an intercostal neuralgia, you will not like to go for this kind of a thing. But most of the other causes where it is giving you that margin, for example, denervation of the joints like knee, shoulder, hip, SI joint, where you want large, big lesions, splanchnic nerve block for patients of upper GI malignancies, there definitely you can go for this versus the standard RF.
One more, with the advent of pulse RF, how do you see the pool RF?
So, sir, the thing is the pulse RF is not a neuroablative procedure, it is more neuromodulatory. So, where we want to do ablation, the choice is very clear. It is between standard RF or cool tip RF. But if you want to do something like a neuromodulatory action, there we can use pulse radio frequency. So for example, what I generally do is, if I have a patient of a chronic carpal tunnel syndrome, so what I'll do a nerve block, along with that I'll do a pulse radio frequency. So that will actually help in the recovery. The same goes if I have a patient of chronic adhesive capsulitis, patient has been restricted movement for a long time, so there I will go for a radio frequency ablation of the suprascapular nerve. Fine. Thank you so much. Any questions? There were a few when we were doing the procedures. Fine. Thank you so much. Yeah, thank you so much. Take care.
The next speaker is Dr. Siddharth Reddy.
Yes, hopefully.
He's talking on non-invasive transcutaneous neuromodeling.
अभी चल रहा है क्या तुम्हारा? That's fine. एक मिनट. Yeah, so we're going to be talking about transcutaneous non-invasive neuromodulation therapies. So basically when we talk about neuromodulation, it is the alteration of any nerve activity through targeted delivery of a stimulus. So whether it is electrical stimulation, whether it is a chemical agent to specific sites within the body. So you want to modulate, so that's either normalize or to attenuate nervous tissue function. Now, we've been talking about spinal cord stimulation, we've been talking about RF, all of these are neuromodulatory modalities. One that we haven't talked about is percutaneous or transcutaneous modulation. So in this presentation, we're just going to run through this quickly. What are the different techniques? What are the outcomes vis-a-vis invasive modulatory therapies? And what is their clinical application? Now, there's a lot of focus recently on using certain approaches when it comes to non-invasive neuromodulation. Primarily, we are looking at either the vagus nerve or the sacral complex. So whenever you have neuromodulation, like the previous speakers said so beautifully, the problem is achieving a clinically relevant therapeutic endpoint, having it stick, optimizing the location where you stimulate, optimizing the parameters of stimulation, and the miscellaneous off-target effects that you get. These are the major concerns whenever you talk about any form of neuromodulation. So now when we're talking about non-invasive neuromodulation, broadly we can divide it into cranial versus peripheral. Cranial, we'll talk about either transcranial magnetic stimulation or MR-guided focused ultrasound, and that is beyond the scope of our discussion today. What we will talk about is vagal, sacral, and posterior tibial nerve modulation. Now, when you talk about the vagus nerve complex and the sacral nerve complex, there's a lot of research about this, because whenever you stimulate these directly, so vagal nerve stimulation or sacral nerve stimulation, this has been approved for epilepsy, it's been approved for major depressive disorder. When you look at sacral nerve modulation, it's been approved for overactive bladder, urinary retention, fecal incontinence. So these are very attractive targets, primarily because for a single nervous complex, they innervate an extremely wide area of tissue. Now, vagal nerve stimulation alone, so the indications can be neurological like migraine or epilepsy, and this can be either invasive or non-invasive, major depressive disorder, chronic tinnitus. A lot of the work we are doing at our hospital is on cardiac and GI neuromodulation, whether it be invasive or non-invasive. So we've been doing a lot of vagal nerve stimulation for conditions like arrhythmogenicity, atrial fibrillation, heart failure with reduced or preserved ejection fraction. GI neuromodulation, and we'll come to that, is patients with functional GI disorders, patients with dyssynergic defecation, IBS, Crohn's disease. So a lot of this therapeutic mechanism of when you stimulate the vagus nerve peripherally, and that's primarily through the ear, is thought to be mediated by concentration shifts of norepinephrine, GABA, as well as acetylcholine within the CNS. So these concentration shifts will lead to changes within the cerebral cortex and alter neuroplasticity. Now, all of us know about the vagus nerve, so it's a major component of the autonomic nervous system, important role in metabolic homeostasis. Neuroendocrine immune axis is another major role through afferent as well as efferent pathways. Now, left cervical vagal nerve stimulation is something that all of you are very familiar with, because vagal nerve stimulators are available for refractory epilepsy as well as major depressive disorders. Right cervical vagus nerve stimulation is the area of interest where you're talking about heart failure as well as GI disorders. Now, the ear basically is an attractive target for when you want to do vagal nerve stimulation, because it's got an extremely complex innervation. It's been innervated by the auriculotemporal, the vagus, as well as the greater auricular nerves. Now, this is basically a relay station that affects other brain areas which are involved in autonomic control as well as pain. So projections of these vagus nerve extend to the ventral medulla, hypothalamus, amygdala, and spinal cord. So this is why when you do a peripheral field stimulation of the vagus nerve near the ear, you can have alterations in neuroplasticity as well as firing rate within the amygdala as well as spinal neurons. So you have significant modulation at the spinal, at the dorsal root level, as well as at the central level. Now, when you talk about the ear, so the anterior superior aspect of the ear is innervated by the auriculotemporal nerve. The inferior wall is innervated by the greater auricular nerve. Now, the superior ganglion of the vagus nerve will give off two branches, and this will innervate basically the posterior superior wall of the acoustic meatus. Now, this area is primarily called the cymba concha as well as the concha. So, these are the targets which we use for auricular vagal nerve stimulation. So when we talked about the auricular branch of the vagus nerve, as soon as it comes out of the jugular ganglion, it basically accompanies the inferior ganglion of the glossopharyngeal nerve. And then it will ascend through the lateral surface of the jugular fossa and run along the temporal bone. So within the mastoid, after that, it will basically course over the canal above the sphenomastoid foramen and then divides into two branches, which is what we talked about. The first branch is going to give off branches to the dura mater, and it has a connection with the chorda tympani, which is a branch of the facial nerve. The second branch will give off two small nerves. One of them connects to the posterior auricular nerve, and the second one innervates the posterior inferior or posterior superior skin of the external auditory canal and the tympanic membrane. Now, this is the nerve we are primarily targeting, the second branch of the vagus nerve. Now, there are a lot of treatment modalities which are available for vagal nerve stimulation. So this is a device which was called Gamma Core. It's non-invasive neuromodulation which is applied directly to the neck, and it's being used for refractory migraine. This is a device which is in development where you attach it behind the helix, and this is what we have been using at our hospital. These aren't commercially available. They actually need to be imported from Australia. But essentially, it's a clip, and the clip attaches over the Simba concave or over the tragus. And what you're doing there is you're going to stimulate this constantly with a TENS device, a commercially available TENS device with stimulation parameters of your choosing. And the stimulus intensity is set to whatever the patient can tolerate. And this tolerance is going to keep increasing with duration. Now, when we're doing this in the vagus complex, what we're looking at is cardiovascular, GI, as well as immune modulation. So, antidepressant effect of the vagus nerve stimulation. So, you have alternation of the connectivity of the default mode network. Like we said, there is a lot of change in the firing of the amygdala, hippocampus, and the hypothalamus. So, you have a significant effect on patients with major depressive disorder. Cardiac applications. One of the primary reasons for many cardiovascular disease is an elevated sympathetic drive. So whether it is heart failure, whether it is hypertension, whether it is atrial fibrillation, ultimately what we're looking at is a hyperadrenergic status. So when you do electrical stimulation of the inner tragus, which is this vagal nerve stimulation, you activate parasympathetic efferents. And what it has been seen is you have reduced heart rate, you have reduced episodes of atrial fibrillation, and improved heart rate variability. So this again is a interesting area of research where as far as cardiac conditions are concerned. When we talk about GI neuromodulation, which is what I said we're doing, auricular neurostimulation in adolescents with irritable bowel syndrome improves abdominal pain scores, improves consumption of narcotics, improves depression scores. So you're looking at overall improved quality of life as far as these patients are concerned. When you look at functional gastrointestinal disorders in adolescent patients, you're not really looking to intervene too much in this patient group. And again, you have improved functional outcomes, you have improved cognitive scores, and as compared to sham. Now, when it comes to PTNS stimulation, so because it's very closely associated with the tibial artery, the tibial nerve is called the posterior tibial nerve. So it basically originates from the L4 to S3 roots, which are composed of motor as well as sensory fibers. So now the interesting part is pelvic floor muscles, bladder sphincters, bladder destrusor muscles are all innervated by the same root values. So now when the posterior tibial nerve is so easily accessible, it provides a very interesting area when you want to stimulate it. So the exact mechanism is unclear, but the logic being because the sacral plexus has the same root value and because the posterior tibial nerve is a branch of the sciatic nerve, retrograde stimulation of this nerve will provide neuromodulation of afferent pathways to the bladder. So patients with overactive bladder, incontinence or fecal incontinence who do not respond well to conservative or pharmacological therapies are quite good candidates as far as percutaneous or transcutaneous tibial nerve stimulation are concerned. There is a device by Medtronic which is still not available in India, but again conventional TENS devices can also be used to stimulate with reasonable effects. Now, as far as evidence is concerned, urinary incontinence and overactive bladder, urge incontinence, there is quite excellent literature to suggest that transcutaneous as well as percutaneous tibial nerve stimulation leads to good outcomes. Home-based, this is one major advantage. The patient doesn't have to come to the hospital. The TENS machine is relatively cheap. And it basically involves 30-minute sessions daily for about 8 to 12 weeks. Compliance is usually not an issue. And when you measure it with metrics like urodynamic studies, usually the patients will have pretty good outcomes. Transcutaneous sacral nerve stimulation, like we said, you can stimulate the posterior tibial nerve in the leg. You can stimulate the sacral nervous complex directly over the foramina. So again, the same patient population per se, overactive bladder in children. So they had a study which compared transcutaneous sacral nerve stimulation versus oxybutynin. And what they concluded is that they were both very effective therapies as far as pediatric overactive bladder is concerned. So, but electrotherapy was shown to be more effective over a prolonged duration of time. Thank you. Of which one, sir? So we do a fair amount of cardiology indications for auricular stimulation. And like I said, there is improvement in heart rate variability. The endpoints of the cardiologists look for are kind of different from what we consider. So they look at AFib burden. So when they're doing 24-hour Holter monitoring, so the AFib burden is significantly lower. They're also looking at remodeling and cardiac biomarkers. And while we haven't done it per se, there is a lot of literature to suggest that cardiac biomarkers also improve with time with sustained auricular stimulation. ETNS, we've been doing for primarily patients who have undergone dystrophism surgery. So, I mean, long-term data on that is still awaited, but yeah. Fecal incontinence. Yeah. Correct. Yeah. So as far as fecal incontinence is concerned, sir, it depends on the etiology. If you're looking at somebody who's got sphincter failure, typically the standard patient that we get, because it's a primarily GI setup, is we get patients who have post-LAR syndrome. So they have sphincter failure after LAR surgery. In that subset of patients, if you do invasive sacral nerve modulation, I'm not talking about percutaneous or transcutaneous, you have a 70% improvement in symptoms long term. That is the data that is there. Yeah. Yeah.
So, if there is no further question, I will request Dr. Siddharth to continue with his second talk.
Yeah.
On hypogastric plexus and splanchnic nerve neurolysis for visceral pain.
So, yeah. So this may or may not be of particular interest to a large subset of people here, but
Before you start, what's the cost of that stimulator which you are talking?
Which one, sir?
This one.
So if you're doing transcutaneously, the TENS machine typically will retail for around 5,000 to 6,000 rupees. That's it. That's a one-time purchase. If you're looking at sacral nerve stimulator insertion, that's a total package cost of around 10 to 12 lakhs. It's cheaper, sir, but yeah. No, 2-3 lakh का फर्क है.
I'm sorry, you can continue.
Yeah.
You can continue.
Yeah, the auricular nerve thing we imported from Australia, and we are planning to basically produce them ourselves. But that's about 25 Australian dollars. It's compatible with your standard TENS machine. Sir. Correct. Correct. So, visceral abdominal pain, again, it's a complex and challenging issue. It arises from diseases affecting internal organs, so it's very difficult to distinguish it from somatic or neuropathic pain. Can be continuous, episodic, provoked, unprovoked. There is actually really no way to predict how visceral abdominal pain really manifests, which is what makes it difficult to treat. So around 25% of the global population is going to experience chronic abdominal pain at some point in their lives. The patients who typically present to us will have chronic pancreatitis, pancreatic malignancies, other GI malignancies, IBD, or functional gastrointestinal disorders. So again, we talked about the vagus nerve, we talked about the sacral nerve. Grossly, all of GI innervation is the same. So you have vagal efferents, you have thoracolumbar pathways, and you have sacral nerve and pelvic nerve pathways. Now, the primary area of interest as far as we are concerned, where GI innervation is concerned, is thoracolumbar pathways, where efferent axons from the GI tract that respond to painful stimuli, as well as efferent sympathetic pathways are there. So this is the area that we're looking to modulate. Now, when you talk about a splanchnic nerve block, a lot of people are familiar with celiac plexus blocks. So splanchnic nerve block is a kind of extension of the same. You want to do it for chronic abdominal pain, you want to do it for chronic pancreatitis, failure of celiac plexus blockade, patients who have abdominal angina, as it is called, or patients who undergo acute pain after arterial embolization for liver tumors. Now, as far as the anatomy is concerned, the abdominal viscera is going to receive sympathetic innervation from the anterolateral horn of the spinal cord. All the fibers that run from the spinal cord are going to synapse at the celiac plexus. Celiac plexus, just before it, there are 3 nerves, the greater, the lesser, and the least splanchnic nerve. So the T5 to 9 is greater splanchnic nerve, T10 to 11 is lesser splanchnic nerve, and T11 to 12 is the least splanchnic nerve. So all the 3 together are going to synapse to form the celiac ganglion. And this is where you typically block it. The celiac plexus blockade, which is conventionally known, are responsible for supplying the abdominal viscera, like esophagus to colon. Everything is celiac plexus. So this makes it a really attractive target as far as abdominal pain is concerned. Now, the reason why we would choose a splanchnic plexus block is because it offers itself as a very good anatomical target. When you look at this, you have an area that is bounded medially by the vertebra, laterally, by the diaphragm, inferiorly by the diaphragm. You got a very well-defined area within the paravertebral space. When you do celiac plexus blockade, you have complications where you're trying to basically bend the needle around the vertebra, and you want to get the drug anterior to the aorta. Whether you go around the aorta, whether you go through the aorta, you're ending up in very close proximity to a major vascular structure. The other problem is most GI malignancies will tend to encase the celiac plexus as well as the different branches of the aorta as it comes off. So this area is a pretty good target as far as it's concerned. You just move one level higher, D10 or D11, and you're able to block the greater, lesser and least splanchnic nerves. Like most of the procedures that you saw today, the patient is positioned prone, buttresses under the chest and the abdomen to reduce the curvature. You want to look at the inferior border of the D11 or D12 vertebra. This is an extremely oblique view with parallax eliminated. The target for the needle is the inferolateral boundary of the vertebra. And essentially what you want to do is manipulate the needle in the space between the vertebra and the rib to move it to the junction of the anterior 1/3 and the posterior 2/3 of the vertebral body. At this point, contrast is usually injected. So the contrast spread is typically like this in the lateral view. You get some amount of spread off to the side and to the front of the vertebral body. You want the contrast to hug the vertebral bodies, and in the AP view, you want it to just outside the lateral border of the vertebral bodies. Too lateral, you're in the muscle. There is also a risk of inadvertent pneumothorax and chylothorax because you're doing it very close to major structures. Vascular injection, nerve damage, epidural as well as subarachnoid injections have all been reported because you're halfway between the foramen as well as the retroperitoneum. Whenever you do this procedure, diagnostic block is done with about 5 to 10 cc of local anesthetic on each side. If you want to do a neurolysis, the same sitting, we usually give around 10 cc of absolute alcohol. When you do a sympatholysis of a major nerve within the thoracolumbar plexus, you are going to have orthostatic hypotension 40 to 50% of the time. Post-procedural referred pain usually radiates to the left shoulder, usually subsides in 24 to 48 hours. Like I said, retroperitoneal hematoma, bowel injury, renal injury, pneumothorax, as well as injury of any kind of neurolytic agent into the artery of Adam-Kivitz all lead to really bad complications. When it comes to literature, this is a recent article from 2021. As opposed to maybe celiac plexus blockade, splanchnic plexus block has pretty good outcomes as far as unresectable pancreatic cancer is considered. Now, there is a problem where there is a need for this kind of intervention in our practice. Patients in developed countries, patients with access to insurance usually will get intrathecal morphine pumps. Most patients can't afford 10 to 12 lakhs once they are diagnosed with terminal cancer. So this gives them pretty good quality of life for anywhere between 3 to 8 months depending on disease progression. As an extension of the same thing, the superior hypogastric plexus is situated in the retroperitoneal space. It extends from the anterior portion of the L4 and L5 vertebral bodies to the upper border of the S1 vertebral body. Now, the lumbar sympathetic chain supplies the afferent and postganglionic efferent fibers, whereas S2 to S4 will supply the parasympathetic fibers. So this travels inferiorly as the inferior hypogastric plexus, and eventually it will form the ganglion impar. So like we said, abdominal pain, which is secondary to malignancy, this is indicated for pelvic pain that is secondary to malignancy. Endometriosis, causalgia, reflex sympathetic dystrophy. This is a lot that we see, proctalgia fugax, as well as radiation colitis or radiation enteritis. This block tends to do quite well in those patients. Again, patient is positioned prone. Now this is an interesting approach, and this is what we usually do, as opposed to, you can again bend the needle around the vertebral body to access it, or an easier option is to go transdiscally. So what we do is we square off the L4 and L5 vertebral bodies, and we go through the L4, L5 disc. So you puncture the annulus posteriorly, You inject contrast, you do a discogram, you know you're inside the disc. Once you engage with the anterior end of the annulus, you take a glass syringe or a loss of resistance syringe, and it is done in the same manner as an epidural. You keep injecting air until you feel loss of resistance. That is when you are just anterior to the annulus. So after careful aspiration, this is not really very clearly visible, but a contrast spread is seen anterior to the vertebral bodies. It usually flows from L5 to S1, and on the AP view it should be dead midline if you're doing it transdiscally. So again, after proper needle placement, 5 to 7 ml, around 10 ml of preservative free local with steroid is injected. Again, usually it leads to about 3 to 6 months of good pain relief. Alcohol neurolysis is usually not a very viable option as far as this plexus is concerned, because of the risk of intravascular injection, hematoma, subarachnoid injection. The major concern here is the proximity to the ureters and the bifurcation of the iliac vasculature. So when we do this procedure, we have to do a contrast, you have to do a continuous fluoro, and you have to be very sure of where you are so that you avoid hitting the ureters, so that you avoid hitting the iliac vessels. Just as an aside, this is again something that we do. Chronic abdominal pain, functional abdominal pain with no good cause, with no good treatment, refractory to all other mechanisms of intervention. There is a lot of literature to suggest that spinal cord stimulation is of benefit in this patient population. So you have a high dorsal stimulation pattern, and again, we're talking about the thoracolumbar sympathetic pathways. These are what are modulated by this stimulation pattern. And again, like we talked about splanchnic nerve neurolysis, splanchnic nerve radiofrequency ablation is also viable. Just the difference is you do D10, D10, D11, D12, 3 stacked radiofrequency needles on either side. And this also leads to good outcomes in patients with chronic pancreatitis where you don't want to do a neurolytic procedure. Thank you.
Thank you, Siddharth, for the wonderful presentation. We will move on to the last presentation in this session by Dr. Mahendra Singh Chauhan, headache and disc pain understood through pain matrix.
Good evening. I hope most of you are still awake. So I'm covering two topics, the interventional headache management and peripheral nerve blocks. Just to give you a follow-up, the patient that we did occipital nerve block has gone down from VAS of 7 to 2. The husband has just called me, and both of the pain are now almost gone. So headache has been a long-term problem for me because my mother had suffered all her life because of headache, and at least twice a week she would be in bed because of that. And then my wife, ever since I met her in 1992 till recent past, had constant headaches. So when you see headaches and you wonder what's happening, the last account that I knew of the several books and several journals, I knew that the pain comes from intravascular, the intracranial part. And then recently last year, what happened that I saw a case of auriculotemporal neuralgia, and then the focus went out extracranial. So now this became a very interesting journey, and we started doing more and more of these headache blocks, and I'm presenting my experience of last 1 year of 93 cases. So I believe now that we should focus much more extracranially than intracranially. One of the first conclusion which proves that it is extracranial was done by Professor Guyron when they did electron microscope and proteomic comparison of trigeminal branches of these nerves, and they showed that there is dysregulation of myelination process in patients with migraine headaches compared with controls. So this was the first evidence. Another thing that I wanted to draw your attention to is a beautiful paper written by Ronald Melzack, and this was in 1990, Pain and the Neurometrics of Brain. And this is something which shows you the mechanism of chronic pain, which has got no survival advantage. Of course, this topic is so big that it requires a separate presentation, so I'll just touch from outside. It just says that the patient, every person has got 4 components. The one is a body self neurometrics, which is a 3-dimensional perception of pain. And then there is cyclical processing and synthesis in which the neurosignature is produced. The sentinel neuron hub, which perceives or which converts the flow of neurosignatures into the flow of awareness, and then activation of an action of neurometrics to provide the pattern of movement to bring about the desired goals, which means that patient with the chronic pain can have a particular gesture or a particular body posture. So this is a paper you must read before you start treating the chronic pain syndromes. So in short, it says that there is no pain cortex, so there is no specific target which you can manipulate. So we expect the sensory, just like we expect sensory and motor cortex where we do surgeries or lesioning. So with this, I would come back to the headache. So Guyron was one of the major person who did a lot of migraine surgeries, and he classified things into from site 1 to site 6. Site 1 is supraorbital supratrochlear nerves in the frontal region. Site 2 is temporal zone, which is zygomatic branch of the temporal. The rhinogenic trigger zone is site 3. The lesser occipital nerve is site 4. Site 5 is auriculotemporal nerve, and site 6 is greater occipital nerve. Now I would like to give attention, and most of you should remember them, that there are these 3 points on the temporal side, then few points here on the forehead, and then these are the secondary points, these are the trigger points, and posteriorly 1, 2, 3 and 4 points on each side, which can show you that the pain is coming from here. Any headache patient comes to you, if you just press these points, you will come to know that the trigger is coming from somewhere in these points. In chronic patients, you can have all of these points activated, so we have to wait till we reduce the mutual induction of these nerves because of chronic pain. I would also like to draw your attention to this dissection, where you can see that there is a huge anastomosis happening in all of these branches from front to side to back, and then because of these, the pain in chronic migraines or chronic pain for the headache, it means that it is spreading from everywhere to everywhere. From it may start from the back, it can go to front, and I'll show you that these patients who I have seen, I have a patient who had continuous headache for 24 years, entirely devastated life, sold her house, husband left her, job was left, became very poor, traveled 3 countries, and still she had headache. I'll show you that case later. So anterior to auricle, there are supratrochlear and supraorbital nerves, then auriculotemporal, which is V3 on the side, and the zygomatic temporal nerve, which is V2. Posterior to auricle is lesser occipital, C2 and C3, greater occipital C2, and third occipital, which is C3. So posteriorly also, lesser occipital nerve anastomosis with great auricular nerve, which is the cervical plexus, and with occipital branch of posterior auricular nerve, which is in turn a branch of facial nerve. At vertex, we have accumulation of all these nerves, and then so vertex, sometimes patient will come to you with only vertex pain or vertical pain. In a nutshell, there is a rich anastomosis across the scalp within the branches of trigeminal, facial sensory, and cervical plexus. Now, these are the triggers which are in the temporal region. Particularly, if you see these zygomatic temporal nerves, if a patient comes and says that my trigger or my pain starts from temporal region, then you have to ask him whether the pain is outside the hairline or inside the hairline. So this, if it is outside, then it is a zygomatic branch of the temporal, or if it is behind the hairline, then it should be auriculotemporal nerve. And it all started with a guy who came to me who had traveled 3 countries to get his pain treated, where he had pain only related to this region, which was auriculotemporal nerve. So he just jokingly told me that, can you cut this nerve which is here, whatever it is? And I said that, okay, I can cut it, but I don't know what will be the result. But then I pondered upon few papers which were describing auriculotemporal neuralgias. So now, instead of going into the types of migraine and cluster headaches, I would say that most of these are just neuralgias. And the more literature you would find, you would realize that these are exactly like trigeminal neuralgias, where either a tissue band or a blood vessel is overriding a vessel which is causing pain, and that's why we also get throbbing pain. So if you start thinking extracranial for headache, you would find so many answers, and these are so easy to treat. This particular point is called as a vulnerable point for zygomatic temporal nerve, and most of the pain it comes from here, even because if some patient has got too much tense, the muscle hypertrophy happens because they are clenching their jaw. So these two muscles, they can actually have pain because of very tense musculature which becomes hypertrophic with time. Now another thing which you should know, that the descending nucleus of the trigeminal nerve, it goes down, and this is the one which is particularly carrying this pain sensation from the face and then from the throat, which interchanges information with the C1, C2 and C3, which is supplying the posterior. So if you've got patients who have so much of pain either coming from the front or in the facial region, which is then referring to the back, or they can have a back pain, occipital pain, which is coming to the face. Like today's patient, she was complaining of pain of the occipital region, which is going typically up to the vertex, and then she was also having referred pain in the eye and in the ear. So now, how to tackle the individual zones? First of all, we'll see the orbital frontal zone, where we usually get a supraorbital, supratrochlear nerves. It is very easy to palpate. All of us know it. Most of the neurosurgeons know right from their ICU or their Glasgow Coma scale examination. So we have always elicited pain in a comatose patient. You can have several types of bands over here. This blue is a fibrous band. So with this fibrous band actually converts this partial fossa into complete foramen, and it can be of various types, type 1, type 2, type 3, although it doesn't matter when you're doing a surgery or first you're doing a block. So it can be a simple band, it can be a band with a division, it can be a band called as inverse T, it can be a band with a calcification nodule, or it can be a band with a partial bony canal, so that there are two foramen, one is supraorbital and another is supratrochlear foramen, or there can be no foramen. But when you are treating them, it's more important is whether they are tender or not, whether they are a trigger point or not. Another thing which also can cause pain is the glabular muscles which are here, which can also, the nerves are supposed to go from behind the belly of corrugator supercilii muscle or these glabular muscles. But another trigger point can be here, and there are now endoscopic subgaleal surgeries happening. Plastic surgeons are doing for a long time. I wonder why neurosurgeons are not doing them. But I intend to do them, and we are actually looking for cases. But right now, my patients are so happy with the blocks. So this is where we can do the blocks. Although from the midline you go up to 2 to 2.5 centimeters, and you can find these trigger points. But I always rely on trigger points. You push them wherever there is sharpest pain. You mark them with a marker pen, and then you can block it. So this is the orbital frontal subgaleal surgeries which can be done. Though we are expecting maybe next year, if I present something like this, we have some experience of doing these endoscopic surgeries. But for now, we have patients who are extremely satisfied with the blocks. So temporal region, this is very simple, 3 points, and then this is the zygomatic branch where you can push it, and then, so there are usually 3 points. You go behind the line, you can go to the auriculotemporal nerve, you can go to the zygomatic temporal nerve just behind the orbital margin. So this is the surgery that I did for first as a auriculotemporal neuralgia, where we found that there was a blood vessel which was tortuous superficial, the temporalis artery, which was over the nerve. So I did 2 surgeries. I cut the zygomatic temporal nerve, but auriculotemporal nerve we just decompressed vascularly, and patient got a complete relief. In occipital region again, usually these nerves, they have an interaction like this one. You can see either it can be perforated, it can be looped around, or it can be pressed by. And then if you press these points which are there, then you would find most of the pain is coming from here. and then you can start doing the injections. So these are the cadaveric studies where the history of the patients who had headaches, and they were found to have the bands like these, and then you can also see that the occipital nerve is perforated by an artery, an occipital artery. And these are the live surgeries done in some patients. Now another question is Botox versus local anesthetic, and I would say that Botox is not required, although they are very frequently described in the books. But when the trigger is a nerve which is in turn causing a muscle contraction, why don't we relax the nerve? Why don't we tone down the nerve so that the muscle gets toned down automatically? That's how I do a lot of selective dorsal rhizotomy procedures. There's no point in cutting a tight muscle when you can cut a nerve and reduce the neural output. So similarly that. So I don't know why Botox is given. I'm not giving, it's very costly compared to just local anesthesia, and I'm getting pain relief for up to 6 to 8 months, in some cases even up to 1 year. So these are the certain landmarks which I just want to give a reference for occipital nerve. Then we'll go for some cases if you want to know. Can we get an audio output? चल नहीं रहा Okay, maybe the video is not, but you can see this patient is weeping, and she kept coming to me. She needed 3 sittings over 6 months. She was pregnant, so we couldn't give her medications anyways. But then after 3rd sitting, she has got more than 90% relief. This patient, 4 years of persistent headache, almost daily, completely satisfied. Now this patient is the one I was talking about. She was working in Kuwait, and then because of too much absenteeism, she was removed from the job. And then her husband left her, then she had to sell her property. She went to USA, UK, nothing happened. For the first time we gave her a block, and then now with the 2 setting of injections over 6 months, she has got more than 80% pain relief. Another girl, her head was thrown against the wall in a madrasa. She had a headache every day for last 19 years, and then I gave her injection, and then you can see that she's very happy after that. So in a nutshell, just remember these points and start hitting them. And very soon you will become an expert doing all of those things. And so 93 cases, 76 females, 17 males, average age was 38, youngest was 14 years, average duration of relief was 4 months, average benefit of VAS was 6 points. And return within 7 days was 6 cases, low grade infection in 1 case, no hematoma, no failure. One more thing which I want to show here, I needed time for that. I already told that something which was not covered in disc pain management or spinal pain management was toxic annular tears. Am I allowed to speak?
I think we can conclude as it is.
2 minutes. Because without this, if you don't understand this, then I think we are not doing justice to spinal pain management. Anyone sees anything in this MRI? This one, yeah? How does it look like when we do endoscopy? It looks like this. This is called as a toxic annular tear with so much of neurogenesis over here, a lot of toxic fluid going from here outside, irritating the dura, something called as chemical neuritis. And then outside there's at this area, there's dorsal root ganglion. Severe pain happens to the patient. Yeah, and if you see this patient is not able to raise his head, this is one of the tests, McKenzie's test. Yeah, severe pain. I just did a disc block here. We gave steroids and local anesthesia here, and patient is walking for the last 5 months. This female, again, a very tiny hyperintensity area here. Okay, not able to walk, not able to do any work. Then we found that there are 3 toxic annular tears, and then we did the steroid injections here, 3, and she started working right from the next day. Severe pain she had. immediately you can see she is able to hyperextend her spine. So this is very important. If you can find these hyper dense zones, then like this one, you can see there is a hypertrophic, almost squarish dorsal root ganglion. DRG block and disc block have not been discussed here. If you had a case, I could have shown you how to block them. One more case, I would say we put, there was a patient who had an intracanalicular screw placement, very beautifully done. Then I removed it after 11 years. And then we put a cage here, but somehow after that she had severe pain. So I did a radiculogram that you can see here. She had severe pain. If I show you this video, she was weeping overnight. I don't know, I'm seeing there, so, but she used to weep a lot. And then you can see we did a block of dorsal root ganglion. And then even in the operation theater, the very next day she started dancing. So that's the magic of disc block and a dorsal root ganglion block. Then again, I was telling about the peripheral blocks and the pseudo-unipolar, the role of pseudo-unipolar neurons, because dorsal root ganglion has one. That means both the axons, they work as the same thing. So whatever you do peripherally starts happening centrally. So if you have a patients like any patient with leg pain or disc pain, just press here, clinically here, common peroneal nerve branch or sural nerve or the posterior tibial nerve, you would have a patient will complain pain even up to neck. And if you block here with just diluted xylocaine, then patient would have magical relief. Right? This patient had a severe cervical pain which was going all the way down. I gave him injection here, and after that now it's more than 7 months patient has got no pain at all. Again, if you see this lady walking like this for 2 years, I gave her a peripheral block and she started smiling. Third patient, not working, but this patient was lying down in front of my clinic when the clinic was closed, pain going from the leg all the way up to the cervical spine. And we gave her local blocks and she is still 4 or 5 months, she is very happy. So these are very important ones. You can sort them out in your own OPD. You don't need to do anything else. And many patients will thank you for even up to 6 months. Thank you so much.
So what is the reason for having a pain right from top, that is from the head to the foot, they have pain and you block them?
Well,
what is the reason of pathophysiology?
So one thing is that there is sensitization of the sympathetic system because the involvement of the dorsal root ganglion. And we have variable like today I elicited the patient had pain, and when I pushed her here, the pain was going all the way up to elbow. It all depends upon what is the duration. So that should be one of the reason why it is there.
Called psychogenic pain. So that is the reason why pain was
Sorry?
DRG block and selective foot block are the same.
A DRG block is particularly you should do when you are seeing a toxic annular fissure right over the DRG from the disc. If it is directly releasing the chemicals over there, area is slightly different. I wish I had time in OT today, I would have explained that with the same transforaminal, you can go to the disc, you can go to the root, and you can go to the DRG. Much better results than epidural, I can tell you that. Sorry? When they come to me, they already medically managed so many times. What medical management we could do? Just painkillers. Remember, when there is a toxic annular tear, which is not discussed today, the neurogenesis keeps on happening. Right? I have another presentation which says endoscopic visualization of pain generators in spine. The nerve generation will keep on happening and the nerve endings will get thicker and thicker, meaning same tear is going to give you more and more pain with time. So there is no logic and reason why you should be conservative with them. And after all, they are just injections. What? I'm not getting you. Can someone give a mic? So there are certain diagnostic processes, like if you press, I told you the peripheral points, if you can press and patient says that there is severe pain, or if you keep the patient prone, and then, so these are called as Goretz sign and Mackenzie sign. If Mackenzie sign means when you allow the patient, you tell him to hyperextend spine while in a prone position with hands behind, and the pain goes all the way to the leg, then or the pain localizes to the spine, that's the time when you have to do these injections.
Because we see such scans almost times in our routine practice. We see such MRIs in our routine practice many times.
I have one case which I could not discuss here, that she had a problem, and again when I was in a big hospital here where they won an award for best spine department, there was this high intensity zone in the disc, and they do a screw fixation on that patient. Patient doesn't get a pain relief. Then that patient goes to, from Kenya, they came to India, they got a surgery done in Ahmedabad, they said 2 more screws are required. So from 2 levels, they go to 3 levels, patient has got the same pain. I have got a video of her, we don't have time. And I just gave her a peripheral block, and she said in 4 years for the first time I have got a pain relief. So many times we don't understand at what we are doing by neglecting such cases. Yes. Yeah, so if patient has this problem, that means already the dorsal ganglion is sensitized. And if you do that, first thing, that patient would know that this guy can treat my pain. Just like with headache. So many patients come to me who have traveled so-called 2-3 countries. And when I'm saying that is it the pain? And they say, exactly, this is my pain. I said, did anyone elicit this pain? Or did anyone recreate your headache? They say, no one did. That means that person knows that where the pain is coming from, that means I can treat. So you get a patient's trust and a short-term pain relief. If you are to do a peripheral this thing to exploit the state of being pseudo-unipolar neuron, you just do diluted xylocaine, and there are several papers on it. You can read them. Yeah. It's a magic. I have a patient's video, she's saying it's a magical injection. So
your talk on the extracranial management of headache is excellent. So I really hope that you publish your data, it will help a lot of pain management.
Definitely, we are very closely observing all these patients, it's very interesting. So my teacher, one of my teacher, he told me only this point, but I press everywhere. Okay, because it all depends upon which dermatome it is coming from, C4, C5, C6, we don't know. I have done that also, because I could see that there is a problem in the disc, and I did that. Even then patient got a relief, but more relief if patient has got this pain. But here only use Xylocard. Patient is going to hypertension.
Madam sir, we have to, because there will be many questions, I'm sure. Yeah. Sure, we'll
enrich your clinical practice, you don't even know that.
Thank you very much for the wonderful talk, and eye-opening talk, I would say. And that brings us to the end of the session. Dharma.
Thank you all the speakers for, thank you chairpersons for conducting a very successful section. Now I request the chairpersons to kindly felicitate the speakers. May I respect Dr. KVL Narsingh Rao, Dr. Navdeep Sokal to kindly felicitate the speakers. Dr. Ajay Chaudhary, please come on the stage, please. Dr. Mahendra Singh. आपका भी दे मतलब डॉक्टर बनर्जी
Dr. Banerjee. Okay. May I respect Dr. Ajay Chaudhary to kindly felicitate our chairperson, Dr. KVL Narsingh Rao. May I request Dr. Navdeep Sukal to kindly felicitate our chairperson, Dr. Ajay Chaudhary. With this, we conclude this new stimulation session. Now, coming on to last session, debate session. In this, we will be dealing about the various modalities of neuropathic pain. We have discussed all blocks and all interventions. Now, this session will be focusing only on the pharmacological aspect of management of neuropathic pain. Can you put the slides, please? वो स्लाइड्स लोड कर दो. ये वाला 01 ये ऊपर वाला ये वाला. This is a debate session in which we will be debating about the use of pregabalin versus gabapentin in the management of neuropathic pain. Before we start with the debate, we will first discuss about what is neuropathic pain. Neuropathic pain was first described in 1994 and it was defined by IASP as pain initiated or caused by primary lesion or dysfunction in the nervous system. However, the definition was felt appropriate and it was revised in 2011 in which the word somatosensory was added to this definition, and since then it is being defined as pain caused by a lesion or disease of somatosensory nervous system because of the presence of sensory symptoms in these patients. Pain associated with the it can be because of the because of the disease or injury in either the peripheral or central nervous system. And in many of the cases there is usually an absence of any stimulus. Another thing to note is that not all patients with neuropathic pain experience, not all patients with nerve damage experience neuropathic pain. These are the various terms we should know. In view of short time, I would not like to go into details of these terms. What is the difference between nociceptive pain and neuropathic pain? Nociceptive pain, usually there is a stimulus, noxious stimulus, and once the noxious stimulus is removed, the pain subsides. What are the various causes? Neuropathic pain can be because of traumatic origin, inflammatory, metabolic, autoimmune, chemotherapy induced, or the hereditary ones, or as neurologists we usually see it in cases of stroke or trauma, or in trigeminal neuralgia or glossopharyngeal neuralgia. How to make a diagnosis? Most of the cases this onset of pain is spontaneous without any stimulus, and distribution of neuropathic pain matches the degree of neural lesion. These patients may present either with the positive symptoms or negative symptoms, and as a clinician we need to demonstrate what the nerve damage or dysfunction in all patients, all these patients experiencing pain, to make the diagnosis. Diagnosis of neuropathic pain rests heavily on the demonstration of sensory abnormalities, and we need to, majority of cases we can treat only the symptom rather than the cause. This is a crux of this. This is the slide which is demonstrating the whole of this conference, and in this we will be dealing the medical management. And this special interest group on neuropathic pain are divided the various medical therapies available for management of neuropathic pain into first line, second line, and third line. These are the various options available with us. NICE guideline also recommended amitriptyline, duloxetine, gabapentin, or pregabalin as the initial treatment of neuropathic pain. The exception being trigeminal neuralgia, in which the first treatment of choice is carbamazepine and oxcarbazepine. These gabapentinoids are third line drugs for the management of this pain. Now I call upon Dr. Abhishek, who will be speaking on gabapentin. After that, I will call, because gabapentin came into the market first, pregabalin came later. That's why we will be discussing gabapentin first. Dr. Abhishek, please.
Good evening, respected delegates. Thanks for the opportunity to speak here. I'll be talking about the gabapentin in here. Management of neuropathic pain is multidimensional. It includes pharmacotherapy with TCAs, SNRIs, and calcium channel ligands, etc. Then non-pharmacotherapy and psychobehavioral. Now I'll be talking about gabapentin. It is an amino acid analog of GABA that is effective against partial seizures. It was originally conceived as a spasmolytic agent, but was later found to be more effective as an anti-seizure medication. It is primarily used in seizure disorders, management of neuropathic pain, and vasomotor symptoms. Now, talking about the potential mechanisms of gabapentin actions, the mechanism lying behind the pain relief is largely elusive. However, its action on the alpha to delta subunit of presynaptic voltage-gated calcium channels, causing inhibition of calcium currents and modulation of neurotransmitter release, is particularly thought as a mechanism causing pain relief. It also alters GABA metabolism, its non-synaptic release, or its reuptake by GABA transmitters. This effect is primarily useful in gabapentin as an anti-seizure medication. Now, the preclinical data which we have available from the laboratory studies are gabapentin does not affect nociceptive threshold. However, it is effective in reducing both allodynia and hyperalgesia in animal models. It may have a selective effect on the nociceptive process involving central sensitization. However, there is no data to support that the effect of gabapentin on spontaneous pain in animal models. Now, is gabapentin an all-purpose painkiller? The answer is unlikely. It is not like a conventional analgesic like opioids that produce analgesia by means of elevating nociceptive threshold. There is no evidence that shows gabapentin to be effective in reducing nociceptive pain. With regard to neuropathic pain, there are few studies which show a small but statistically significant reduction of global pain scores in patients with diabetic neuropathy and post-herpetic neuralgia. Non-controlled open-label clinical studies support a role of gabapentin in reducing spontaneous pain and allodynia to both thermal and mechanical stimuli, regardless of the etiology. It appears particularly helpful in reducing paroxysmal pain with lancinating and burning quality. Now, the side effect profile. The major side effects associated with gabapentin are dizziness, somnolence, confusion, and ataxia. Dizziness and somnolence, these are usually experienced by the patient during the initiation phase of the therapy. Later, they subside. There are some sporadic cases of gabapentin-induced polyneuropathy and psychomotor agitation. There was one study directly comparing the side effect profiles of gabapentin and amitriptyline, and this study failed to prove a better side effect profile for gabapentin over amitriptyline. Now, is gabapentin better than other adjuncts when in pain medications? There is only one randomized double-blinded crossover study that compared the efficacy of gabapentin and amitriptyline on diabetic neuropathic pain. There was moderate to great pain relief in 52% of the patients. Since the study was a relatively small-scale clinical trial, it failed to prove an advantageous effect of gabapentin over amitriptyline. Also, the side effect profiles of both the drugs were not much clinically different. At present, there is more data is needed to support the notion that gabapentin is a first-line treatment for neuropathic pain with a better efficacy, fewer side effects, and a favorable cost to efficiency ratio. This table was taken from the Cochrane study done in 2017 on around. This study concluded around 37 to 40 studies, and the study found that there was it on using gabapentin at a dose of more than or equal to 1800 mg per day. Compared with placebo, the gabapentin fared better in reducing post-herpetic neuralgic pain. This table was taken from the same study for peripheral diabetic neuropathy. When gabapentin was given at a dose of more than or equal to 1800 per day, gabapentin fared better than placebo in the trial. Again, study from the a table from the same study. This table shows us the adverse events and withdrawals associated with gabapentin use at a dose of 1800 to 3600 mg per day. When compared with placebo, gabapentin had more side effects. Now, the same study, a different table. This table shows that when gabapentin was used alone or in combination with morphine, it fared better than placebo in controlling all kinds of mixed neuropathic pain. Now, this table is taken from study which was published in JAMA in 2019. This was a randomized double-blinded trial of gabapentinoid versus placebo for off-label treatment of pain. The study shows that the gabapentin is particularly useful in treating back pain or radicular back pain, diabetic neuropathic pain, but it is not useful in treatment of central neuropathic pain, traumatic nerve injury pain, or acute zoster pain. So in conclusion, gabapentin is a good drug and can be used to treat neuropathic pain. Thank you.
Now coming to pregabalin, pregabalin was synthesized in USA in 1990, and both of these drugs are gabapentinoids. Mechanism of action and the site of action is nearly the same. Pregabalin doesn't bind to both of them don't bind to GABA BZD receptors, or none of them form GABA. And this is the chemical diagram of GABA, pregabalin, gabapentin. We can see that basic molecule is nearly the same. Pregabalin and gabapentin are the extensions of GABA. This has already been discussed, and the point I want to highlight in this slide is pregabalin is more potent than gabapentin, and that's why it's prescribed in lower doses. Coming to pharmacokinetics of pregabalin, it's actively absorbed from GIT. Food may delay its absorption. Bioavailability is nearly 90%, and protein binding is 0%. T-half is around 6 to 7 hours in adults, and is less in children. Time to peak is around 3.5 hours when you are fasting, and after food it's 3 hours. It is transported actively across blood-brain barrier, and it undergoes negligible metabolism in the body and eliminated unchanged in urine. Dosing, it was first approved for clinical use by FDA and European Union in 2004, and generally it is started at low doses, and gradually we have to increase. Guidelines says 25 milligram per week we have to increase, and can be increased maximum up to 300 to 600 milligram per day. In various countries have different indications for using this drug for the patients, and this is according to Australia. This can be used only for refractory neuropathic pain not controllable by other treatment, and in epilepsy. However, in India, due to lack of any legislation, there are many off-label uses for both of these drugs. Response of this drug is not immediate like paracetamol. Like you give a medicine and within half an hour you will get a relief. It's not like that. Usually the response takes time, and the response patients gradually start getting the response within the first week after starting therapy. And how we can declare there is no response, and when we can declare it, it's usually at least 8 weeks of adequate dosing of therapy before declaring no response if response to relief of pain is less than 30%. These are the definitions which are used in literature to define the benefit of the drug. Moderate benefit is labeled when at least 30% pain is relieved, and substantial benefit of the drug is labeled when at least 50% pain is relieved. Coming to adverse reactions, incidence is very low, around 3%, and the common adverse effects are respiratory depression, especially when it is taken with other CNS depressing medicines, and suicidal behavior, suicidal thoughts or behaviors is also often found adverse event with this drug. Other common drug adverse reactions seen with this drug is dizziness, drowsiness, blurred vision, fatigue, weight gain, dry mouth, headache, impaired balance, and peripheral edema. And this I already discussed. Interactions coming to the important adverse effects is dose. It's a dose dependent, and fatal respiratory depression can be seen when it's administered concomitantly with other CNS depressing medicines. Hypersensitivity reactions as seen with any other drug is possible with this drug, and visual disturbances may also be seen. Pregabalin adverse effect is very less, or you can say nearly same as placebo at doses of 150 milligram per day. Higher doses are likely to produce higher adverse events. And this we can see nearly the same effect, same adverse event of 150 milligram per day with placebo. Coming to the overdose, overdose symptoms are usually CNS related, like dizziness, agitation, delirium, or headache. And some of these patients might have ECG abnormalities or GI upset or kidney failure. Management is usually supportive, and death is unlikely because of overdose. Are there any contraindications for using these drugs? Hypersensitivity, which is there with any drug. In cases with renal impairment like CRF, we need to do some dose adjustment. And patients with substance abuse, we need to be cautious while administering such drugs. How to, when the patient has got relief for the from the disease, can we withdraw it? Yes, we can withdraw it, but we should not never stop it suddenly. It should be gradually withdrawn. Drug interactions, especially with alcohol, people who take alcohol, especially in the evening, should be and taking the night dose of this drug should be cautious about the CNS depressant effect of the dual combination. Thiazolidinones may enhance the fluid retaining effect of this pregabalin and should be given carefully. Is it safe in elderly? Yes, it is safe in elderly, though symptoms like dizziness, somnolence, peripheral edema, they are slightly more commonly seen in elderly. From this discussion we could make out there are a lot of similarities between the government in site of action, mode of action. Many things are nearly the same. But what are the differences? Differences are there in the dosing, are there in the potency. Gabapentin being slightly less potent than pregabalin. That's why gabapentin dosage is slightly more, 300, 400. Pregabalin is 75 or 150. Addiction potential of pregabalin is slightly higher because it gets absorbed quickly and gives quicker onset of action. However, FDA indications are of these two drugs are quite different, and this is again the same summary. And to this, I would like to conclude that both this pregabalin and gabapentin are quite effective in relieving neuropathic pain in various conditions. Now I request Professor Deepak Agarwal to kindly summarize and conclude about this debate session.
Good evening. I have the honor of taking the last talk of the day, and I'll keep it quick. I'm not going to summarize it because as a debate, I'm supposed to say what is against pregabalin and gabapentin, and we know as pain specialists, as neurosurgeons, we have been using pregabalin right, left and center. Every patient, we don't even write crocin or paracetamol nowadays, we first write pregabalin. And most of the time we find out the patient's already receiving it from the previous doctor. So we increase the dose. Because there is no other drug. Anything beyond pregabalin becomes actually an opioid like a morphine or a tramadol. There is nothing between them. And unfortunately, we are not very well aware of the side effects. We have been so much industry driven that we have in a way turned a blind eye to potentially fatal complications which these drugs can have. And it is not a small, I would say, kaleidoscope. It is a full array of complications which are not existing. Rajiv said there was a very low complication rate. Actually, complication rate is extremely high. Extremely high. Dizziness, almost every patient will have dizziness. We all know that. And one of the most common things, I think, which the books don't sell, we should start at a very low dose. In fact, in elderly patients which are 60 years above, you should start at 25 mg. And 25 mg pregabalin is available in the market. But we never prescribe it. It is not to be... In children, it is not indicated only because there are no studies, it is contraindicated in children. So why have they made 25 mg? It is for only this reason that you have to start at a very low dose and gradually, because elderly patients, sometimes they will go into a kind of stupor if you give this. Also, common complaint is it's like you are drunk, very high. And actually it makes you feel that. It's a dose dependent side effect. Normally what has been given in books is you can give easily up to 600 milligrams a day. That is the standard dose of pregabalin. We never give that high dose. We usually go up to 150, maximum 300 mg. But in books it is given, and people, once they get addicted to it, go up to 3000 milligrams per day. So 3000, 6000 they can take, because chances of dying is very low, as Dr. Rajiv rightly said. But the high, because patients get tolerant to the drug, so they keep taking higher and higher doses. and it gives you the same high as alcohol. Cardiac causes are very important, and especially for the large number of patients who have blood pressure, congestive heart failure, some other thing, we never take the history. Peripheral edema, which we see, we disregarded. Patients come with swollen, feet, which we can't understand. And PR interval, which is recorded, and I'll tell you why we should be doing all this. Psychiatric, obviously, as I said, psychiatric and neurological complications intermix. And when I say common, it is up to 10%. And very common means more than 10%. Immunologic complications, nobody talks about it, very common. So of infection increase, any patient you're giving pregabalin, chances of getting any kind of infection will increase dramatically. In fact, if a patient is having some infection and give pregabalin, a more chance of going to sepsis or something like that. Urinary complications, common. Ocular complication, I think Rajiv also touched upon it, but you have to understand visual field defects, very common. 10% or more will have visual field changes. Nobody knows why, but they will have changes. Common is blurry vision, abnormal vision, we consider, we don't even think about it, but patients are, this is a common complication reported. Chest complications are also been reported to be common. We are giving it for pain, but again, this is a drug which can also cause pain. One of the most feared complications, dermatological complications, angioedema is reported swelling. As I said, they can have a very innocuous like swelling in the feet, but it can progress to angioedema, which can go into something akin to anaphylactic reactions, and there have been deaths. So it is not that it's not fatal. They have been, and if you are predisposed, God forbid, if you're predisposed, we never take the history. If you're predisposed to any kind of angioedema because of any other cause, this can prove the last straw in killing you off. That is why what has been actually suggested is you should have for every patient a standard ECG to make sure what is the PR interval. You should have an eye examination, because if the visual field changes, we can never document unless you have a baseline examination. You should have a platelet count, because bleeding, as a neurosurgeon, we all are so aware that bleeding problem should be there or not there. Aspirin somebody is taking, we stop all surgeries on that patient, but we hardly bother about pregabalin, and it has been known to cause platelet dysfunction, and it should not be given in those patients in which you're thinking of getting operated. Also, it increases serum creatinine kinase because of rhabdomyolysis, and we should be monitoring that, especially in those patients which are prone to it. In fact, the complications have been so much that FDA had issued an alert some time back, and that alert in India specifically sent an alert to the government that India is one of the countries which is freely giving this drug. Most of the countries have made it, as Dr. Rajiv said, a controlled substance, a Schedule 5 drug. It's almost at the level of morphine. So imagine any country, be it US, be it UK, be it Australia, it is considered same as morphine. You cannot take it out from anywhere. And only in India it is given like Crocin or any other drug. And that is why the abuse has started. And in India, if the abuse starts, where it starts from? Punjab. So already papers are studying coming out from Punjab for pregabalin abuse. It is being sold. In fact, there was a crackdown. There was a newspaper report, there was a crackdown. They caught tons of pregabalin being supplied. Pharma companies are doing it. So it is now, it is legally available, almost like off the counter drug, and people are enjoying. It gives you the high. Why should they not take it? Taking 600 milligrams will make you like you're taking a peg of rum. Today all you will be having maybe. So quickly to conclude, see, I can tell you my experience, but doesn't want to stop it. I write, my staff and everybody says, what does Dr. Depot do? He only writes pregabalin. Because any patient with back pain, any patient, any kind, first drug you write is pregabalin. They don't understand at the back end, there is so much of things you're thinking when you're writing pregabalin, when you're stopping, how much you're writing, how much you should give. And I think this lot of quackery is also going on, because everybody knows that pregabalin will make you feel high, will make you feel euphoric, will make you feel, will obviously affect the pain. So that sense of safety profile which we should be as neurosurgeons, pain specialists, we should be aware of. That is, if we are at 50%, other people beyond our community at 0%. So that is, we should be cognizant, and we should do responsibly our duties in terms of prescription. And bottom line is the minimum possible. That is true for every drug, more so for this drug, especially because the government controls are so lax in this country. It should be the minimum possible dose and for the minimum possible period. Thank you so much.
Any questions?